Hello and welcome to the final dash by Medico. I'm Dr. Shashank Bed and today I'll be taking a live session on surgery. Now, I would like to emphasize that one day is not enough to cover surgery. Surgery is a very vast subject and I'll be trying to cover what are the most important previous year questions and previous year topics. So, let us try to do as much as we can in one day. But for full details, I would like to emphasize that please refer to the app. There are beautiful videos on the app which looks at the subject in extensive detail. So let's begin. Category 3 of Maastricht classification is, so the options are dead on arrival at hospital, awaiting cardiac arrest after withdrawal of support, cardiac arrest while brain dead, and cardiac arrest and unsuccessful resuscitation in hospital. So let us look at this table which details the modified Maastricht classification. This is taken from Bailey and Love. Now this is very easy to remember. There are no need of any mnemonics to remember this Maastricht classification. So imagine that you're an intern working in the casualty in the emergency department. So what is category 1? Category 1 is you're working in the casualty. There is a patient who comes. Now the patient, he is dead on arrival at hospital. So there is nothing that you can do for this patient. He is dead. So the location of the death is considered to be the emergency department, right? This column, whether that is a type of DCD, that is a type of donation after surgery death, I shall be discussing after I discuss all the categories. So type 1 is you are in the casualty, the patient is dead when he arrives. What is type 2? Type 2 is you are a doctor in the casualty, the patient comes and the patient is in a very poor condition. The patient suffers a cardiac arrest while he is in the casualty. You try to do a resuscitation, however, you are unsuccessful. So the patient dies and the patient dies in the emergency department. Now, what is type 3? Type 3 is again you are a doctor in the casualty. You are a patient has come who is very serious. So you try to resuscitate the patient. You have successfully resuscitated the patient, and you're going to shift the patient to ICU for further care, right? But you know in the back of your mind that as soon as you withdraw support, this patient is going to die. So if this patient dies, he is going to die in the ICU. What is category 4? Category 4 is now this patient has come to casualty in a very serious condition. You've done resuscitation, the patient has revived. However, you took a long time to resuscitate the patient, all right, or rather the patient has been, he has had cardiac arrest for more than 10 minutes. So, if he's had cardiac arrest for more than 10 minutes, that means cerebral ischemia supervenes, and even though the patient is alive, the patient is actually brain dead. So, this patient is going to go to the ICU. Whenever he dies, he's going to die in the ICU. Now, what is category 5? Category 5 is the patient has come to the casualty. You've done a very good resuscitation. You're extremely happy. You've shifted the patient to ICU, and your colleagues and your seniors and juniors, they ask you for a treat. So, you're out partying, you're giving a treat to your colleagues. And while you're giving a treat to your colleagues, you get news that the patient has died. So, that is an unexpected death. So, in this scenario, also the patient dies in the ICU. Now, what do you mean by this controlled and uncontrolled? Now, for any transplant team, they want a patient, whenever they want a patient, whenever a patient dies, they want the patient to die in a controlled manner. Why in a controlled manner? Because then they can harvest the organs, they can counsel the patient's attenders, the patient's relatives for organ transplantation. They can get their team ready for surgery. They have to prepare so many things, right? So that is why that is the difference between controlled and uncontrolled. So when the transplant team is they have a control over when the patient is going to die, or they have enough time to prepare, that is when it is called controlled. If they do not have enough time, then it becomes uncontrolled. So now in type 1, the patient is dead on arrival, so you have no time to prepare. I mean, if you're a transplant team, you have no time to prepare, so it is uncontrolled. In type 2, also you are not able to resuscitate the patient properly, successfully, so it is uncontrolled. Type 3 is you've done a resuscitation, you've shifted the patient to ICU, and you also know that the moment you withdraw support, the patient is going to die. So this becomes controlled. So in this interval, you can get the transplant team ready. They can do the needful that is required to harvest organs. Now, category 4 is also controlled because here the patient is brain dead, and so that then gives you time to get the transplant team ready. Type 5 is the type where you're going to see. So just notice that in type 1 and 2, the location of death is in the emergency department. Whenever it is in the emergency department, it is an uncontrolled type of DCD. right? Whenever the death is happening in the ICU, it is usually controlled except for one scenario. So, what is that one? That one scenario is when you are giving a treat to your colleagues and you do not expect that the patient is going to die, right? So, that is type 5. So, coming back to the question, category 3 is you are awaiting cardiac arrest after withdrawal of support. So, moving ahead, what is the investigation of choice for a blunt trauma abdomen in an unstable patient? Now, whenever a trauma patient comes to casualty, your idea is to save life and to save limb. These are the two things that are your priorities, right? Now, if you want to save limb, if you want to save life and to save limb, you want to know what are the what are the life-threatening injuries, right? So, the life-threatening injuries, supposing if it is external, if you can see a bleeding wound on the outside, then that is very easy to diagnose, as well as it may not be easy to manage, but it is at least easy to diagnose. Now, on the other hand, suppose if it is an internal injury, then time is of the essence, right? You need to know as fast as you can as to whether the patient is, what investigation is necessary and whether the patient is bleeding internally or not. So, what investigations will you do in such patients? Now, supposing if the patient is stable, if the patient is stable, then you have a lot of time. You can go for a CT scan, right? If the patient is unstable, in an unstable patient, there is no time, right? So, you start resuscitation and simultaneously you will do something called a fast scan. This fast scan, it stands for focused assessment with sonography for trauma. There's a mistake over here. It is focused assessment. This is wrong. Focused assessment with sonography for trauma. So, in this you are going to look at particular areas of the abdomen to look for hemorrhages, and if there is a hemorrhage, if you can see a hemorrhage over there, that means you have to manage accordingly. Now, this fast scan, what is special about it is it is done in the casualty itself. So, you would have seen during your internship that whenever a patient comes to casualty and you want any investigation, you have to shift the patient to the radiology room. You have to talk to the radiology PG, you have to write a requisition, you have to do all that. But as far as fast is concerned, it is done by the surgeon themselves. It is done always in the casualty. Now, supposing if in this question fast was not among the options and the option was what would you do when a hemodynamically unstable patient comes in? Supposing if one of the options was laparotomy, then you would go for laparotomy. So, laparotomy is the answer of choice when it is present. Since in this question there is no laparotomy as option, your answer is fast scan. Now, fast scan, you're going to look at the abdomen. So, you're going to look at the perisplenic area, the perihepatic area, the pelvic area. So, supposing if you want to look at the thoracic cavity also, then it becomes what is called as an E-fast scan or an extended fast scan. Now, in fast scan, there is no attempt made to determine the nature or the extent of the specific injury. So, unlike CT scan, when you will know the grades of injury, your idea is just to see whether there is any active bleeding or not. So, it is rapid, it is reproducible, it is portable, it is bedside. That is why there is no need to shift the patient. This saves time. Now, E-fast or fast, it is accurate at detecting more than 100 ml of free blood. All right. So, if there is less than 100 ml of free blood, then it may not be that accurate. But the problem with fast, since it is sonography, it is very operator dependent. So, this is a drawback of USG in general, that the investigation is very operator dependent. So, suppose if you have a sane radiologist, if you have a good radiologist, you might get an excellent report. On the other hand, if the radiologist is not that good, you will not be able to get a good report. And fast scan, mind you, is being done by a surgeon, right? So, it is not being done by radiologists. So, the quality of the report will not be as reliable as that done by a radiologist. So, it is operator dependent, and it becomes difficult when the patient is obese or if the bowel is distended with gas, right? Because then it obscures vision. So, in fast scan, you look at the right upper quadrant, that is the perihepatic area. You look at the left upper quadrant, that is the perisplenic area. You will look at the pelvis and you will look at the pericardium. So, you have the 4 P's: perihepatic, perisplenic, pelvis and the pericardium. Supposing if you look at the thorax, that is the pleura also. If you look at the pleura also, then it becomes EFAST, that is extended fast. So moving ahead, a male was brought unconscious to the hospital with external injuries. CT brain showed no midline shift. So what is this midline shift? Supposing if there is any raised intracranial pressure, that is when you will get midline shift. So the CT brain showed no midline shift, but the basal cisterns were compressed and there were multiple small hemorrhages. So what is your diagnosis? Now this multiple small hemorrhage, that means supposing if an MCQ says the words multiple small hemorrhages, this is equal to diffuse axonal injuries. All right. Now what is diffuse axonal injury? So it is a primary injury. Yes. Secondary injury is an outcome of a primary injury. So supposing say there is edema after the injury, then that is secondary brain injury. So it is seen in high energy accidents. It usually renders the patient comatose and there is very poor prognosis. Now, what is the cause of this diffuse axonal injury? So, as the name suggests, there is diffuse axonal injury, that is, there is damage to axons throughout the brain, and this damage is because of rotational acceleration and then deceleration. So, what pathology do you see in these patients? So, the axons become completely disrupted. As the name suggests, it is an axonal injury and you will get what is called axon balls. Now, you will also get, like I told you, you will get multiple small hemorrhages, right? So, where do you get these multiple small hemorrhages? You will get it in the corpus callosum and in the dorsolateral rostral brain stem. So, clinical features are the patient is comatose and one of the differential diagnosis, this is also an MCQ question, it is basilar thrombus. So, now DAI, it is a pathological diagnosis, that is, it is usually made post-mortem, right? But there are certain clues that you will see on imaging investigation, such as CT scan and MRI. So, what do you see? So, one is you will see hemorrhagic foci. Second thing is you will see a loss of gray and white matter differentiation. Now, obviously, an MRI is better than a CT scan, but MRI is not always available. So, treatment is you have to stabilize the patient, you prevent further brain damage, and you give support to the patient in whatever way you can. So, supposing if there is airway damage, you will give intubation and airway control. If the intracranial pressure is raised, then you might have to do the measures to reduce intracranial pressure, such as you elevate the head end of the bed, you might have to give mannitol, hypertonic saline, diuretics, sedatives, analgesics, antiepileptics, muscle relaxants. You might even have to insert an external ventricular drain into the lateral ventricle. So, what drugs will you give? You will give antiepileptics, that is, you will give phenytoin is the drug of choice. Now, you will it is no longer recommended to give routine corticosteroid. That is, there is no need to give corticosteroids to each and every patient. You will give it only to those patients where it is specifically indicated. Now, it is proper to ensure, since this patient is comatose, this patient will be in the hospital for quite some time, right? So, you have to give a source of nutrition. So, whenever you are giving a source of nutrition in any patient, it is always preferred to give enteral nutrition. That is, here the nutrition is going to be given to the patient via tube, that is via nasogastric tube or via nasojejunal tube, right? Since the patient is comatose, the patient cannot feed. Now, enteral nutrition is always better than total parenteral nutrition for obvious reasons. So, supposing if say if you're going to give nutrition via the total parenteral route, then what happens is there is overgrowth of bacteria in the gut, and that bacteria can then translocate and cause peritonitis. Along with that, you will also give prokinetics. Prokinetics, it has two advantages. One is it promotes absorption. The second thing is it ensures that the contents it ensures that peristalsis happens properly. That is, the contents are being pushed distally. And the prokinetics that are usually given are metoclopramide and erythromycin. Okay, the essential components of damage control surgery are all except. So let us understand this term of damage control surgery. What is this damage control surgery? So in the earlier days, that is during, or rather during war, so whenever a ship or a tank would get damaged, they would bring it, they would remove it from the battle site and they would not try to repair it completely. They would just repair it to the bare minimum so that it can function again. So this concept of damage control surgery has been borrowed from war, and the idea is you in damage control surgery, your idea is to just save life and limb. Your idea is not to do a definitive repair. You are just restricting yourself to save life and to save limb. That is a priority in damage control surgery. So what all do you need to do to save life? So initial laparotomy, yes. Why is this correct? Because say supposing say the patient has an internal bleed, then you're going to save the life by controlling the source of bleed. ICU resuscitation, yes. Definitive reconstruction, no. And arterial embolization or clamping, yes, because then this will reduce bleeding. Now, why are we not doing a definitive repair? So, the concept behind this is that when a patient is coming in a very morbid condition after trauma, already his physiological reserves are compromised. He might be in a state of shock, right? And since his physiological reserve is already compensated, supposing if you do an extensive surgery, so if you do a definitive surgery, it might take say 4 hours or 6 hours. But if you do a bare minimum surgery just to control bleeding, it will not take that much time. Now, surgery is an extra assault on the patient, right? Surgery also is also a form of trauma. So, supposing say the surgery is prolonged, then the patient may not be able to tolerate that surgery. So, even though the surgeon has done a wonderful surgery, the patient dies at the end of it, right? So, the idea is you do the bare minimum. All right, you select which patient needs these surgeries. You do the bare minimum, then you shift the patient to ICU. You allow the patient to recover his physiological reserves, and when the patient is fit, then you will again shift the patient to OT and do a definitive repair. So damage control surgery, it aims to break the vicious cycle of hypothermia, tissue hypoxia, coagulopathy and acidosis before later definitive repair. Now among these four things, acidosis, coagulopathy and hypothermia, these three together they form what is known as the triad of death. That is, when a patient has these three conditions, and when they coexist, there is a high chance of mortality. So DCS aims to save life and limb. Definitive reconstruction is done in the end. And so basically, you have to remember this one sentence: anatomy is restored. That is, you're going to do definitive reconstruction only when the physiology is optimized, right? So the principles are in sequence. What are your principles? So you will do short operations. You're not going to do long surgery. You're going to do short operations which aim to control hemorrhage and to limit contamination so that the patient does not go into sepsis. You will be doing an ongoing correction of deranged physiology. So such as that is acidosis, hypothermia, perfusion, all this you're going to do it in the ICU. Once the patient becomes fit, then you will do a definitive surgical repair. So there are it is divided into several phases, okay, to 4 phases. So in phase 1, is patient selection. So in phase 1, you are going to select which patient requires DCS, and in such patients you will do rapid sequence induction of anesthesia and intubation, right? You will do early rewarming and you will move the patient very promptly to the OT. In phase 2, you will do a immediate laparotomy, and here you will do rapid control of bleeding as well as contamination. So you might have to do a perihepatic packing, you might have to do an abdominal packing, right? And your idea is to just what is that to control bleeding, and you will close the wound temporarily. So what do you mean by temporary wound closure? So you might use something called a Bogota bag, or abdominal zipping. So in these scenarios, what you're going to do is you're going to leave the abdomen. Actually, in the app, when I've discussed the test and discussion series, I've looked into this in extensive detail. There are nice images as well. So in Bogota bag, basically, you're going to leave the abdomen open, and as the name suggests, you're going to place a bag. So the abdomen is covered not by the abdominal wall, but by a bag. So the reason why you're doing this is because of two reasons. One is that this is going to take lesser time, Secondly, you're anyways going to come, you're going to do a second surgery, right? So phase 3 is you move the patient to the ICU. In ICU, you resuscitate the patient further so that there is normalization of both biochemical as well as physiological parameters. Now, once the patient becomes optimized in the ICU, once the patient has regained their physiological reserves, then you're going to shift the patient back to the OT and you're going to do a definitive repair. So, which of the following is not a hard sign of arterial injury? This question has been asked in the recent years. It's an important question. Now, what do you mean by a hard sign and what do you mean by a soft sign? So, there are two kinds of signs. One is hard and the other is soft. So, in questions where there are just two kinds of things, so here, for example, here you have only hard and soft. There is no need to memorize both hard as well as soft. You just know the hard signs. So, whatever is remaining is by default the a soft sign. So, that is the beauty of MCQs, because here the answer is there in front of you. You just have to, I'm sorry, you just have to select the answer. So, a hard sign means it is a clear and a definitive indication that an artery has been damaged. So, when an artery has been damaged, that is when there is a hard sign, you have to do an immediate intervention, right? So, what are those hard signs? The hard signs are distal circulatory deficits, an absent or diminished pulses, bruit, expanding or pulsatile hematoma. Please note that they have not just mentioned hematoma, they've also added an adjective. The hematoma is either expanding or it is pulsatile. So, if it is expanding, it means that there is ongoing bleeding. If it is pulsatile, that means there is some connection of the hematoma with an open blood vessel, right? So, that is why the pulsations from the artery are being transmitted to the hematoma. And arterial bleeding. So, supposing say that if you know just the hard signs, then you can guess the soft signs. So, let us come back to the question. So, expanding of pulsatile hematoma, this is a hard sign. Arterial bleeding is a hard sign. Shock was not a hard sign. Bruit is also a hard sign. So, see, shock need not mean that the patient is bleeding. Shock can also be because of dehydration, right? Okay. So, moving ahead. What is Fogarty's catheter and where is it used? Now, let us say that a patient has got an acute arterial emboli or an acute thrombus, right? So in this, what happens is, so you can see over here that in this, you can see the blood vessel. This is the clot. This brown thing that you see over here, this is the clot, right? So your aim is to remove the clot. So you remove the clot by using an instrument called the Fogarty catheter. Basically, you do an arteriotomy, that is, you make an opening in the wall of the artery. You insert the Fogarty catheter. The tip of the Fogarty catheter, that is the balloon, is extended beyond the clot. The balloon is inflated, and as you withdraw the instrument, the clot is seen to be coming out. So, this is a Fogarty catheter. Let us look at the other some other things. So, this is a pulmonary catheter, also known as a Swan-Ganz catheter. The details of this is not really required, and it is also discussed in the app. So, a pulmonary artery catheter is also known as a Swan-Ganz catheter or a right heart catheter. Then you have a Foley's catheter. Foley's catheter, all of you have seen it during your internship. It is to drain the urinary bladder. So, in Foley's catheter, let me tell you a few important points. You have a bulb over here. This bulb is always inflated with distilled water, never with normal saline, never with any other, never with air. You will always use distilled water. So, Foley's catheter, let me tell you a few salient points. So, the diameter of the Foley's catheter is in FR or French. This is in contradistinction to an IV cannula, which is in gauge. So, another difference between the French and gauge is, so in French, as the number increases, the diameter increases. It is opposite in IV cannulas. So, in Foley's catheter, 3 French is equal to 1 centimeter. So, supposing say if you have the commonly used sizes are 14, 16, 18, 20. So, 14 French, that means this is going to, so 3 French is equal to 1 centimeter, right? So, that is why how you can get the diameter of this. Now, this 14, 16, 18, 20 is what is normally asked in your exams, You can remember this by the mnemonic GORI. So G is for green, O is for orange, R is for red, and Y is for yellow. Next, which of the following statements is not true? So in this question, let us discuss what is ankle brachial index. So ankle brachial pressure index, as the name suggests, it is the ratio of systolic pressure at the ankle to the systolic pressure in the ipsilateral arm. So at the ankle, you take the highest pressure. So in the ankle, you have the anterior tibial, posterior tibial, and the dorsalis pedis. So, right. So among these, you take whichever artery has the highest pressure, and you take a ratio of this to the highest brachial systolic pressure, right? That will give you the ankle brachial index. Now, the normal value of ABPI or the ankle or ABI, that is ankle brachial pressure index, is 0.9 to 1.4. Supposing if it is less than 0.9, that means that the patient has an arterial obstruction that might be in the form of, so the patient might even have claudication. Supposing if it is less than 0.4, that means the patient has chronic limb threatening ischemia. So when it is between, when it is zero 0.5 to 0.8, see 0.9 to 1.4 is normal, right? When it is 0.5 to 0.8, that means the patient has intermittent claudication. But when it is less than 0.4, the patient has chronic limb threatening ischemia. That means if there is no intervention done on an emergency basis, the patient will lose their limb. In calcification of arterial wall, or whenever there is media sclerosis, the ABPI is not 14, it is 1.4. It is more than 1.4. All right. So now let us look at the question. So ankle brachial index less than 0.5 indicates critical limb ischemia. This is true. Ankle brachial index changes during exercise and rest. Yes. So supposing you want to be sure of the ankle brachial pressure index, sometimes you can make the patient exercise and then compare that value with that at rest. If it is more than 1, it is normal. This is true. So 0.9 to 1.4 is considered normal. Smoking is more specific for peripheral vascular disease than coronary artery disease. This is wrong. Smoking is more specific for coronary artery disease. That is, for heart attacks, it is more specific rather than peripheral vascular disease. Okay, yes. So, whenever you are measuring the ankle brachial pressure index, if you retest after exercise, especially to the onset of pain, that is useful, because then that gives you a guide as to how much obstruction might be present. Supposing if the ABI, it drops to more than 20% after exercise, that means it is indicative of flow limiting arterial disease. This means that if, let us say that the ankle brachial pressure index was 1, right? After exercise it becomes 0.7 or maybe 0.6. So this drop is more than 20%. So when this drop happens, this means that there is an arterial disease which is limiting the flow. That is, it is a flow limiting arterial disease, which means that at rest the blood supply is enough, but when the patient is exercising, the blood supply is not enough. So it is indicative of ischemia. So moving on, which of the following is the best way of preventing development of DVT in post-op period? The best method of preventing DVT in a post-op period is prophylactic heparin. Now, why is this? Let us look at the the other options. So even in this question, even if you do not know the answer, you can still guess it. So let us look at the other options. So early ambulation. So is this a can early ambulation be the best way? No. Why not? Because not all patients will be able to ambulate after surgery, right? Some patients might want to rest. Some patients may not be comfortable with ambulating. Some patients cannot be ambulated. So this is not a good method. The same goes with physiotherapy. So the thing with ambulation physiotherapy, so there are some patients who are athletic, who are well built, right? So these patients will recover better after surgery. These patients can ambulate better after surgery. But supposing, say, if the patient was not that active, not that fit prior to surgery, he may not ambulate as well. Also, supposing, say, if the surgery was done in the lower limbs or in the hips, the patient can't ambulate, right? So in that scenario, prophylactic heparin is a much better. It is a rather a foolproof method. Low dose aspirin is not as good as prophylactic heparin. Another thing is low dose aspirin is it prevents clots in the arteries, whereas heparin will prevent clots in the veins, right? So, let us look at some other points of DVT. There is a scoring system which is called modified well score, and this modified well score is used as a guide to prevent DVT. What are the prophylactic methods? So, mechanical methods, you have graduated elastic compression stockings. So, in this the patient is going to wear a stocking from the toes to maybe above the knees, and the pressure is higher in the toes, it is lower as you come proximal. You can also use external pneumatic compression. So, in this image also has been asked in the previous years. So, here you can see that there is a machine over here, and this lady is wrapping some sort of device or stalks or whatever you want to call it around her lower limbs, right? And this is connected via these wires, um, which will then help to inflate this. So, it is an external pneumatic compression device. So, pharmacological methods are more effective than mechanical methods, but they have the obvious drawback that they carry an increased risk of bleeding. Now, low molecular weight heparin, what are its salient points? It is given subcutaneously. It has an OD dose, that is, it is a once daily dose. It has a lower risk of bleeding complications, that is, if you give a low molecular weight heparin, it has lower risk of bleeding complications when compared to unfractionated heparin. It is contraindicated, however, in patients with renal impairment. So, when the patient has renal impairment, in those patients you will give low dose unfractionated heparin. Now, let us say that the patient has got a DVT and the clot has embolized to the lungs. Then what do you do? So, most pulmonary emboli, they can be treated by anticoagulation and observation. That is, they do not need any intervention. Supposing if the patient has severe right heart strain, or if there is shortness of breath, right, that means it is interfering with the pulmonary artery circulation. In that scenario, you have to do a thrombolysis or a radiologically guided catheter embolectomy. That is, only in these scenarios you will be doing any intervention. So, how do you treat DVT? You will treat DVT by rapid anticoagulation. So, rapid anticoagulation is with parenteral drugs. So, again, if you give an oral drug, supposing say if you give dabigatran or something which is an oral drug, that will take some time to act, right? So, um, a parenteral drug obviously acts faster. Then you will once you have achieved rapid anticoagulation, then for maintenance you will require oral drugs. Then you can also use inferior vena cava filters and endovascular surgery. So, rapid anticoagulation is required to reduce the risk of pulmonary embolism, and in rapid anticoagulation you are going to give a treatment dose of subcutaneous low molecular weight heparin. So, a treatment dose is higher than a prophylactic dose. Please remember there are two different doses, one is a treatment dose, one is a prophylactic dose. Supposing if the patient has renal impairment, then you cannot give low molecular weight heparin. In such patients you will give unfractionated heparin. Now, supposing say the patient has a sensitivity towards heparinoids, right? Maybe the patient has a history of developing heparin-induced thrombocytopenia, that is HIT syndrome. Then in these patients, you will give another anticoagulant. So, what are your options? You might give an indirect factor 10A inhibitor, that is fondaparinux. You might give a direct thrombin inhibitor such as bivalirudin. Now, how do you maintain anticoagulation? So, you will maintain anticoagulation um, via oral anticoagulation, right? And you will give the patient oral anticoagulants for at least 3 months, and you will use novel anticoagulants such as apixaban or rivaroxaban. So, this apixaban and rivaroxaban, they are direct inhibitors of factor 10A. So, now as you can see in the drug name itself, you can see an X, you can see an A, right? So, and you can see an AN. So, AN is the antagonist, and AN stands for antagonist, and XA is the 10A inhibitor. Thrombin inhibitor. So, TR is thrombin, AN is antagonist. So, what are these inferior vena cava filters? So, patients who cannot be safely anticoagulated, right? That means if you anticoagulate the patient might have a risk of bleeding. So, in these patients, you will consider a temporary IVC filter. So what is this temporary IVC filter? So as long as there is a risk of the patient developing a thrombus in the veins, there is also a risk of the thrombus embolizing into the lungs, right? That is via the deviance, it is going to go into the inferior vena cava. From the inferior vena cava, it will go into the right heart. From the right heart, it will enter the pulmonary, that is the lungs. That will cause a pulmonary embolism. So sometimes you are not able to anticoagulate the patient. So what your idea is, okay, let the clot happen, but let me prevent the clot from reaching into the heart and the lungs. So how do you prevent the clot from reaching the heart and lungs? Here you're going to use an IVC filter. So IVC filter, you are allowing the clot to happen, but you are preventing the clot to become you're allowing the clot to happen, you're allowing the clot to embolize, but you're preventing the clot from reaching into the right heart, right? So how do you do this? You're going to use a IVC filter. Now please note that these IVC filters are always temporary, they are never a permanent solution. Why not? Because of simple reasons, right? So you cannot have an external device in the IVC for a long time, because then that filter itself will cause it will disturb the virtuous triad. You can get a clot over there itself, right? So you're going to use it only as a temporary measure. And what is the temporary duration? The duration is until the patient is safe enough to be anticoagulated or the risk of embolization has subsided, right? Now, if you want to do an intervention, you will be doing an endovascular surgery. So, what are the aims of this? Aims is, one is to restore patency, and second is to reduce the risk of chronic post-thrombotic syndrome. So, whenever there is a DVT, obviously there is a risk of the thrombus embolizing to the heart, but there is also a risk of the patient developing, that is the leg of the patient developing post-thrombotic syndrome, right? So you have to you want to prevent that as well. So this post-thrombotic syndrome, again I've discussed it extensively in the app. So what procedures do you do? So your idea is, you can either remove the thrombus. If you cannot remove the thrombus, you will think, okay, if I can't remove it, let me at least destroy it. So you will try to lyse the clot, and after doing that, you might want to keep a stent, that is, it will ensure patency. Now let us look at the grades of lymphedema. This grades of lymphedema is named after Brunner. Brunner was the doctor who gave these grades. Now there are 4 grades, but the first is a subclinical or latent grade. So you have subclinical, you have grade 1, grade 2, grade 3. Now in subclinical, as the name suggests, so subclinical means there is excess interstitial fluid and histological abnormalities in lymphatics and lymph nodes, right? So there is excess interstitial fluid, and there is an abnormality in both the lymphatics as well as the lymph nodes. However, there is no clinically apparent lymphedema, right? That is why it is called subclinical. That is, you are not able to see it. Now, after subclinical, that is, you're going to get your edema. So, in grade 1, there is edema present, but the edema is of pitting type. So, whenever it is pitting type edema, that means it is a reversible edema, right? And when does it reverse? It reverses whenever the patient is taking rest with the lower limbs elevated. So, supposing if the patient is resting at night, when the patient wakes up in the morning, there is no lymphedema or it has reduced. But as the day progresses, so during the day, the patient is walking, sitting, he's going about his daily activities, right? So that will then cause the edema to return. Now in grade 2, again the edema is progressing further. So in grade 1, like I told you, pitting is reversible edema, right? In grade 2, it is non-pitting edema. So along with being non-pitting, it does not reduce significantly upon elevation. So even after an entire night of rest, or even after using pillows under the lower limb, the edema is not decreasing, right? And you also get something called as positive stemmer sign. So what is this stemmer sign? So whenever you try to pinch the skin of the toes, so right now you can try on your own toes. Whenever you try to pinch the skin of your toes, you will find that you are able to pinch the skin of the toe. That is normal. But in grade 2 lymphedema, that is where you get a stemmer sign, you will not be able to lift the skin. You will not be able to pinch the skin. Now grade 3 is, along with being non-pitting edema, you will also get some skin changes. Now, these skin changes are irreversible. So, what are those skin changes? You will see fibrosis, you will see papillae. Now, let us continue. So, this is a very important topic, that is the segments of the liver. This is examiners love to ask this question. So, I will present it briefly in today's session. If you want to look at an extensive discussion, you will again have to refer to the app. So, uh, the question is, a surgeon excises a portion of liver to the left of the attachment of the falciform ligament. So, what are the segments that have been resected? So, now traditionally, that is earlier when they wanted to divide the liver. So, basically whenever you do a laparotomy, you can see, supposing say this is the liver, you will always see a structure on the anterior aspect which is connecting to the umbilicus and the anterabdominal wall. This is called the falciform ligament. So, traditionally they thought that whatever is to the right of it is called the right lobe, whatever is to the left of it is called the left lobe. However, this is not true. I mean, dividing it into right and left did not give any advantage to the, basically it was not of any use. You could not plan surgeries just on the basis of the falciform ligament. So, then they realized that this is not correct in relation to the blood supply by the to the liver. So, then they came up with something called the surgical segments of liver. Now, in surgical segments of liver, the liver is composed of 8 segments, right? So, why is it divided into segments? Because each segment, it has its own portal pedicle. That is, each segment has its own portal triad. This portal triad, it contains a hepatic artery, a portal vein and a bile duct, right? So, each segment has its own separate portal triad. Now, again these 8 segments, so there are 8 segments which are grouped into 4 sectors. So, you have 8 segments, right? But then they are going to form sectors. So, each sector is going to have uh, 2 segments, right? Except for one sector, except that is the medial sector of left hemiliver, it contains only one segment. So, each sector has 2 segments except for the medial sector of the left hemiliver. Now, these sectors are separated by cicerrae. What are these cicerrae? Cicerrae is basically which contains a hepatic vein. So, now since there are 4 sectors, so 4 fingers in my hand, there are 4 sectors. So, you have 3 cicerrae in between. So, you have 3 veins. So, you have the right hepatic vein, middle hepatic vein and the left hepatic vein, right? And these 4 sectors, then they are grouped into hemiliver. So, you have a right hemiliver and a left hemiliver, right? And each hemiliver contains 2 sectors. So, now let us look at the right hemiliver or the right liver first. The right hemiliver, it contains 2 sectors, and that is, it contains 4 segments. So, you have the anterior sector and the posterior sector. Anterior sector, it contains the segments 5 and 8. Anterior, so basically when you are looking at the liver, um, this is the liver, right? So, you have the right, you have the left. So, whatever you are seeing over here, this is the anterior, this is the posterior, right? Something like this. So, the anterior sector, it contains segments 5 and 8, posterior sector contains segments 6 and 7. So, how do you remember which are the numbers in these sectors? It can be very confusing, right? So, easy to remember. See, 5 plus 8 is equal to 13, and 6 plus 7 is equal to 13, right? So, each sector is going to add up to 13. So, anterior means it is in front, right? So, if it is in front, it has to have the highest number. So, it has 8, and along with 8 it will have 5 because the sum total is 13, and the remaining are there in the posterior sector. So, the anterior and posterior sectors are separated by the right scissura. This right scissura, it contains the right hepatic vein, right? Now, this right hemiliver, it is supplied by the right hepatic artery and the right branch of the portal vein, and the biliary drainage is via the right hepatic duct. Now, between the right hemiliver and the left hemiliver, you have the main scissura. This main scissura, it contains the middle hepatic vein, right? And this main scissura is also known as the Cantley's line. This Cantley's line is an imaginary line which extends from the gallbladder fossa and the main hepatic vein. the middle hepatic vein, I'm sorry. So left hemiliver, let us come to it. It contains 3 segments. So see, there are 8 segments in the liver, right? So you have 4 on the right, you have 3 on the left, and you have segment 1, which is unique. Why it is unique, we'll discuss later. So the left hemiliver, it contains 3 segments, right? So it has 2 sectors. So like I told you, there is only one sector in the liver which contains a single segment, and that is the medial sector of the left hemiliver. This contains only segment 2. Lateral segment contains segments 3 and 4. So the lateral and medial sectors, then they are separated by the left scissura. The left scissura contains the left hepatic vein, and left hemiliver, like the right hepatic liver, the left hemiliver, just like the right hemiliver, it contains all the, it is supplied by all the left-sided structures. So what are those? The left hepatic artery, the left branch of the portal vein, and biliary drainage is via the left hepatic duct. Now you have, let us come to segment 1. This is a unique segment. It is also called the caudate lobe. Why is it called the caudate lobe? Because it is the dorsal portion of the liver, right? So that is, it is in the posterior most aspect. Now why it is unique is, so you can see, if I zoom in, you can see, let me use a different color. So you can see over, this is segment 1, right? It is present posteriorly. So on the left you have segments 2, 3 and 4, right? And on the right you have 5, 6, 7, 8. This 5 and 8 form the anterior sector, 6 and 7 form the posterior sector. So when you look at the liver, basically it comes something like this, right? That is why you're going to see an anterior segment in front and a posterior segment behind you. So the caudate lobe, that is segment 1, it is the dorsal portion of the liver, and the vascular supply as well as the biliary drainage, it comes from both the left as well as the right pedicles. So coming back to the question. So the surgeon is excising a portion of the liver to the left of the attachment of the falciform ligament, right? So what is going to be removed? Now left of it is segment 2, 3 and 4, right? So your answer is D. Now supposing you had no idea about this, you were not sure, you know that there are 8 segments, but you do not know what is the correct answer. Then how do you decide it? So see, segment 1 is present in both options, so this is obviously incorrect. So these 2 options are ruled out, right? And even if you remember that there are 8 segments, so there is 4 on one side, the remaining half on the other side. So that is why this is the answer. So now let us look at some of these terms with respect to liver surgery. So if segments 5 to 8 are being removed, it is called a right hepatectomy, also known as a right hemihepatectomy. If along with 5 to 8, you are also going to remove the segment of the liver which is closest to the right hand side, that is, you are going to remove segment 4, then it is called a right lobectomy, also known as a right trisectionectomy. If you are going to remove segments 2 to 4, 2 to 4 is on the left side, right? So it is going to be called a left hepatectomy or a left hemihepatectomy. If you're going to remove 2 and 3, but you're going to leave segment 4. Segment 4 is the medial segment, right? Then it is called a, if you remove only 2 and 3, you're going to leave 4 behind. 4 is the medial part. So 2 and 3 will be called left lobectomy, only the left hand side, or it is going to be called a left lateral sectionectomy. So you're going to remove only the lateral part, the medial part is intact. Supposing if you remove 2, 3, 4, 5 and 8, then it is called an extended left hepatectomy. See, 2, 3, 4, you're already removing on the left hand side, right? Now, you're going to remove the part of the right hemiliver which is closest to the left hand side. So, closer to the left hand side, if you remember from this diagram, is segment 5 and segment 8. This is closest to the left hand side, right? So, if you include this in your excision, then it is going to be called a left trisectionectomy, right? So moving ahead. A patient came with profuse diarrhea and dehydration, reaches the OPD. For maximum flow of fluids, which cannula can be inserted? Again, this is a favorite question of examiners. They're very fond of asking the size of these IV cannula along with the color coding. So, how do you remember this color coding? So, when I was an intern, one of my seniors, they taught me a very vulgar mnemonic, which I remember to this day. So, the mnemonic is, oh God, why God, pink bra, yellow panties. So, basically, like I told, it is a vulgar mnemonic, probably which is why I'm able to remember it. So, you try to imagine a girl who's wearing a pink bra, who's wearing yellow panties. So, this is the essence of the mnemonic. Now, let us look at what these stand for. So, O, it stands for orange. God, it stands for grey. Y stands for white. Again, God stands for green. Pink is pink. B is for blue. You have yellow and you have purple. Now, some of you might ask me that this is not a useful mnemonic because there are two G's and there are two P's in this. So, then how do you, how do you remember it still? So, it is in alphabetical order. So, GRA comes first, GRE comes second. Similarly, PI and PU, this is alphabetical order. Next, let us look at the numbers. So, let us put the numbers next to it. So, orange is 14, this is 16, sorry, correct, 14, 16, 17, 18, 20, 22, 24, 26, right. Now, with IV cannula, what happens is as the number increases, so the diameter decreases, right. So, that means 26G cannula will have a smaller diameter than that of 14G cannula, right. So, if it is of a smaller diameter, then when you insert this cannula, the fluid which is whatever it is going to give, it is going to come at a lower pace, right. So, if you want maximum flow, that is coming back to the question, if you want maximum flow, then you have to give orange or gray. These are the lowest, right. So, here option has gray. So, the answer is gray. Now, let us know a few more points. So, whenever a patient comes to casualty with shock, right, as an intern, you would have been taught that you always have to put green or lower, never higher than green, right. So, whenever a patient comes to casualty with shock, your cannula of choice by default is a green cannula. You can obviously you can put an orange, gray or white also, but the thing is that these cannulas, it is slightly thicker, so it is difficult to cannulate. So, you might during your internship, many of you might have done this, that when you're trying to learn cannulation for the first time in an adult patient, you might put blue and you're very happy that you put blue cannula. But that is wrong practice, because remember it this way: B for blue and B for bacha. So, blue is always used in kids, right. In surgery, that is in shock, you're going to use green. So, where do you use pink? So, in elective patients, supposing a patient is being admitted with gallbladder stones and I want to do a lap cholecystectomy for him, it is an elective case, it is a planned case, I am going to use a pink cannula. So, for elective cases and in your medicine wards, you will be using pink cannula, right. So, here you would have noticed that it is up to 26G. Now, let me tell you two more important points. What is the importance of 23G? What is the importance of 27G? Now, 23G is the size which is used for FNAC, and 27G is used for spinal anesthesia. This 27G needle, it is also called a 2He needle. Okay, so moving on. During surgical exploration for hydatid cyst of the liver, any of the following agents can be used as a scolicidal agent except. So, what are these scolicidal agents that are used? So, you will use hypertonic sodium chloride. Yes, formalin is not used. You can use cetrimide. Cetrimide is nothing but Savlon. You can also use povidone iodine. Now, let us look at the treatment of this hydatid cyst in some amount of detail. Supposing if say this cyst is asymptomatic or if it is inactive, you can leave it alone. You just monitor its size by USG. Supposing if this cyst is active, then you first treat it with a full course of albendazole or praziquantel, right? And after giving a full course of drugs, then you will go for surgery. So when you do operate, what are your surgical options that are available? So first we have something called PAIR. This PAIR, it stands for puncture, aspiration, injection, reaspiration. Basically what this means is you've done a laparotomy. I mean, you've gained access to liver. You've either by a laparoscopy. Okay, we'll take a technical break here, and after the break, I'll resume discussion of this. So let us resume. We were discussing the treatment of hydatid cyst. So when you look at the surgical options, you have various options. The first one of which is PAIR. So now what does this PAIR mean and what does it stand for? PAIR stands for puncture, aspiration, injection, reaspiration. That means once you've gained access to the hydatid cyst, how do you gain access? Either via laparotomy or via laparoscopy. So you can visualize the hydatid cyst, right? Once you visualize it, you puncture the hydatid cyst, you aspirate its contents, you inject something into it and you re-aspirate. So after puncture and aspiration of contents, what do you inject? You will inject a scolicidal agent. Now examiners are very fond of asking what these scolicidal agents are. So you have a hypertonic saline. Hypertonic saline means it is 15 to 20%. Normal saline is 0.9% NaCl, right? Hypertonic saline is 15 to 20%. Then you have absolute alcohol, that is 100% alcohol or maybe more than 95% alcohol. Povidone iodine, which is 5 to 10%. 0.5% cetrimide with 0.05% chlorhexidine. So if you recall the options in the equation, formalin is not used. So now after you inject the scoricidal agent, you will then re-aspirate the content. So what is the idea? You first puncture the cyst, you aspirate whatever you can, all the fluid, then you will inject a scoricidal agent. Why don't you inject a scoricidal agent immediately after puncturing? This is because if you inject a scoricidal agent immediately after puncturing, there is a risk of spillage. And if there is a risk of spillage of hydrated cyst contents, that spillage, it can cause anaphylaxis, right? So you will puncture, you will aspirate, you will inject, you will kill these scoliosis, and then you will again re-aspirate, right? Now, before pair is done, it must be ensured that the hydrated cyst does not communicate with the biliary tree. Why is that? Why is that necessary? Because if it communicates with the biliary tree, that means whatever scoricidal agent you are going to be injecting, it is going to enter the liver via the biliary tree. It will cause some amount of chemical damage to the liver, right? So, how do you know whether the cyst is communicating with the biliary tree or not? That is, preoperatively, you will be doing a scan. Now, what happens if you accidentally inject this scoricidal agent into the biliary tree? It can cause sclerosing cholangitis. So, this is also a MCQ point. Now, there is something called pericystectomy with omentoplasty. So, supposing say if the lesion is in the peripheral part of the liver, then what do? You just want to, like, we surgeons are very fond of removing or excising things, right? So, if it is in the central part of the liver, it is not possible. But if it is in the peripheral part, then I will just do a pericystectomy. So, why is it a pericystectomy? Again, because I do not want to damage the cyst, right? So, I will do a pericystectomy, and whatever defect is there in the liver, I will plug it with omentum. So omentoplasty basically it means I'm going to put a part of the omentum into that defect which I have created. So omentum is the abdomen, is the policeman of the abdomen, right? Whenever there is any problem in the abdomen, the omentum goes over there. So even in perforation, a perforation is naturally sealed by omentum. Next, hepatic segmentomy. Supposing say if I am not able to remove the cyst, let me just remove the liver only. So I'm throwing the baby out along with the bathwater. Then laparoscopic marsupialization of the cyst. So basically I'm just going to de-roof the cyst. So I de-roof the cyst, I remove the cyst which contains the endocyst along with the daughter cysts. So the idea behind it is that if you just remove the contents, that is enough. So moving on. All of the following are true about fibrolamellar carcinoma of the liver except. So again, this is a very important topic. I've looked at, I've discussed hepatocellular carcinoma in detail in both the test and discussion, as well as you will find it in the app where sir is discussing this in detail. So here I've just taken the most important points, questions from liver in today's final dash. So now there is one variant of hepatocellular carcinoma which is called fibrolamellar HCC. This fibrolamellar HCC, it is different in many ways to a standard hepatocellular carcinoma, right? And it is where it is from these differences that these questions are usually asked. So let us look at this table from Sabiston. Now, hepatocellular carcinoma is way more common in males than females, right? Fibrolamellar carcinoma, actually the ratio is equal. So if you see, it is 1:1. So it is present equally in both males and females. But when you compare fibrolamellar HCC to HCC, it means that this fibrolamellar HCC is more common in females, right? That is why the ratio is 1:1. So F for fibrolamellar, F for females. Then the median age of HCC, it is 55 years. Of FHCC, it is 25 years. So FHCC occurs in younger age group. Then because it is occurring in a younger age group, we are assuming it is of better prognosis, right? So it is well circumscribed. It is 50 to 75%. You can easily remove it. And it causes lesser damage to the liver when compared to the standard HCC. So it is cirrhosis chances is lesser. AFP, that is alpha fetoprotein, which is the tumor marker of HCC, it is not that commonly seen over here, and it is not associated with hepatitis B. So basically, fibrolamellar HCC is a very well behaved young female. So, it is what are the following are true except more common in females, this is true. Better prognosis than HCC, obviously, right? If it is well circumscribed, if it is for a younger age group, then it is going to be easily resectable as well. So, it is going to have better prognosis. Also, in hepatocellular carcinoma, it is also with hepatitis B. Now, the problem with hepatitis B is, so the rest of the liver is also cirrhosed and part of it has turned into malignancy. So, the functional hepatic reserve is low. Whereas in a fibrolamellar HCC, it is only that part of the liver which has a tumor, right? So, it has a better prognosis. Now, AFP levels always more than 1000 picograms per ml. Now, this is false. Now, the last option occurs in young adult, this is true. Now, I want you to pay attention to this word always. So, I am very fond of telling this that always, whenever you see this in a MCQ, there's a thumb rule. Always is always incorrect and never is never correct. So, barring a few exceptions, whenever you see the words always and never in an MCQ, you will know that that is the answer. You can, supposing if you want to take a wild guess, this is usually safe, not always, but usually it is safe. So, moving on, which of the following is not an indication for cholecystectomy? So, let us look at the indications for cholecystectomy. Now, cholecystectomy is one of the most commonly performed surgeries in today's surgical practice. It has become as common or maybe even more common than hernia in some parts of India. So, now not all gallstones require intervention, right? So, supposing if it is an asymptomatic gallstone, it does not require intervention. So, what do you mean by an asymptomatic gallstone? That means the patient has undergone a scan for a different reason. He might have undergone a routine scan or he might have undergone a scan for a different reason, and during the scan it has come to his knowledge that he has gallstones. That is asymptomatic. But you might have to do prophylactic cholecystectomy either via an open route or via laparoscopic route for asymptomatic cholelithiasis in some situations. So, now what are those? So, if it is large stone, large means it is more than 3 centimeter, because these stones are then associated with cancer. If there is choledocholithiasis, that means there is a stone in the common bile duct. So, that means that means there is a high chance that the stone is forming in the gallbladder. So, this is the right hepatic duct, left hepatic duct, common hepatic duct, cystic duct joins to form the common bile duct. This joins the main pancreatic duct to form the ampulla of Vater. So, this is the left hepatic duct, right hepatic duct, common hepatic duct, the cystic duct, common bile duct, main pancreatic duct. This is the ampulla of Vater, right? In this cystic duct, you have the gallbladder over here. Now, in choledocholithiasis, you have a stone in the common bile duct, right? Now, supposing if you just remove this stone from the common bile duct, there is a high chance that the stone has come from the gallbladder, right? So, you will want to remove the gallbladder along with, you will want to remove the gallbladder as well, even if it has no stones, or even if the stone is not causing any problems, because then that stone is going to go into the CBT, right? So, choledocholithiasis, then chronic hemolytic conditions. So, a patient who has sickle cell anemia or hereditary spherocytosis, you will do a cholecystectomy. If there is a gallbladder polyp of more than 1 centimeter in diameter, higher the size of the polyp, that is greater the diameter, greater the risk of malignancy. Supposing if there is a suspicion or risk of malignancy, that means if there is an anomalous pancreatic ductal drainage, right? So, the main pancreatic duct, instead of this normal anatomy that you see over here, it is going to drain into the CBD. Then it can cause malignancy, right? So, then in that scenario, you will do a cholecystectomy. Then in a post-Lien gallbladder, what does post-Lien gallbladder means? It means that the wall has become calcified. Then in some ethnic groups, or that is patients who live, so in India it is basically North India, that is in the Gangetic belt, there is a higher risk of gallstones, and these gallstones have a higher risk of developing into gallbladder cancer. So in these patients, it is justified if you do a cholecystectomy even when the patient is asymptomatic. Next is transplant patients. So during the transplant procedure itself, you remove the gallbladder, Then bariatric surgery. Then for patients with symptomatic gallstones, cholecystectomy is a treatment of choice if there are no medical contraindications. So all these indications that we discussed earlier were of asymptomatic gallstones. But if the patient is symptomatic, you will do a cholecystectomy always. No questions asked unless and until the patient is not fit for surgery. Okay, a 40-year-old woman has undergone a cholecystectomy, right? Now, once you do cholecystectomy, you're going to then send the specimen for biopsy. Histopathology reveals that the patient has a 3 centimeter adenocarcinoma in the body of the gallbladder, which infiltrates up to the serosa. So, what further management will you advise? So, when you look at the management of gallbladder cancer, there are two separate categories. One is when you're doing you do not suspect that the patient has gallbladder cancer prior to the surgery. You do the surgery, say for gallbladder stone. Once you send the specimen for biopsy, it comes out as gallbladder cancer. That is what has happened in this patient in this question. Second is the patient has the symptoms of gallbladder cancer, and then your management changes. So when there is gallbladder cancer, it is done in a planned way. That is a separate topic. Here we are looking at what is CA gallbladder when it is detected incidentally. So now let us look at the layers of gallbladder. You have the mucosa. Okay, before that, let us look at the layers of GIT. In GIT, you have mucosa, submucosa, muscularis propria, and serosa. Right. In gallbladder, the submucous is not well developed. So you're going to have the mucosa, then you're going to have a layer of loose connective tissue, muscularis propria, and then the serosa. Okay. So let us move on to this question. So now, okay, supposing say if the gallbladder cancer is only in the mucosa, right, then there's nothing else to be done. You tell the patient no problem, it has not invaded. Supposing if it is invading beyond the mucosa, then you will do an additional intervention. So what is that intervention and why is it important? So as the depth of the tumor increases, so supposing say if it infiltrates the muscularis propria or the serosa or the connective tissue, the risk of lymphatic invasion is higher. That is why you have to do an extra intervention along with removing the gallbladder. So what intervention do you do? So an incidental gallbladder cancer is diagnosed following HPE, that is histopathological examination of gallbladder, after it has been removed for presumed benign disease, that is for presumed gallstones. So supposing say if the patient has an early stage disease. So what do you mean by this early stage disease? Early stage disease means it is confined to the mucosa of the gallbladder, okay, and it has a negative cystic duct margin. So what do you mean by this negative? Where has the cystic duct come from? So see, this is the gallbladder, this is the cystic duct, this is the common hepatic and the common bile duct. So now when you're doing a cholecystectomy, usually you will place two clips distally, one clip proximally, and you cut it over here. So when you excise the gallbladder, you're not only removing the gallbladder, you're also removing a part of the cystic duct, correct? So supposing if this cystic duct, that is this portion, right, where you have cut, supposing it is on this side of the line, that is this part. 1 minute. It is this portion. Supposing if that comes out to be malignant, then that means you have to give some other form of treatment. But if this cystic duct margin is negative, no need to worry. So here you will give no further treatment. On the other hand, supposing if say it is a transmural disease or if the cystic duct margin is positive, then what will you do? You will do radical en bloc resection of the gallbladder fossa, all right, and surrounding wedge of liver. Since so now the which segment of the liver is the gallbladder draining into, that is segment 4B, right. So along with removing the gallbladder, you will want to remove a wedge of the liver, that is surrounding the gallbladder fossa. Whatever liver tissue is there, you will remove it. You will also remove the regional lymph nodes, right. So you will be doing a radical resection. So you have to take the patient back to OT. Now, when I was preparing for NEET PG and this MCQ was asked in the exam, it would always be the exam is always fond of telling that you have to excise the port sites. But in today that when I've become a surgeon, that is no longer recommended. So now instead of removing the port sites routinely, you examine the laparoscopic port sites. Fine. And only so there is no need for routine resection. If only the I mean, what is it saying? Yeah, so if the port site is involved, only then will you do an intervention. But that is, you will want to excise the skin over there. But you have to bear in mind that if the port site is involved, then that means it has spread across the peritoneum. So it has very poor prognosis. So finding of disease at port sites is a sign of generalized peritoneal disease and carries a very poor prognosis, right? And so supposing if you cannot do if you cannot operate on the patient, what treatment will you give? Along with palliative care, you will also give chemotherapy, right? In fact, even after doing a revised surgery, you will still be giving chemotherapy to the patient. That is, you will be giving adjuvant oral chemotherapy. So, what is that adjuvant oral chemotherapy? You will be giving capecitabine plus minus gemcitabine or oxaliplatin. So, capecitabine is definitely given, and along with capecitabine, you will give either gemcitabine or oxaliplatin. So now what happens if it is okay? Let me discuss the previous part. So in a planned case, I just want to discuss. See, the entire topic of gallbladder cancer is again in the app. Sir has discussed it in his classes, as well as I have discussed it in the test and discussion videos. In this question, I have chosen to discuss only the treatment part. Now, supposing it is a planned case, so it is a pre-op diagnosis, then how do you go about it? So now most of these patients, when they present, they have advanced disease, right? And they have a low performance score. They are not candidates for surgical therapy. So even if you want to operate, before you do a definitive surgery, you will first do a diagnostic laparoscopy, right? When you do a diagnostic laparoscopy, you do it before doing a formal laparotomy, because when you do a diagnostic laparoscopy, supposing if there is meds which are not picked up on imaging, that meds is going to prevent you from doing an extensive surgery, right? So if there are meds present, you abandon the procedure. You tell the patient that, look, there are meds, we cannot operate. So a staging laparoscopy or a diagnostic laparoscopy is mandatory prior to doing a formal laparotomy. Now, so this patient has a pre-op. So let us look at this part. So basically, the patient you've identified gallbladder cancer prior to the surgery. You've done a diagnostic laparoscopy. There are no contraindications to resection. Then you decide to do a formal laparotomy. So when you do this, what all are you going to resect or remove? Surgeons are very fond of removing things. So you will do a radical en bloc resection. This en bloc resection, it includes the gallbladder. Then wedge hepatectomy. Wedge hepatectomy means 2 centimeters of liver in the gallbladder bed, or segments 4, 4B to be specific, and 5 if there is concomitant liver infiltration, or extended hepatectomy, and bile duct resection if the bile duct involved or the if the bile duct is involved or the cystic duct margin is positive. So intraoperatively, how do you know whether the margin is positive or not? You send for a frozen section. Along with this, you will be considering a regional lymphadenectomy, even if you do not do it. So what if you want to do a regional lymphadenectomy? What lymph nodes do you remove? You will remove the parachoredocal lymph nodes, portal lymph nodes, along with the right hepatic artery and the retroduodenal nodes. So your idea is to remove the tumor entirely and to achieve negative histopathological margins. Okay, now supposing if the patient has advanced disease, then what do you do? That means in these patients, it is not possible to operate the patient. Then what do you do? So you will give palliative therapy. Palliative therapy basically it means you're going to give symptomatic treatment. Now the patient might have obstructive jaundice, right? So obstructive jaundice is relieved by endoscopic or percutaneous method. So what is this endoscopic method? Endoscopic method is basically you're going to do a biliary stenting. And for stenting in a malignant, so there are two kinds of stents, plastic and metallic. For a malignant disease, you will be doing a metallic stenting. So where do you do a plastic stent? Plastic stent is done in benign pathology. For example, if there is jaundice due to stones, there you will use a plastic stent. Percutaneous methods is you're going to do a you're going to do a, you're going to make an opening in the gallbladder and you're going to drain the contents of the gallbladder, right? Okay, next, let us look at the topic of Charcot's triad. So, Charcot's triad is seen in cholangitis. It is seen in cholangitis and it has three components. What are those three components? It has, so clinical jaundice, the patient has fever and there is pain in the right upper quadrant. So now this will also be seen in hepatitis, right? In hepatitis also the patient has pain in the right upper quadrant, there is clinical jaundice and the patient might have fever. But but um, Charcot triad is specific to cholangitis. Now why is this important? So see, in hepatitis fever may or may not be present, but if there is high grade fever, then that is seen usually in Charcot's triad in ascending cholangitis. Now why is the Charcot's triad important? Because you want to identify Charcot's triad because it is a potentially life-threatening emergency. So whenever there is infection of the biliary tree, that is you see fever. Fever is indicative of infection. That means um, the patient has a high mortality, right? The patient has a higher chance of malignancy. Now you want to prevent this Charcot's triad from progressing into Reynolds pentad. So what is this Reynolds pentad? So Reynolds pentad equals Charcot's triad plus shock plus mental changes. So Reynolds pentad equals Charcot's triad plus shock plus mental. Why is this mental changes happening? Maybe because of hepatic encephalopathy. So when Reynolds pentad occurs, Reynolds pentad has a mortality of almost 100% without prompt treatment, right? This is the importance of Charcot's triad because when you get Charcot's triad, it is a treatable condition. And it is serious, but it is not life threatening. But it can progress to a life threatening condition. So moving ahead, which of the following is most diagnostic investigation for acute pancreatitis? So actually, in today's final dash, since surgery is a very vast subject and it is impossible to cover it in a single day, I have taken one or two questions from each chapter. These are usually the questions which are either previously year questions or previous year, both PYQs as well as PYTs, and topics which I think are trending topics and which can be asked in your NEET PG. But again, for all these questions, since I'm not able to discuss the entire thing, if you want to know the entire topic, please look at the app, because in the app you have both sir's discussion where he is looking at the topic subject in detail. You also have test and discussion where I'm discussing MCQs in way more detail than right now. So, which of the following is most diagnostic investigation for acute pancreatitis? So, for pancreatitis, the most diagnostic investigation is always serum lipase. So, now usually in pancreatitis, two enzymes are raised, right? Amylase and lipase. When the patient comes to casualty, you will send for these two enzymes, amylase and lipase. Among these two, lipase is more diagnostic. Why? Because lipase has a longer half-life, so it is going to stay elevated for a longer periods. Also, there are many other causes of hyperamylesemia, but lipase is more specific. So let us look at the investigations of pancreatitis. So elevated amylase, elevated lipase, this is usually 3 to 5 times above normal. Then imaging. When you do an X-ray of the chest and abdomen, see, these are not diagnostic, but but you should get an X-ray abdomen done because it will rule out the differential diagnosis. So see, all the surgical condition of liver which require an emergency, it can be more or less picked up on X-ray. For example, perforation can be picked up on X-ray. Bowel obstruction can be picked up on X-ray. Appendicitis cannot be picked up, which is also a common emergency. But you have to always do an X-ray abdomen in surgery casualty because to rule out the other emergencies. So, for example, in pancreatitis, a patient has upper abdominal pain, right? Now you want to rule out perforation, so you will be doing an X-ray just to rule out the differential diagnosis. Now, supposing if you do an X-ray and the patient does indeed have pancreatitis, what findings will you see? So you will see a few non-specific findings. Now, what are those? So you will see sentinel loop. you will see colon cutoff sign, you will see renal halo sign. So basically, the pancreas is present in the gastric bed, right? So anterior to the pancreas, you have the stomach. You also have the, it is also related to the transverse colon. So whenever there is pancreatitis, there will be a peripancreatic fluid collection. That peripancreatic fluid collection, along with the inflammation of the pancreas, it can cause localized ileus. So whenever there is localized ileus, that is when you will get colon cutoff sign or sentinel loop sign. Occasionally, you might see calcified gallstones or you might see pancreatic calcifications. Now, the most common cause of acute pancreatitis is gallstones, right? So, whenever a gallstone slips and it gets lodged in the ampulla or water, it can cause upstream dilatation, upstream block. It can cause pancreatitis. So, if the gallstone has enough calcium, it is radio opaque and it can be seen on X-ray, right? The most common cause of chronic pancreatitis is alcohol. Now, chest X-ray may also show a pleural effusion, right? And in severe cases, it might also show a diffuse alveolar interstitial shadowing. So this is indicative of, or in these patients, they might be, it is suggestive of rather acute respiratory distress syndrome. Next, you will do a USG. Now, see, there is a rule in when you have to memorize the investigations, you need to remember that an organ which is present on the surface, it is nearer to the skin. If it is nearer to the skin, that means when the radiologist does a USG, they're going to put a probe on the skin, right? So when they put a probe, the nearer the organ of interest is to the probe, the better reports you're going to get. Now, since the pancreas is posterior to the stomach, so there's an entire stomach and maybe the colon also, maybe ileum also, which is present over there, and they are full of contents. It is difficult to diagnose pancreatitis on an USG, right? So, for all retroperitoneal organs, for example, pancreas, adrenal glands, or kidneys, a CT scan is much better than a USG. So, say, even though a USG is not that useful, why do you still do it? Because it detects gallstones as a potential cause. Also, it rules out acute cholecystitis as a differential diagnosis, right? USG is also good for the CBD. It will tell you whether the CBD is dilated or not. So, CT scan is the imaging investigation of choice, and you will do it whenever there is diagnostic uncertainty in patients with severe acute pancreatitis because you want to distinguish it from necrotizing pancreatitis. Then, when you do a CT scan, you get something called a CT severity index or the Balthazar criteria. This helps to stage the severity of pancreatitis. So, also it is indicated in patients who have organ failure, signs of sepsis or progressive clinical deterioration, and when you suspect a localized complication secondary to the pancreatitis. For example, if there is a fluid collection or there is a pseudocyst or there is a pseudoaneurysm. So, MRI can also be used, and MRI it will give you similar information to a CT scan. MRCP is used for evaluating the biliary tree, right? So it can not only assess the presence of stone in the CBT, it will also give you information about the pancreatic parenchyma. Now, ERCP, in today's world, ERCP is no longer used for, it is very rarely, should not say no longer, it is very rarely used for diagnosis because MRCP is available, right? So ERCP is usually therapeutic. So it is diagnostic as well as therapeutic. In today's world, it is more therapeutic. How is it therapeutic? Supposing there is a stone lodged in the CBD or in the ampulla of which is causing pancreatitis, it can remove that stone. Okay, now let us move on to the topic of cystic lesions, cystic neoplasms of the pancreas. So this is again a very important topic. So which of the following is not true about mucinous cyst adenoma of the pancreas? So now there is a very beautiful table taken from Sabiston. I hope my screen is not zoomed out. I hope you can see this. Is the screen? Yeah, this is perfect. Okay, one moment. We'll just take a break. We'll come back. Okay, I'm sorry. When I zoom in, actually, it is not seen properly. So I had to zoom out. That is why we had to take a break. So when we compare the cysts of cystic lesions of the pancreas, when there are the common cysts are, you have a pseudocyst of the pancreas, there is a serous cystic neoplasm, mucinous cystic neoplasm, and an intraductal papillary neoplasm, right? So how do you compare these two? So let us first look at the gender. So pseudocyst is seen commonly in both females and males. It is equal in males as well as females. Serous cystic and the serous cystic is more common in females. So is mucinous, right? But mucinous is the most common in females when compared to the others. IPMN on the other hand is equal in both females as well as males. Next, when you look at the location, so a pseudocyst of the pancreas is evenly distributed. So serous, so in Hindi or in Sanskrit, sira is head, right? So sir is head, so it is more common in the head. The answer is not evenly distributed, the answer is head. Mucinous, now mucinous is more common in females. Females, now I have a very dirty mind and sometimes it helps me remember some topics. So mucinous is more common in females, right? Females have a good body, a good tail. So mucinous is more common in the body as well as tail. And IPMN, that is an intraductal papillary mucinous neoplasm on the other hand, is more common in the head. Now what is the appearance? So pseudocyst, when you look at it, it is usually round. It is a thick walled large cyst. Since it is large, it is going to cause pressure atrophy or pressure necrosis of the pancreatic gland, and you will also see calcification. Now S for serous, S for small. So in serous cystic neoplasm, you will see multiple small cysts which are separated by internal septations. Again, S for septation. Along with this, you will see a central starburst calcification, right? So S for small, S for septation, S for star, there is a central stellate scar, and S for serous. Mucinous, on the other hand, it is thick walled. It is, you will see macrocysts, right? As far as it is more common in females, you will see bigger cysts, um, and there is eggshell calcifications, right? Okay. Now, does it communicate with ducts? So, pseudocyst communicates with ducts. Pseudocyst is because of, so basically, whenever there is acute pancreatitis, there is peripancreatic fluid collection, right? And that fluid, it leaks from the ducts. So, it communicates with the ducts. Serous and mucinous do not communicate with the ducts. IPMN communicates. Now, supposing if you take the fluid from the cyst and you want to analyze it, what do you see? Since pseudocyst is a complication of pancreatitis, you will see inflammatory cells. In serous, S for sugar. So sugar, glycogen. So you will see glycogen-rich cells which with positive periodic acid Skiff stain, right? On the other hand, in MCN, you will see clusters of columnar mucin-containing cells. Okay. So mucin stain is positive in MCN as the name suggests, as well as in IPMN. Amylase is very high in pseudocyst and high in IPMN. CEA is low in pseudocyst as well as SCCN, but high in MCN. Okay, so here I have compiled which part of the pancreas what lesion is seen. So pseudopancreatic cyst is most common. It is seen throughout the substance of the pancreas, but it is most common in the body and tail, and to be specific, in the lesser sac. Insulinoma is equal distribution. Vipoma is tail of pancreas. Glucagonoma is in the body and tail of pancreas. Somatostatinoma is head. Ductal adenocarcinoma is in the head. Serous is in the head. IPMN is in the head and ancillary process. Blunt trauma is more common in the body and neck. Mucinous is in the body. To add over here, okay. What is the commonest site of accessory spleen? Now, accessory spleen is also called splenunculi. So, splenunculi are nothing but single or multiple accessory spleens. So, what is this meaning of accessory spleen? Now supposing if we're going to do a splenectomy for say hereditary spherocytosis, right? So your idea is to remove the spleen in entirety. So you've removed the spleen, but post-op you realize that the patient is not recovering as you have expected the patient to recover. So this is because there are accessory spleens present in other parts of the abdomen as well, and then that undergoes hypertrophy. It undergoes compensation. So see, when you do nephrectomy on one side, there is compensatory hypertrophy of the other remaining side, right? Similarly, in spleen, when you remove the entire spleen, the big gigantic spleen, but supposing, say, if you have not removed the accessory spleens, and it is actually not possible to remove the accessory spleens also, because see, when you do a laparotomy, sometimes you can see it, sometimes you cannot see it. So the ones that you cannot see are the ones which are very small. Those then undergo compensatory hypertrophy after splenectomy, right? And that will give rise to residual symptoms. So commonest site of accessory spleen is in the hilum of the spleen. So the other locations are gastrosplenic ligament, tail of pancreas, splenocolic, these. But what you need to remember is most common is near the hilum of the spleen. Okay, so now how do you localize these accessory spleens? You can use a scan. So you can use a technetium scan. So technetium 99M scintigraphy. This can um, identify these accessory spleens, right? Now, what is the commonest type of tracheoesophageal fistula? So tracheoesophageal fistula, it is of 5 types. So in type 1, you can see over here that the proximal end of the esophagus is blind. The distal end is also blind. In type 2, the uh, the proximal end is attached to the there is a connection between the proximal blind end to the trachea. Distal end is blind. In type 3, the upper end is blind, but the lower end, it is connected to the trachea. This is the most common type. That is, type 3 is the most common type. In type 4, both the upper as well as the lower end, they are connected to the trachea. In type 5, it is basically an H-shaped fistula. So here the trachea is in, the esophagus is in continuity, but there is one fistulous tract connecting it to the trachea. So the commonest type of tracheal fistula is type 3. In type 3, basically the proximal end is blind and the distal end is communicating with the trachea. This is type 3. So congenital esophageal atresia or tracheoesophageal fistula is an important condition because see, if the esophageal tube is blind, that means whatever the baby feeds, the baby is not receiving nutrition, right? So the baby is going to die. So you have to identify it, recognize it, and correct it as soon as possible, because that is the only hope of survival. So I have discussed the 5 types. What are the ways in which you treat it? So basically you will place, okay, before that, what is one clinical feature of it is, whenever you give the patient, whenever you give the baby feeds, the baby vomits it out. Suppose if you try to insert a Ryle's tube, the Ryle's tube does not pass, right? This is how you identify it. So how do you treat it? You can use a nasal tube or a oral sump repogal tube. This repogal tube is placed to drain saliva. Why do you need to drain saliva? Because you want to prevent aspiration, right? Next, positive airway pressure, that is in the form of ventilation, that is avoided, because whatever air is passing through the fistula, it can cause gastric distension, right? If it causes gastric distension, then that will further, if the stomach becomes big, it will cause pressure on the lungs. So it will further compromise ventilation. Also, as the stomach distends, it can also get perforated. Now, supposing if pressure support is indeed needed, perhaps maybe because of respiratory distress syndrome, right? Then you have to do a prompt ligation of the fistula. So until you ligate the fistula, you should not give ventilatory support. So what is the treatment? Type A and B, they have a long gap, right? So these ends, they do not meet and they usually require esophageal replacement. So you require maybe colonic or jejunal or gastric transposition, and that will then act as to bridge the gap. Sometimes you can also do progressive traction. You can make the ends meet and you can do a delayed anastomosis. In type C and D, So in type C and D, in type C, if you recall, it is the most common type, and it is where the lower end of the esophagus that is connecting to the trachea, right? So in this, you get access to it via a thoracotomy because it is connected to the trachea, or you can also do a thoracoscopy. That is, you can do a minimally invasive surgery, and you supposing if the neonate is stable, then you can fashion an anastomosis over a transanastomotic tube, right? But supposing if the primary anastomosis is not possible, then you will do a delayed anastomosis. In type E, it is usually found in the neck. So since it is in the neck, it can be repaired easily. Now, what is the best test to diagnose gastroesophageal reflux disease and to quantify acid output? So, if you want to diagnose GERD, you need to have objective evidence that there is indeed contents of the stomach which is coming into the esophagus, right? That means there is either acidic content or biliary content. So just symptoms is not enough, right? So what is the best test? The best test is a 24-hour pH monitoring. You have to memorize this. Is a very important question frequently asked in exam. The entire topic of GERD is again discussed in the app, but uh, just the investigations part I'm discussing over here. So ambulatory 24-hour pH monitoring is the gold standard test to diagnose GERD. D-Mister score is used. If the D-Mister score is more than 14.7, that means the patient has GERD. You will also do an HRM to rule out other disorders. You will do an endoscopy to grade severity. So you can use Los Angeles grading system. Again, the Los Angeles grading system is discussed extensively in the app. You can also do a barium esophagram, because supposing if there is long-standing gastric reflux, the thing is there might be some amount of fibrosis, scarring, or changes to the anatomy of the esophagus. That is best seen on barium esophagram. How do you manage it? You will give antacids, H2 receptor antagonists like Rantac, proton pump inhibitors like pantoprazole, omeprazole, prokinetics. This is new. This is present in the new edition of Bailey and Love. You will give PCAB. PCAB is nothing but a potassium competitive acid blocker. I have included this over here because this is given only in the new edition of Bailey and Love. This is an important topic. This is an important point and can be asked in your NEET. So how do you surgically manage it? Surgically manage it is you will do an anti-reflux surgery. So the anti-reflux surgery is done by fundoplications. Fundoplication, it can be either a Nissen's fundoplication, which is a complete, or a 360-degree. It is a 360-degree. Some problem with the pen. Okay, anyway, Nissen's is 360 degrees fundoplication, and the partial ones are anterior, that is door. Door is 180 degrees. You can also have a Watson fundoplication and a posterior or a Toupet fundoplication. Now, usually the question that is asked commonly in the exam is which one is a posterior or which one is a partial fundoplication, right? So Nissen's you have to memorize. Nissen's is the one which is complete. Among the partial ones, which is posterior. So the word Toupet, it has P in it. So is posterior, right? This is how I remember it. Okay, moving on. The treatment of achalasia cardia, which is associated with high rate of recurrence, is so there are various forms of treatment. So what is achalasia cardia? It is the failure of lower esophageal sphincter to relax. So the lower esophageal sphincter in achalasia cardia, it does not relax, right? So because it is not relaxing, uh, contents are not able to food contents are not able to pass from the esophagus into the stomach. But basically the lower esophageal sphincter becomes stiff, so you want it to become loose, right? So what do? So you can either do a pneumatic dilatation. Basically you put a balloon over there and you inflate the balloon. So when you inflate the balloon, that sphincter becomes big. Or you can do a laparoscopic myotomy or an open surgical myotomy. Basically, as the name suggests, since it is a myotomy means you're going to myotomy. You're going to make an opening. You're going to incise the muscles of the esophagus, right? That is the muscularis propria layer. So once you incise the muscles, obviously the sphincter relaxes. The same thing is done in Fistula-in-ano. In Fistula-in-ano also, since the sphincter is tight, you will do a lateral internal sphincterotomy. So the moment you incise the muscular fibers, it relaxes, right? So that is one way of doing it, and you can also do a Botox. In Botox, basically you're going to inject a botulinum toxin into the involved area. That will it will destroy the nerves over there. So once it destroys the nerves over there, the muscle is not contracting as well as it was contracting earlier, right? Now, among all these treatments, the highest rate of recurrence is with Botox. In fact, with Botox, the patient might have recurrence of symptom within even 3 months, right? Now, supposing, say, if you do not have, if you did not have any idea about this topic and still this question was asked in the exam, you can still rule out a few options. So, since myotomy is common, both these options are ruled out, right? And then your answer is between pneumatic dilatation and Botox. Okay, so what is the medical treatment of acalsia cardium? So, you will give calcium channel blockers, nitrates, and 5' phosphodiesterase inhibitors. Now, these are usually given to patients who are not able to undergo surgical treatments, right? And sorry, these drugs are usually given just prior to a meal. So, prior to a meal, if you give these drugs to the patient, the sphincter relaxes, the patient is able to have a proper meal. Okay. So Botox, it is a potent presynaptic inhibitor of acetylcholine release from the nerve ending. Since it prevents the release of acetylcholine, the nerves, they're not, the impulse is not transmitted basically. The problem with Botox is it is injected, it requires repeated injections. And how do you inject it? It is injected endoscopically. So one advantage of Botox and pneumatic dilatation is it is done via the endoscopy route, right? So it is lesser invasive compared to myotomy. Okay, so pneumatic dilatation has a risk of perforation. You will do a Heller's myotomy. A Heller's myotomy involves cutting the muscle of the lower esophagus as well as the gastric cardium. You will usually do an anterior myotomy, obviously, right? Because it is difficult to, if you're doing laparoscopically or laparotomy, it is difficult to look at the posterior part. So you're going to do an anterior myotomy. So currently, the standard procedure is a laparoscopic approach, right? But earlier you could do a laparotomy also, and sometimes even a transthoracic procedure is um, indicated depending on the position of the lower esophageal sphincter. Now, when you do a myotomy, you are destroying the muscle fibers over there, right? So it becomes relaxed. Sometimes it becomes so relaxed that reflux is happening. You do not, so you neither want reflux to happen nor do you want contents to stay over there. You want contents to pass freely, right? So when you do a myotomy, in order to prevent reflux, you will do an anti-reflux surgery. That is, you will do a fundoplication. So when you're doing a fundoplication, you are usually going to do a partial fundoplication. So this partial fundoplication, you either do an anterior door or posterior toupet. Usually a posterior toupet is preferred, and this will then it will take care of the risk of GERD. Now, the newest form of treatment is something called POEM, that is per oral endoscopic myotomy. Now, as far as esophagus is concerned, actually, the treatment of esophagus has been taken over by endoscopists, right? They are doing more procedures in the esophagus than surgeons. So, what is this POEM? In POEM, it involves creation of a long esophageal myotomy using a flexible GI endoscope. So, basically, they insert a scope via the oral cavity. It reaches the esophagus. Once it reaches the esophagus, um, what happens is they make an incision into the mucosa. Once they make an incision in the mucosa, they then, via the help of dissection, they get access to the muscular layers. Once they get access to the muscular layers, they can then divide the muscular layers. So now the esophagus has two muscular layers, right? It has an outer longitudinal and an inner circular. Now, supposing if you're going to do a myotomy, that is from the anterior route, then you will be cutting the you will be cutting both actually, longitudinal as well as inner circular muscles, right? But when you do it endoscopically, you're going to be cutting only the inner circular muscles, because here your axis is from inside to outside, right? Now, once you have done the dissection, you will then clip the esophageal mucosal opening. Now, supposing say if this is done properly, then it is almost as effective as a Heller's myotomy. Now, supposing say the patient is a long-standing case and the patient has developed a sigmoid esophagus or a mega esophagus, then you will do something called a esophagectomy, right? So, moving ahead, antenatal double bubble appearance on ultrasound is due to what? So, you have to memorize this. Single bubble is seen in congenital hypertrophic pyloric stenosis. Double bubble is seen in duodenal atresia. Triple bubble is seen in jejunal atresia. So, basically, uh, this is the esophagus, this is the stomach, right? Here you have the um, pyloric valve, all right, and here you have the C loop of the duodenum. So normally what happens is if you look at, if you take an X-ray from a normal individual, you would normally see a gastric bubble, right? So you normally see a gastric bubble. Now supposing there is duodenal, so you will see an air bubble over here, because so why do you see an air bubble only in the gastric? Because there is a valve present, right? Because there is a pyloric valve present, that is why there is some amount of air which is collecting proximal to it, which is seen on X-ray. Now supposing say if there is duodenal atresia, that means there is an obstruction over here. So you will not only see an air bubble in the in the stomach, you will also see an air bubble over here, which gets trapped in between these 2 points. That is a double bubble. In jejunal atresia, now supposing say there is, so this was the C lip of the duodenum, this is the jejunum. Supposing say there is an atresia over here, right? Then you will see gastric bubble, you will see a bubble over here, and you will see a bubble over here. So you will see a triple bubble appearance. So let us discuss duodenal atresia in some amount of detail. So the obstruction duodenal atresia usually lies just distal to the ampulla of Vater. The proximal duodenum and the pylorus dilate with swallowed amniotic fluid, rendering the pylorus temporarily incompetent. Now, sometimes there might be a web, and this is the grades of duodenal atresia. This is again given in more detail in the app. I can't go into that much detail today because of lack of time, but okay, let us move ahead. So, you can actually diagnose this antenatally, right? Supposing if you diagnose this, if you suspect it antenatally rather, you can confirm it postnatally. So so the mother is basically warned that the baby might have duodenal atresia, and she undergoes delivery in a place where there are facilities to take care of the neonate, right? So you can do it antenatally also. Supposing say if it is missed, then you will see a double bubble sign. Now, how do you treat this duodenal atresia? So, you will treat it, the repair is done by something called a open chimera duodenostomy, right? And after you do a duodenostomy, you might or may not place a transanastomotic tube. So, how do you do this duodenostomy? You can see this image over here. You make an incision in the proximal part, you make an incision in the distal part, and you bring these two together. Once you bring these two together, the diameter increases, right? Then you can also place a tube. So, this is an X-ray image which is showing two bubbles. You have one bubble here, one bubble over here. Okay, so let us take a lunch break here. After break, we shall resume. welcome in this post-lunch session. So we've been discussing a few topics such as transplantation, liver, gallbladder, pancreas, esophagus, stomach since morning. So let us resume. So nerves of Lethargit are spared in. So what are these nerves of Lethargit? Basically, these nerves of Lethargit, they are nerve supplies, nerve supply to the stomach, and they are spared in highly selective vagotomy. So usually the question that is asked easily commonly in exams is in selective vagotomy. So there are three types of vagotomy. One is truncal vagotomy, one is selective, and one is highly selective. So in selective, these Lethargit is sacrificed. In highly selective, it is preserved. So where is this highly selective vagotomy done? It is done in duodenal ulcers or gastric ulcers. Now let us discuss about the treatment of duodenal ulcer in brief. Now the goal of surgery in duodenal ulcers is you want to exclude acid from the duodenum, right? So how do you do this? You do this by two ways. One is let the stomach produce acid, but you divert the acid away from the duodenum. Second thing is you decrease the production of acid by the stomach, that is you reduce the secretory potential of the stomach. So what are the gastrectomy based procedures? That is where you are reducing the secretory potential of the stomach. So gastrectomy can be done in the form of either Billroth 1 or Billroth 2. Billroth 1 gastrectomy is where the lower half of the stomach is removed, and the cut stomach is then anastomosed to the first part of duodenum. So in Billroth 1 only the stomach is being removed, right? So once you remove the lower half of the stomach, the remnants, I have a diagram which I'll show you to you later. You remove the distal half of the stomach and the proximal half is anastomosed to the first part of duodenum. So it is anastomosis to D1. Now let us look at Billroth 2. Billroth 2 and polygastrectomy, in which 2/3 of the stomach is being removed. So you are removing more stomach than in Billroth 1. There you are removing only half. Here you are removing 2/3, right? And along with this, after you remove the 2/3 thing, the duodenal stump is being closed, right? So there is no anastomosis happening to the duodenum like it was in Billroth 1. Here the duodenal stump is being closed and the stomach is then being anastomosed to the jejunum. That is, you're going to get a gastrojejunostomy. So in Billroth 2, what is happening is you are diverting the gastric secretions away from the duodenum, right? Now there is no elective role for these procedures in the treatment of duodenal ulcer, right? But sometimes the polya procedure is occasionally needed. Okay, so now what is vagotomy? So vagotomy means you are sectioning the vagus nerve. That is, you make an incision in the anterior vagus nerve and in the posterior vagus nerve. Now by doing this, what happens is you decrease the peak acid output by almost 50%, right? So only vagotomy, it will be around 50%. Vagotomy plus antrectomy. Why antrectomy? Because it is in the antrum that those cells are present, which is going to produce, that is maximum HCl is being produced in the gastric antrum. So if you do a vagotomy and an antrectomy, then in this scenario your output is being decreased by 85%. So now what is this truncal vagotomy? Truncal vagotomy is you're going to perform division of the left and the right. So you're not choosing either left or you're going to section both left and right vagus nerves. It is done above the, so left is above the hepatic and right is above the celiac branches, right? Now, along with, once you do a vagotomy, see basically the vagus is parasympathomimetic, right? So it is helping in the contents, the peristalsis of contents from proximal to distal. Now, once you have sectioned the vagus nerve, there is going to be some impediment to peristalsis. So you have to take care of that as well, right? So you also do a drainage procedure. This drainage procedure is being done to avoid gastric stasis. So the, why do you do a drainage procedure? This is because pyloric relaxation is mediated by vagal stimulation, and a vagotomy without a drainage procedure can therefore cause delayed gastric emptying, right? Now when the duodenal bulb is scarred, that is after a duodenal ulcer, supposing because of duodenal ulcer there is some fibrosis or scarring in the duodenum, then what do you do? So there you will do a you will do a Finney's pyloroplasty or a jabular gastroduodenostomy. This is a useful alternative, right? I'm sorry, I missed out one part. So when you do a vagotomy, the drainage procedure that is most commonly done is the high neck Miculix pyloroplasty, right? But in a high neck Miculix pyloroplasty, you are going to anastomose to the duodenum, so duodenal bulb. But supposing the duodenal bulb is scarred, then you might have to do an alternative procedure that is called a Finney's pyloroplasty or a jabular gastroduodenostomy. Now, supposing there is so much of scarring in the duodenum that there is no way that a gastroduodenostomy or a pyloroplasty is possible. In that scenario, you will have to do a GJ, that is an anastomosis between the stomach and jejunum. This will bypass the fibrous portion in the duodenum, and therefore it is better. So, truncal vagotomy can also be combined with andrectomy. Yeah, selective vagotomy. So, I told you that in truncal vagotomy, you are going to divide the right and left vagus nerves proximal to the celiac and hepatic branches, right? But in selective vagotomy, you are going to divide the main right and the left vagus nerves distal to the celiac and hepatic branches, right? Along with this, you are going to do a pyloric drainage procedure. So, pyloric drainage procedure is being done in both truncal vagotomy and selective. Pyloric drainage procedure is not done in highly selective vagotomy. So, let us come to highly selective vagotomy. This is also called parietal cell vagotomy or proximal gastric vagotomy. Basically, you are going to divide only the vagus nerve which supplies the acid producing portion of the stomach within the body of the stomach and the fundus. So, since it is preserving the vagal innervation of the gastric antrum and the pylorus, therefore, there is no risk of gastric stasis and you will not be doing any routine drainage procedure. In GJ, we already discussed GJ. When you do a GJ, it can be an anterior or it can be a posterior type. Anterior or posterior. The posterior GJ is usually retrocolic. Now, when you do a posterior GJ, when you do a GJ, the posterior GJ is preferred. So, in posterior GJ, the jejunum is anastomosed to the posterior dependent wall of the stomach. Let us look at the diagrams. What is Billroth 1 gastrectomy? Billroth 1 gastrectomy, what I told you was the lower half of the stomach is excised, resected, and the proximal half is anastomosed to the first part of, so the stomach is getting anastomosed to the first part of duodenum, right? This is what is happening in Billroth 1 gastrectomy. In Billroth 2 gastrectomy, what are you going to do? You're going to remove 2/3 of the stomach, fine. So, once you remove the stomach, there is a portion of the duodenum which is remaining. You close that stump. You close duodenal stump. Now you have to establish a passage, right, for the stump for the contents to go. So for that you will be doing a GJ. To be more specific, you will be doing a posterior GJ, right? So here you can see to do a GJ, you have to make an opening. You have to make an opening in the transverse mesocolon, right? Sorry, you have to make an opening in the in the omentum of the transverse colon. So when you make an opening in the omentum of the mesocolon, you are then going to take the loop of jejunum to the dependent wall of the stomach. So once you do that, there is a defect which is present in the mesocolon. That defect has to be closed. If you do not close that defect, it can cause internal herniation. So moving ahead, which of the following is not true regarding gastrointestinal stromal tumor? So let us look at the options. Tumor size is an important prognostic factor. This is true. They arise from the interstitial cells of Kajal. This is also true. It is the most common mesenchymal tumor of the GIT. This is also true. Most of them are associated with ALK mutation. This is false. So most of them have CD117 or platelet derived growth factor receptor alpha mutations. So GIST are the most common mesenchymal neoplasms, arise from the interstitial cells of Kajal, and these cells of Kajal, what is the function of it? It is a GI pacemaker cell. Now As the name suggests, it is gastrointestinal. So it can arise in any part of the GIT, but most common is the stomach. Now, what is the etiology? Like I told you, it is usually a mutation in the tyrosine kinase oncogene, right? That is CD117. Also, there might be a mutation in the PDGFRA, that is the platelet derived growth factor receptor alpha genes. So, now these GIST tumors, they express certain CD markers. Those CD markers are CD117 and CD34. Now, the size of the tumor as well as the mitotic index, they are the best predictors of metastasis. Therefore, they also predict the prognosis of these tumors. Peritoneal and liver mets are most common. The spread to lymph nodes is extremely rare. So, what are the clinical features? They are equal in both males and females. And supposing if the tumor is small and it is in the stomach, it might go unnoticed. But if the tumor is large, then they present with non-specific symptoms. What are those non-specific symptoms? Early satiety. So, since it is arising in the stomach and it is occupying a part of the gastric lumen, therefore the gastric capacity decreases. Because of this, the patient has early satiety. He will also have bloating. He also has vague abdominal pain. Now, bleeding can occur, and bleeding whenever it occurs, it is more commonly in the form of melena. So, melena is more common than hematemesis. So, in melena, some amount of bleeding is occurring continuously, and as the blood is passing through the GIT, the hemoglobin gets altered, and which gives black color to the stools. Sometimes the patient might even vomit it out. When the patient vomits it out, it is hematemesis. Now, tumor rupture can also happen. If the tumor ruptures, then you will have intra-abdominal hemorrhage. Tumor rupture is more common when it is present in the outer, that is in the external aspect of the GIT, not close to the lumen. If bleeding occurs in the lumen, then you will get melena. But supposing the tumor is present more towards the outside, the tumor becomes big and the tumor ruptures, then it might cause hemoperitoneum. Now, many patients remain asymptomatic and they are discovered incidentally. What investigations do you do? Now, for all cancers from the hair to your toenails, the best investigation for any cancer is always biopsy. Fine. Now, so to do a biopsy, you need some access to the tissue, right? So, for in the GIT, you have endoscopy as well as colonoscopy, right? Or for example, urinary bladder, you have cystoscopy. So, the advantage of, or in trachea, you have tracheoscopy, you have bronchoscopy. So, the advantage of these scopes is you can not only visualize the lesion, but you can also take a biopsy, and biopsy is gold standard diagnosis for almost all diseases with a few exceptions. So, you do an endoscopy. In endoscopy, what happens is, you can take the biopsy, but sometimes what happens is, supposing if the mucosa which is overlying the tumor, since it is a stromal tumor, it is not arising from the mucosa, right? So, supposing if the mucosa above the tumor is normal, that is the mucosa is not ulcerated, you might even give a wrong report saying that it is a normal finding, there is no tumor. So, in such scenarios, suppose if you have a doubt that this is the area where there is a tumor, so you can insert a ultrasound probe via the scope, that is called the endoscopic ultrasonography, right? So, when you do an endoscopic ultrasonography, you will get to know that this is the part of the GIT wall which contains the tumor, and you can target that part specifically to do a targeted biopsy. Then you can do a CT scan of the abdomen with oral and IV contrast. Now, supposing if the patient, so for CT scan, you're going to do a CT scan, right? That is, you're going to insert a dye. The dye will be taken orally as well as intravenously. Now, if it is given orally, it is going to get excreted in the GIT. Some amount might get absorbed, right? A very minute portion. But supposing supposing say if the patient has that is, you can give either oral or IV route, right? Now, supposing the patient has renal disease, you cannot give that dye. So, there are two absolute contraindications for giving dye in a CT scan. One is if the patient is allergic to the dye, because the patient can get anaphylaxis and die. Second is, since the dye is going to be excreted via the urine, that is, it is going to be filtered at the kidneys. If the kidney is not functioning properly, right, that means you cannot give the dye. So, there are contraindications. One is anaphylaxis and the other is renal injury. So, supposing say if the patient cannot receive IV contrast for these reasons, or if the tumor is in the rectum. Now, rectum is present in the pelvis, right? So, supposing if it is in the pelvis, if you do a CT scan, the image is not that clear. So, for pelvic part of the colon, the investigation of choice is always an MRI. Therefore, patients who cannot receive IV contrast or for rectal cysts, then MRI is preferred. Then you can also do immunohistochemistry, that is IHC. IHC will show you CD117, CD34 and PDGFRA mutation. Now, the mainstay of treatment is complete surgical resection. Supposing say if it is a small tumor, you will just be doing a wedge excision, right? Supposing if it is a large tumor, now if you recall in the MCQ, we had said that the size of the tumor determines the prognosis of the tumor, right? So, if it is a large tumor, it might require a gastrectomy or a duodenectomy, fine. But lymphadenectomy is not required. This is an important MCQ point. Please make note of this point. Lymphadenectomy is generally not required in cysts. Now, supposing say the tumor is even bigger, so if it is small, you just do wedge resection. If it is larger, you might have to do a gastrectomy or a duodenectomy. Now, supposing the tumor is even larger, then you might have to do a multivisceral resection. Along with that, you have to resect the mets. Then next is targeted therapy. In targeted therapy, since in targeted therapy, so just they are sensitive to certain, they are very sensitive to a tyrosine kinase inhibitor called sunitinib and imatinib. So more than sunitinib, it is actually imatinib. So if you have the if the MCQ has only one option of sunitinib, you will choose sunitinib. If it has options of both sunitinib and imatinib, you will choose imatinib. So cysts are sensitive to the tyrosine kinase antagonist imatinib, right? Therefore, it can be used either in the neoadjuvant or in the adjuvant setting. Neoadjuvant means you're going to give it before surgery. Adjuvant means you're going to give it after surgery. Okay. Which one of the following statements is incorrect regarding Meckel's diverticulum? So, what is this Meckel's diverticulum? So, Meckel's diverticulum is found on the anti-mesenteric border of the small intestine. This is true. So, supposing say this is the small bowel, right? This is the mesentery. So, the blood vessels are present in the mesentery, right? So, when it is present, so this is the mesenteric border. This over here is the mesenteric border. This is the anti-mesenteric border, right? So, Meckel's diverticulum is usually found on the anti-mesenteric border of the small intestine. This is true. Consists of mucosa without a muscle coat. This is false. So, now there are two types of diverticula. One is a true diverticula and one is a false diverticula. A true diverticula, it contains all the layers. So, that means it contains mucosa, submucosa, muscularis propria as well as serosa. But a false diverticulum, it will not contain all these layers. It is usually a mucosal outpouching. Meckel's but is a true diverticulum. So, it contains all the layers. So, this option is false. So, this is your correct answer. Coming to the other options. Heterotopic gastric mucosa can ulcerate and cause a brisk GI bleed. Now, with Meckel's diverticulum, you have the rule of twos. So, rule of twos means it is usually 2 inches long. It is usually present 2 feet proximal to the ileocecal valve, right? And it usually contains two types of mucosa. That is, it can contain either gastric mucosa or pancreatic mucosa. Now, if it contains gastric mucosa, it will also secrete acid, right? If it secretes acid, the acid is going to come in contact with these neighboring mucosa. Now, the stomach cells are adapted to the presence of acid, right? But the colon cells, that is, I'm sorry, the ileum cells are not adapted to the presence of acid. So, if there is gastric epithelium and the gastric epithelium produces acid, and if the acid is then going to act on the neighboring mucosa, that mucosa ulcerates. So, when that mucosa ulcerates, you will get brisk GI bleed. So this option is true. Now sometimes there might be a fibrous band between the apex of the diverticulum and the umbilicus, right? So whenever there is a fibrous band between the apex and the umbilicus, that is, let us say if this is the diverticulum, let me give some space over here. This is the diverticulum, right? So sometimes what happens is there might be a band of adhesions between the tip of the diverticulum to the umbilicus. So when that happens, there is a so that acts as a torsion point, and by that point the ileum can get twisted. There might also be adhesion between the tip of the diverticulum to the lateral abdominal wall. In that scenario, what happens is, see, if it is lying freely, there is not a problem. But the moment it is being adhesed to the umbilicus or the anteabdominal wall, it can twist. The torsion can happen, right? Supposing if there can be adhesions between the tip of the diverticulum to the lateral abdominal wall. So then you have a space over here, right? That is, if this is the anterior lateral abdominal wall, you have this space. Now, why this space? Why do you have this space? Because here it is adhesed, right? So via this space, an internal herniation can occur. So this option is also true. So what is this Meckel's diverticulum? It is actually a persistent remnant of the vitello-intestinal duct. So antimesenteric side, it is a congenital diverticulum. True diverticulum it has its own blood supply. Yes, rule of two is present in 2% of the population, 2 feet proximal, 2 inches long, 2 types of mucosa. Now, the vast majority of these patients are asymptomatic and it might present in the following ways. Hemorrhage I've already discussed. Diverticulitis, just like appendicitis, it can get inflamed. Intersusception, yes, because the diverticulum can act as a lead point. If it acts as a lead point, the intersusception that occurs is either a ileo-ileal or an ileocolic intersusception. So, chronic ulceration we've discussed, bowel obstruction also we've discussed. Perforation also, yes. So, just like how you can get perforation in the stomach because of acid or in the duodenum, similarly, in fact, if the Meckel's diverticulum contains gastric mucosa, the adjoining wall of the ileum, of the ileum, that is more prone to get perforated, right? It is not as resilient, as strong as the gastric mucosa. So, if this perforates, you're going to get peritonitis. In fact, I've seen when during my MS days, when I was posting pediatric surgery, I had actually seen a child who had perforation just adjacent to the diverticulum. So they say seeing is believing. So after I've seen that case, I've never forgotten this particular complication of Meckel's diverticulum. So now, how do you diagnose this? So the most accurate diagnostic test for diagnosing a Meckel's diverticulum is a sodium 99m, that is a technetium per technetate scintigraphy. This is the single most accurate diagnostic test. So why is it so accurate? It is because this 99m technetium per technetate, it is preferentially taken up by the mucus secreting cells of the gastric mucosa and the ectopic gastric tissue in the diverticulum. So if it is preferentially taken up by these cells, so once you give the dye, this is actually nuclear medicine. So once you give the dye, this gastric tissue, it in the diverticulum, it takes up this dye, right, and then it lights up on screen. So supposing if you want to improve accuracy, you can use certain drugs. For example, you can use cimetidine. Now, supposing if this test comes negative, right, but you're still suspecting Meckel's diverticulum, then you will use other tests. So why can this test come negative? Supposing if it does not contain gastric mucosa, then this test will come negative. So in that scenario, you will do some other tests. Anyway, so now let us come to the treatment. So what is the treatment of Meckel's diverticulum? Now, supposing if you've done a laparotomy and during the laparotomy, you come across a Meckel's diverticulum, should you do something or should you just leave it alone? So, supposing if say the Meckel's diverticulum has a wide mouth, right? And if the diverticulum is not thickened, you leave it alone. If it has a wide mouth, the chances of it undergoing what is that? Of it undergoing diverticulitis is very, very low. So see, in the appendix, the mouth is narrow, right? So the appendix, it can get obstructed by a fecalith or even because of edema. So that can cause appendicitis. It can cause the accumulation of secretions distal to the obstruction, right? But supposing if say the diverticulum has a wide mouth, then you can leave it alone. Okay. But whenever you are in doubt, supposing you are like thinking, should I remove it, should not remove it, it is better to remove it, right? So if you want to remove it, how do you do it? So there are two ways of doing so. One is you resect the diverticulum and you suture the defect at its base. So supposing say this is the diverticulum, right? So you resect it only over here. You resect this part and whatever is remaining, you suture that close. Or if not this, there is another way of doing it, and that is, so this is the diverticulum. You do a resection anastomosis, right? So let us look at some images. So see here, you can see, let me use it. Yes, I'll use this. So this is the appendix, right? This is the appendix, and around 2 feet proximal to it is the ileum, which contains this diverticulum. This is the Meckel's diverticulum. Now, all are associated with non-healing of fistula except. So, here they are talking about an enterocutaneous fistula. So, if there is a contained abscess, obviously it is not going to heal. So, this is true because till you drain that abscess, till you remove the pus, it is not going to heal. There is a distal obstruction, yes, it is going to be non-healing because in case of a distal obstruction, the only outlet for the contents is via the fistula. Non-epithelialization, this is actually a fact which promotes healing. So, this is wrong. So, this is the answer. Radiation enteritis, yes, this is also true because in radiation what happens is the tissues become friable and there is a higher chance of it non-healing. Now, if there is non-epithelialization, what does that mean? So, for example, if you look at a pseudocyst, so in what is a cyst and what is a pseudocyst? A cyst is any structure, I mean collection of fluid or whatever, but the cyst is lined by uh, epithelial tissue. It can be squamous, cuboid, columnar, whatever, but it is lined by epithelial tissue. A pseudocyst, on the other hand, is not lined by this not lined by epithelium tissue. So, it is easier to treat a pseudocyst than a cyst which is epithelialized. Similarly, once the fistula epithelializes, that means it has got some integrity to it, that then it becomes non-healing. So, let us look at the other factors which are associated with non-healing of fistula. So, if it has a high output, what do you mean by high output? It means there is more than 500 ml of output every day. If there is severe disruption of intestinal continuity, that means it is involving more than 50% of the bowel circumference. If there is active inflammatory bowel disease, so there is continuous inflammation, therefore it is not going to heal. Cancer, yes. Radiation enteritis, yes. Distal obstruction, yes. Undrained abscess cavity, yes. Foreign body, yes. Fistula tract less than 2.5 centimeters. So, you might in your brain think that if the fistulous tract is bigger, see, we've discussed that if the output is more or if the circumference is more, it is not going to heal quickly, right? So, you might in your brain think that if the fistula tract is long, it is not going to heal, but the converse is true. Why is that? So, if the tract is small, right? If the tract is small, supposing say if this is the no, see, this is an ileal loop, right? This is a fistula which is occurring in the skin. Now, if this is long, supposing if say this were to be long, then any portion of it can become obliterated, right? And the fistula can heal. But if it is small, the chance of it obliterating on its own becomes less. So, if the fistula tract is less than 2, you have to remember these values: 500 ml per day, 50% bowel circumference, and 2.5 cm. You have to remember these values, right? So, the fistula tract is less than 2.5 centimeters. That means um, there is a better chance of it. Sorry, there's if this tract is small, it has a worse chance of healing on its own. And lastly, epithelialization. Okay. So moving ahead, let us look at the signs of acute appendicitis. So hyperextension of hip producing pain in acute appendicitis is due to which muscle? So this is because of muscle spasm of the psoas, that is the psoas major. So let us look at the signs in acute appendicitis. One is there is muscle guarding over the McBurney's point. So what is this McBurney's point? Supposing say this is, let us draw the abdomen. Now this is the umbilicus. This is the anterior superior iliac spine, right? So if you join a line between the ASIS and umbilicus, so junction of medial 2/3 and lateral 1/3. This is the McBurney's point, right? So this is the position where the appendix is normally present. So if there is muscle, so in one of the signs of appendicitis is there is muscle guarding over the McBurney's point, right? So this McBurney's point is the point of umbilicus. It is the right iliac fossa. Finger pointing signs, the same thing. The patient with one finger will point and tell you that this is where I've got pain. What is this Rovsing sign? So this is the part of position of umbilicus, right? So if you palpate over there, you're going to get tenderness. You might get rebound tenderness also. Sometimes if you palpate in the left iliac fossa, if you palpate over here, then too you might get pain. If you get pain, and where do you get pain? You get pain in the right iliac fossa. It's not that you're going to get pain in the left iliac fossa. You will get pain in the right iliac fossa only. But that is called Rovsing sign. So why is this happening? So when you palpate in the left iliac fossa, the bowel loops get displaced, and the inflamed appendix uh, it might touch the parietal peritoneum on the right side, right? So when that happens, it's going to cause pain. Now what is this psoas sign? Supposing if the inflamed appendix, if it lies on the psoas muscle, the psoas muscle goes into spasm. So once the psoas muscle goes into spasm, the patient, to get pain relief, the patient will lie with the right hip flexed. So this is the right hip. The patient is going to lie with the right hip flexed. This is spasm, and this is pain. Pain free of pain has decreased in this, right? He's going to lie with his hip flexed. Now, supposing if the inflamed appendix were to touch the obturator muscles, right? If it touches the obturator internus, then what happens is there's going to be a spasm of that muscle as well. So, in that scenario, the patient is going to get relief by flexing the hip and by internal rotation of the hip, right? So, in psoas sign, when you extend the hip, you're going to get pain, and in obturator sign, when you externally rotate the hip, you're going to get, I'm sorry, in obturator sign, when you externally rotate the hip, you're going to get pain. Next, cutaneous hyperesthesia may be demonstrable in the right iliac fossa. Now, there is a score which is associated with appendicitis. This is called the Mantrell's or the Alvarado score. Very easy to remember. M for migratory pain, A for anorexia, N for nausea and vomiting, T for tenderness in the right iliac fossa, R for rebound tenderness, E for elevated temperature, that is fever, L for leukocytosis, S for shift to left. Shift to left means when you take a peripheral smear, you will see more number of immature leukocytes rather than mature leukocytes. So, in this Mantrell score, each parameter is given a score of 1 except for two things. One is the tenderness in the right iliac fossa and one is the leukocytosis. These are special. These are given 2 points each. So, when you add all this, you're going to get a total score of 10. So, how do you interpret this? If the score is 9 or 10, it is very probable that it is appendicitis. If it is 7 or 8, it is probably appendicitis, right? So 7 or 8, you can still go ahead and operate. 9 and 10, you will definitely operate. 7 and 10, it is 7 and 8, it is probably appendicitis. So we'll still operate. If it is 5 to 6, it is equivocal. So if it is equivocal, you have to do, usually you will do an imaging investigation to confirm or to rule out appendicitis, right? If it is up to 4, it is normal. So there is no justification of acute appendicitis or no need, there's no justification of appendicectomy and there is no need for investigation when it is less than up to 4. 5 and 6, it can be either thing. So 5 and 6, you will supplement your diagnosis with an investigation. If it is 7, 8, 9 or 10, 9 and 10, definitely you're going to operate. No need for any investigation. 7, 8, it is justified if you operate. Okay, when rectal washouts are given to Hirschsprung's disease, the following fluid is used. So, in Hirschsprung's disease, the patient is going to have constipation, right? So, there might be accumulation of stool. So, if you want to give a bowel wash in such a patient, you will use the fluid, that is, you will use normal saline, right? Normal saline is usually used when you want to give a rectal washout. So, what is this Hirschsprung's disease? So, in Hirschsprung's disease, a segment of the bowel, it is usually the distal colon or the rectum, that is aganglionated. So, what do you mean by this aganglionosis? So, usually you have two nerve plexuses in the bowel, right? You have a submucosal Meissner's plexus and you have a myenteric Auerbach's plexus, right? So, as the name suggests, submucosal plexus is present beneath the submucosa and it is present in the submucosa, that is just below the mucosa, and in the myenteric plexus is present in the muscular layer, right? So, both there is absence of ganglion cells in both submucosal as well as myenteric. It is not that only one is affected, both are affected. This is more common in males, right? There is a family history. So, with Down syndrome, and there are a few genes which are involved. These genes are RET, EDNRB, and EDN3. So, what is the pathogenesis? So, basically, in this condition, um, so usually what happens is there are some neurons which are derived from the neural crest. These migrate to the colon. When this migration is affected, it causes Hirschsprung's disease. And when this migration is affected, that the term given to it is called neurocrestopathy. So it is derived from the neural crest, right? And that is not that migration is not happening properly. So it is the neurocrestopathy. So it is a pathology of the neural crest. Now, whenever this happens, it leads to aganglionosis. That is, there are no ganglions present. So, because of this, what happens is there are thickened nerve trunks in the distal bowel, right? This aganglionosis, it extends. So, what is the extent? It can extend from the anus to the sigmoid colon. This is the most common. So, only the sigmoid colon is affected. Sometimes it can go up till the proximal colon. It can even go up to the terminal ileum. So, what happens if there is aganglionosis? If there is aganglionosis, there is no peristalsis which is going to happen. So, there is going to be an obstruction over there. That is a functional obstruction, right? So, because of the functional obstruction, there is a what happens is, so supposing say this is the zone of obstruction, right? Proximal to it, this is proximal, this is distal. Proximal to it, the bowel will dilate, right? Because there is an obstruction, and distal to it, it can become empty. So, usually some stools are present, but as the patient passes stools, that becomes empty. So, a transition zone, it lies between the dilated proximal normal bowel and the narrow distal aganglionic bowel. So, what are the clinical features? So, if it is presenting in neonates, it will cause a delayed passage of meconium, abdominal distension, and bilious vomiting. Supposing if the patient, the diagnosis is missed in the neonatal age group, and as the child grows older, or sometimes even in adults, the patient will usually give you a history of constipation. And along with constipation, there will be chronic history of abdominal distension. So, what are the complications? So, the most common cause of death in Hirschsprung's disease is enterocolitis. Supposing if Hirschsprung's is not corrected, enterocolitis can supervene and that can cause death. So, how do you investigate such patients? So, the gold standard is rectal biopsy. Since it is aganglionosis, seeing is believing, right? So, you examine the bowel, and if there are no ganglions present, that means it is definitive proof of Hirschsprung's disease, that is aganglionosis. So, rectal biopsy is the gold standard. Now, how do you do a rectal biopsy? There's no need to do a laparotomy. You use a suction rectal biopsy kit. That is, you insert something rectally, and that will suck some amount of cells, and therefore it can be done bedside, right? And if you do a contrast enema, it will then show the narrow aganglionic segment and the dilated proximal bowel. Cone is what? Cone is the distal part. Now, the only curative treatment of Hirschsprung's is you have to excise. You cannot give nerves. You're not God, right? You cannot give nerves to the aganglionic segment. So, you excise that aganglionic segment. Then what do? So, supposing you excise a segment, whatever is present proximal to it, You either anastomose it to the, you can anastomose it to the lower one, but still that is not a foolproof method. The best, because it usually if you look at Hirschsprung's, it is extending from the anus, right? So it is not that somewhere in the middle it is involved. In the anus only it is, I mean, at the terminal part only or near the terminal part only it is involved. That is why when you look at the pathology, the distal part, you are hardly seeing any distal part, right? Because it is at the exit level point. So since it is very close to the anus, there is no role for anastomosis. So what happens is, you remove the A ganglionic segment and whatever bowel is present above it, right? You pull it down, right? So you bring the ganglionic, that is a normal bowel, to the anus. So there are definitive procedures which there are two ways of doing it. One is there's a definitive procedure. One is you do it in multiple sittings. So definitive procedures are much better and they are named. So these are Swenzel, Duhamel, Swerve, and you can also do transanal pull through operation. Now, before you operate, you need to establish fecal passage, right? You need the stools to pass. So you try this out first, right? So what you do is you do a rectal or bowel washout. If this works, good. If this does not work, then you have to do a laparotomy and you fashion a stoma. So that means you create a end stoma, right? Why do you do this end stoma? Is because, where do you do this end stoma? So what you do is, wherever you're suspecting that Hirschsprung is present, just proximal to it, you take a few cells, you send it for frozen section. If the pathologist tells you that there are ganglion cells present over, then that is normal. You can bring it out. Supposing if it is not present over there, you have to go slightly proximal. So you can see in this image, so these yellow dots that you can see over here, these yellow dots over here, right? I'm putting blue color over it, but these yellow, this is the dots and the lines, these represent the ganglion. So in Hirschsprung, this is what happens is, the ganglion cells are absent. Because of this, the distal part, that is the part which is very close to the anus, even though it is a small part, that becomes shrunken, and this becomes also appears. So if you look at the entire thing, so since the proximal part is dilated, this entire thing will look like a cone, right? Okay, moving ahead. So what is this Hinchi classification? Where is it used? Hinchi classification is used for perforated diverticulitis. So this diverticula is not the Meckel's diverticulum. This is the sigmoid diverticula, right? So what happens is, whenever there is sigmoid diverticulum, you can have complications. If there is diverticulitis and if the diverticulitis perforates, only when it perforates, you are going to use a classification that is called the Hinchi classification. So mind you, this classification is not there for just for diverticuli. It is there for perforated diverticulitis, right? So there are four types in this. One is in Hinchi one. So in Hinchi one, there is perforation. Some amount of feces, that is contents, have leaked out. It is causing a localized abscess. So it is paracolic, right? In Hinchi 2, it is not just paracolic, it becomes bigger. And since it is usually the sigmoid colon which is involved, you're going to get a pelvic abscess. In Hinchi 3, the abscess, it bursts. So what happens is, there is going to be pus present in the peritoneum, that is, there is purulent peritonitis. And in Hinchi 4, you are going to get feculent peritonitis. So you can see this beautiful diagram over here. In Hinchi 1, you are going to get a small paracolic or a pericolic abscess. Hinchi 2, you are going to get pelvic abscess. Then if this discharges, you are going to get purulent peritonitis, and here feces are coming out. So moving ahead, which polyp has maximum malignant potential? So let us look at the types of polyps which are present in the bowel. So adenomatous polyps are the most common polyps with malignant potential. So the progression of an adenoma to an carcinoma is very well documented, right? So whenever there is an adenoma, that is, whenever there is an adenomatous polyp, rather, it has a high chance of malignancy, right? That is why it is important. So now, obviously, the adenoma, that is a benign tumor, is more common than the malignant part. Let me I think I'm confusing you more. See, adenoma can transform into carcinoma, right? This sequence is well documented. Now, obviously, carcinoma is malignant and adenoma is benign. So, obviously, the benign part is more common. So, there are many people who have adenomatous, that is benign polyps, but not all of them turn into malignancy. So, now how do we know which polyps are going to turn into malignancy? Right. Now, again, see this polyps and all the polypitis, the Peutz-Jeghers syndrome and all those other syndromes, I have discussed in extensive detail in the app. So, you can look at Sir's videos and you can look at my test and discussion series videos where I have discussed the polypid disorders in extensive detail. Here, because of lack of time, since it is a single day session, we have to utilize time, and I am just giving you a brief overview. So, the most common adenomatous polyps which can cause malignancy, we are going to look at that, right? Now, the most common polyps, like I told you, are adenomatous polyps. That is the most common polyps with a malignant potential. Now, among the most common adenomatous polyps, you have tubular adenomas, and these are frequently pedunculated. So, that means a tubular adenoma and a pedunculated adenoma. These are all risk factors for malignancy. So, let us look at the types of polyps. So, on the basis of histology, you can get tubular, you can get villus, you can get tubulovillus, right? Now, tubular is benign, right? Since it is benign, it is the most common subtype. Villus is the villain. It is the villain which is going to be malignant, right? So, villus has the highest risk of malignancy. Tubular villus is a combination of both. So, the risk of malignancy will be villus followed by tubulovillus followed by tubular, right? Tubular villus has both. So, basically, more the amount of villus epithelium, more the chances of malignancy. On the basis of morphology, the polyps can be of two types. One is sessile and one is pedunculated. Pedunculated has a higher risk of malignancy. So, risk of malignancy is dependent on the histology, the morphology and the size. Tubular adenomas have the lowest risk with increasing risk as the villus features predominated. Tubular adenomas are generally pedunculated, villus is generally sessile, right? I think I made a mistake. I don't know what I told you earlier. It is a sessile which has a higher risk of malignancy. I'm not sure what I repeated earlier. In flow, I may have made a mistake. So, malignancy, it is villus followed by tubulovillus followed by tubular, and it is sessile more than pedunculated. Pedunculated is usually, therefore, pedunculated is more common. See, that is what I had mentioned over here. Most common adenomatous polyps are tubular and they are frequently pedunculated. That is because the benign part is always more common than the malignant part. Okay. Where were we? Yes. So, sessile and particularly depressed lesions have more malignant potential than pedunculated ones. The risk of malignant change increases with size. So, just like GIST, the size matters. So, see in the urological, that is in penis carcinoma, in testicular carcinoma, the size does not matter. But as far as bowel is, as far as polyps and as far as GIST is concerned, size definitely matters. So, the risk of malignant change increases with size, and almost one third of large colonic adenoma, large adenoma means it is more than 3 centimeters. So, if it is more than 3 centimeters, one third of those polyps will have a area of invasive malignancy. So, now what are high risk polyps? So, supposing if a patient undergoes screening, a lot of polyps are seen. So, then what do you mean by high risk polyps in that scenario? So, a high risk polyp is two or more pre-malignant polyps, out of which at least one is an advanced colorectal polyp, right? What do you mean by an advanced colorectal polyp? Advanced colorectal polyp means a serrated polyp of 10 mm or more in size, or it contains any grade of dysplasia, or it is an adenoma of 10 mm in size or more, or it contains high grade dysplasia. So, these are the this is the criteria for calling it a advanced colorectal polyp. So, one is serrated polyp, 10 mm in size. This is first one. Second one is containing any grade of dysplasia. This is 2. Third one is an adenoma more than 10 in size. Fourth one is if there is a high grade dysplasia. So, if there are 2 or more premalignant polyps, out of which at least one is an advanced colorectal polyp, or if there are 5 or more premalignant polyps, this is also a high risk for malignancy. Now, what is this virtual colonoscopy? Virtual colonoscopy, this is also a trending topic. It is an important topic. You need to know this. Now, some patients, they may not want to undergo a colonoscopy for whatever reasons. They are either scared of the procedure, they feel it violates their privacy, whatever it is. So, in those patients, you can offer them a virtual colonoscopy. So, what do you do in a virtual colonoscopy? In virtual colonoscopy, you are going to take a lot of images of the colon. You're going to use both CT scan and you're going to use MRI, right? And once you use both CT as well as MRI scan, you're going to put all those images together and you're going to generate an image. So this is what a virtual colonoscopy looks like, right? See this one, this is a CT scan and this is a virtual colonoscopy. So the images that are seen are almost as good as of a conventional colonoscopy, right? But what is the obvious disadvantage of a colonoscopy? So in a sorry, what is the obvious advantage of a colonoscopy? So in colonoscopy, you can take a biopsy, right? In CT scan, you cannot take a biopsy, but in CT scan, you can also look at pathology which is present outside the colon. So let us look at the questions. True about virtual colonoscopy, you're not going to do a real, you're not going to put a real scope. So has better images than conventional colonoscopy? No, I would not say that. See, you're going to get this image, right? You're going to get a good image, but it is no way better than a actual colonoscopy. This is false. It is performed by CT and MRI. This is true. Takes more time than conventional colonoscopy? No. CT and MRI hardly takes, CT hardly takes any time. MRI also you can finish in 20 minutes or half an hour. Colonoscopy, you have to prepare the patient, shift the patient, do so many things. And helpful in pathology outside colon, this is obviously this is true. So in virtual colonoscopy, it is helpful in pathology outside the colon, obviously. So if you're going to do a CT scan, you are going to you're going to you can also look at pathology outside the colon. So let us look at the discussion part. So a double contrast barium enema which was used earlier, that has been almost replaced by CT scan, CT colography, or a virtual. So a virtual colonoscopy is also called a CT colonography. In the newer edition of Bailey and Love, this term is given. So CT colonography is the same as virtual colonoscopy. Now this is extremely sensitive in picking up polyps up to a size of 6 mm. So it has the advantage of being less invasive than a colonoscopy, but obviously if a biopsy is required, you will still need a colonoscopy. So it is used as a diagnostic tool in patients with a palpable abdominal mass. Suppose there is a mass per abdomen and you're going to suspect colon cancer, you can use this. So whenever you want to stage colorectal cancer, you have to do a CT scan of the thorax, abdomen, as well as the pelvis. So CT scan of the thorax, abdomen, pelvis, this is a standard means of staging colorectal cancer. Now patients with colorectal cancer require magnetic MRI for local staging. So coming back to the option, coming back to the questions. So I had told you that this is true. That is, it is performed by CT and MRI both, right? So this is true for rectal cancers because in the rectum you are going to use MRI, but in if it is in the proximal part, you will be using only CT scan images. So in this option, supposing if you are going to get this same question in the exam, your answer will be helpful in pathology outside the colon, right? You have to choose one, but both options are almost correct. So moving ahead, in case of elective surgery of CS sigmoid colon, which of the following should be done? Now, whenever you're going to plan, whenever you plan a surgery, usually you would have seen during your internship that you usually have to write in the pre-op orders that you have to, the patient has to be shifted to the OT with a particular antibiotic, right? So now whether this antibiotic should be used, should not be used, as the additions of BL and LF change, they keep on changing. So there is no, these guys can't make up their minds basically whether you should use prophylactic antibiotics or they keep changing it from edition to edition. So you need to know what is given in the current edition. So in the current edition, it says that if you want to do an elective colorectal surgery, you have to memorize this basically. You have to give pre-op mechanical bowel preparation. That is, you give the patient you have to give the patient something to drink which will wash out all the which will prepare the bowel. Basically, it will remove all the feces, right? So you give a pre-op mechanical bowel preparation. That is, you ask the patient to drink something. You also will have to give pre-op oral antibiotics. So why do you give pre-op oral antibiotics is because it is said that the advantages of pre-op oral antibiotics is it will reduce the chances of surgical site infection, it will reduce anastomotic leak, it will reduce post-op ileus, the risk of resurgery and mortality, right? And along with this, should you do anything else? So you will give pre-op mechanical bowel preparation. That is, you ask the patient to drink a liquid which will cause all the contents to be flushed out. You will give oral antibiotics. Do you give IV antibiotics? Yes. So IV antibiotics, just like any other surgery, are given at the time of induction of anesthesia. Why at the time of induction of anesthesia? Because uh, so when the patient is being induced and then after subsequently when you're operating, when you're handling that tissue, there is high chance that the quantity of antibiotics in the blood will be at its highest. So the best time to achieve that would be to give antibiotic at the time of induction. You will also ask the patient to bathe preoperatively, right? Okay, so moving ahead, transmural inflammation with skip lesions in colon are characteristic of. Okay, before that, so in the previous topic, I just discussed very briefly about colon cancer. If you want to know for each, so whether the treatment of ascending colon cancer, transverse colon, since it is a very huge topic, and because of lack of time, I've discussed only very briefly today. For the entire discussion, you have to again go to the app. So transmural inflammation with skip lesions in colon. What is this transmural? Transmural means the entire thickness of the GIT is involved. Okay, I'll just take a technical break. After the break, we'll resume from this session, this question. So now let us resume. In this question, we'll be discussing the differences between ulcerative colitis and Crohn's disease. Now, this is a very important topic, and examiners love to ask the differences between the two. So, if you want a full discussion of this inflammatory bowel disease, because of lack of time, I could not discuss it. For that, again, you have to look at the app. So, let us discuss this particular question. Transmural inflammation with skip lesions in the colon are characteristic of. The answer is Crohn's disease. So, transmural means the entire thickness of the bowel is being involved and there are skip lesions. So, basically, Crohn's disease, it can happen anywhere from the mouth to the anus, right? And there can be skip lesions. So, there might be an area of pathology followed by a normal area, then again a pathological area. But ulcerative colitis, as the name suggests, it usually the rectum is almost always involved and it extends up to the colon. Okay. So let us look at the differences. So let us look at the parameters for the differences. So diarrhea is a common finding in Crohn's colitis and it is common in ulcerative colitis as well. Rectal bleeding is less common in Crohn's colitis but is almost always seen in ulcerative colitis. So patients who have ulcerative colitis, they will come to you with symptoms of passing blood during passing stools or even passing blood otherwise. Then the cramps. So cramps are more severe in Crohn's colitis than in ulcerative colitis. Why is that? So one way of remembering it is because in Crohn's colitis, it is the entire thickness. That is, it is a transmural inflammation. Because of that, the cramps are are moderate to severe. Whereas in ulcerative colitis, it is usually mild to moderate. Palpable mass is present at times. Again, why? Because the entire thickness is involved, right? In ulcerative colitis, it's not usually seen unless and until the pathological part of the ulcerative colitis, it has transformed into malignancy. So, what about anal complaints? So, now anus is usually spread in ulcerative colitis. There is no absolute, but it is less common. So, it is infrequent. But in Crohn's colitis, you will get fissures, fistula. So, anal complaints are very common in Crohn's colitis. So, ileal disease is common in Crohn's. It is rare. It is actually not seen in ulcerative colitis, as the name suggests. Ulcerative colitis it is basically colon and rectum. So the ileum can be involved, but it is very rare and it is because of backwash ileitis. So nodularity, fuzziness is not seen in Crohn's. It is present in ulcerative colitis. Skip lesions are seen. Skip lesions are not seen. These are continuous lesions. Then when you look at Crohn's colitis, you will see linear or cobblestone fissures, right? But in ulcerative colitis, you will see collar button ulcers. So this is a difference between the two. You have to remember this. Cobblestoning ulcers are present in Crohn's colitis, whereas in ulcerative colitis it is collar button ulcers. Toxic dilation, that is toxic megacolon, is it is rare in Crohn's colitis. It can happen in ulcerative colitis. So it is among between the two, toxic megacolon is more common in ulcerative colitis than Crohn's disease, right? So anal fissure, fistula abscess, obviously it is common in Crohn's. Rectal sparing. So in rectum, the rectum is usually not involved in Crohn's, but it is almost invariably involved in ulcerative colitis. And granular mucosa is seen in ulcerative colitis, whereas the ulceration is superficial in ulcerative colitis, as the name suggests. It is ulcerative colitis, so it is universal ulcer. But in Crohn's, it is linear, deep, or scattered. So in Crohn's colitis, you will see something called a string sign of Cantor. String sign of Cantor. Right. This is what you can see over here. This is the string sign of Cantor. So this is an image of the mucosa. And now let us look at the extra-intestinal manifestations. So the external manifestations of ulcerative colitis, you can get arthritis. Arthritis is typically involving the large joints. It is a polyarthropathy, right? So it affects the knees, ankles, elbows, wrists. You will get sacroiliitis, ankylosing spondylitis, sclerosing cholangitis. This sclerosing cholangitis, it can progress to cirrhosis, hepatocellular failure. Then cholangiocarcinoma, erythema nodosum, pyoderma gangrenosum, uveitis, episcleritis, right? So here you can see the lead pipe appearance. lead pipe or pipe stem colon. This is because of the haustrations are normally present in the colon, right? But the haustrations are absent. So you can see it is smooth over here, right? So this is seen in ulcerative colitis. Then this is the collar button ulcers. What you can see over, these are the collar button ulcers. This is the collar button ulcer. Okay. In Crohn's disease, you can see something called a rose thorn appearance. This is the rose thorn appearance. So when you zoom into this image, you can see over here that supposing you say this is the colon, you can see small spicules, just like a rose thorn. Now let us look at the complications of stoma. Known complication of stoma, example colostomy are prolapse, yes, stenosis, yes, retraction, yes. So the answer is all of the above. Now again, like I told you in the morning session about always and never. So always is always incorrect, never is never correct. Likewise, uh, whenever the option all of the above is given, if you want to guess, you can, as a last resort, you can pick that as the answer. It is usually correct. Anyways, let us look at the complications. So stoma complications are poor location. Supposing if you have not sighted the stoma properly, so you are not bringing it out in the place where you intended to bring it out. If it retracts means it is going back inside. Or when you brought it out, you've not sutured it properly. You've not you've not sectioned the colon properly at the site of stoma. That can cause ischemic necrosis. So detachment, abscess formation, opening of the wrong end. So instead of the proximal part, you bring out the distal part. In the skin, what happens? There is, since the skin is going to be exposed to biliary, the bowel contents, it is going to cause excoriation and dermatitis. And systemic complications, it can be a high output complication. High output means lot of output is coming out. That can be an early or a late complication. Late complications on the other hand are of the stoma. You can have prolapse, you can get stenosis, parastomal hernias, fistula formation, gas, odor. Again, this is a very extensive topic. I'm trying to cover it as much as possible in today's final dash session, but the app has the entire topic. So peristomal skin, you can get parastomal varices, you can get dermatosis and cancer. So irritation is going to happen immediately, right? That is excoriation. But dermatosis, cancer, cancer because of irritation, or parastomal varices are going to happen later. So what is, let us look at the types of colostomy. So this is a loop colostomy. In loop colostomy, as you can see, a loop of bowel is being brought out, right? Loop of bowel is being brought out. Here you can see the proximal opening, you can see the distal opening. Then Hartmann's end stoma. So this is the procedure of choice in um, sigmoid volvulus, for example, or maybe in the emergency. Emergency, you can do a loop stoma also. But anyways, Hartmann's end stoma. In this, the distal stump, it is sutured, it is stapled or sutured close. Proximal part is brought out as a stoma. So what is a double barrel colostomy? Double barrel colostomy. So here, just like the double barrel of a gun, um, the stoma will have two openings. Now you might think that this is similar to a loop stoma, but in a loop stoma, the bowel is in continuity, right? Here the bowel is not in continuity. You can see a gap over here. So the proximal part is the colostomy. The distal part is just a mucus fistula. That is, it is only mucus is going to come out, nothing else. So you have to explain the procedure properly. You have to motivate the patient, and it should be preferably be through the rectus abdominis, because that will prevent. It is a very snug fit in the rectus abdominis. It prevents prolapse. It prevents hernias also. It should be through flat surface of abdomen. Supposing if the patient is obese and you're going to place it below the below his pot belly or her pot belly, the patient cannot see it. If the patient can't see, the patient can't take care of it. Then it should avoid skin creases, scars, bony prominences. So in a stomal prolapse, here you can see that the stoma, I mean, it is protruding out, right? Here you can see a parastomal hernia. So in this portion, the bowel loops are seen to be coming out. So here you can see this is the muscle, right? This is the sheath. So ideally, only one stoma should be coming out of here, right? Ideally, this is the scenario. But in parastomal hernia, what happens is you can see a bowel loop also. So you can see a bowel loop over here. Then skin excoriation, stomal necrosis, stoma retraction, where it is going. This is the opposite of prolapse. It seems to be going inside. Now, what are the causes of intestinal obstruction? The most common cause is iatrogenic adhesion. So, causes of intestinal obstruction can be either dynamic or it can be adynamic. Dynamic means the bowel is contracting vigorously to overcome the obstruction. In adynamic, there is no actual obstruction, so it is not contracting vigorously. So, in dynamic, it can be intraluminal, intramural or extramural. As the name suggests, intraluminal is within the lumen. So, supposing there is fecal impaction, a foreign body, a bezoar or a gallstone ileus. Intramural is within the wall of the bowel, so it can be a stricture, a malignancy, an intersusception or a volvulus. Extramural is outside it. So, for example, if the patient has bands, adhesions or a hernia. Adynamic is if there is paralytic ileus or pseudo obstruction. These are examples. Okay. All are true about radiological features of the intestinal obstruction except. Okay. So, let us look at the radiological features of intestinal obstruction. So, first let us look at the threshold levels. So, when do you call it to be obstructed? So, for small bowel it is 3 centimeter, cecum it is 12 centimeters, proximal large bowel it is, so it is 3 centimeters, 9 centimeters, proximal bowel is 12 centimeters, distal large bowel is 6 centimeters. So, it is all multiples of 3. Okay, then should you take an erect X-ray or should you take a supine X-ray? Now, the new edition of Bailey and Love says that there is no need to take an erect X-ray. You're going to just take a supine X-ray. Now, on an erect X-ray, you're going to see air fluid levels. On a supine X-ray, you're going to see dilated bowel loops, right? Again, I've discussed this in extensive detail in the app. Here, I'm just touching at the finer points. So, in a supine X-ray, when the patient is supine, bowel loops tend to become dilated, right? So, when the bowel loops become dilated, you need to know the measurements. That is why I've given this over here. Ileum is 3 centimeters, cecum is 9, proximal colon is 12, distal colon is 6, right? Okay. So, now coming back to the options. Small intestines are said to be dilated if the loops of bowel have a diameter of more than 3. This is true. Large bowel are said to be dilated if they are more than 5 centimeters. Cecum, if you remember, was 6 centimeters. Sorry, 9. Proximal bowel was 12 and distal was 6. So, large bowel are said to be dilated if they are more than 5 centimeters for distal bowel. That is true. I had told you 6 centimeters, but some books write 5 and 9 centimeters for proximal bowel. This is also true. Then volvulus and mesenteric ischemia have characteristic signs on abdominal film. This is wrong. Why is it wrong? See, sigmoid volvulus, you might see a coffee bean appearance, you might see a characteristic appearance, but mesenteric ischemia is what? Mesenteric ischemia is something like a heart attack, right? Because there is a diminished supply to the, like in myocardial infarction, you have decreased blood supply to the heart muscles. Similarly, in mesenteric ischemia, you are going to have diminished blood supply to the bowel. That diminished blood supply will not be seen on an X-ray. You want to look at the abdominal vessels only, and the vessels are best seen in an angiography, right? Okay. Next. So this is the answer. This is false. Let us look at the last option. The absence of air fluid levels on plain supine radiographs does not rule out the presence of an obstruction. This is true. Now, air fluid levels are seen only on erect X-rays, right? So, if you do a supine X-ray, you will not see air fluid levels. But if air fluid levels are not seen, that does not mean that obstruction is absent, right? Okay. So, let us look at the investigation of choice. In acute mesenteric ischemia, the investigation of choice is an angiography. Chronic mesenteric ischemia, it is you have to go higher up, right? So, you're going to do a aortography. And for mesenteric vein thrombosis, you're going to do a CCT scan. Next, what is this Good-Sol's rule? So, in this Good-Sol's rule, so in this image, the patient is in the lithotomy position, right? So, this is the lithotomy position. The patient is lying down like this, right? And this is the anal opening. So, this is the anal opening, and here they have this broken line is dividing it into two halves. So, you have the anterior half and the posterior half. Now, if the fistula is basically um, an epithelial line tract between a fistula is a tract connecting two epithelial line surfaces, right? So, which are those two epithelial surfaces in a fistula-in-ano? One is the skin, that is outside part, normal skin, and the second one is the anal mucosa, right? So, if these two openings are present, if the external opening is present, I'm sorry, I'm stammering. What I meant to say is, supposing if this external opening is present anterior to the dotted line, that is the anterior half, the track of the fistula is going to be straight, right? So, supposing if the external opening is at 9 o'clock, you're going to have the internal opening also at 9 o'clock. But for the posterior half, what happens is, no matter where the external opening is, it is always going to be a curvilinear track, and the internal opening will always be at 6 o'clock. That is called Goodsall's rule. But there is one exception. Supposing if in the anterior half, if the external opening is more than 3 centimeters, then the track is going to be a curved one and enter uh, posteriorly at 6 o'clock. So, exception to Goodsall's rule is when it is 3 centimeters, right? Now, Park's classification, you are going to have 4 kinds of fistula. So, one is the intersphincteric type. This is the most common. 2 is the transsphincteric. 3 is suprasphincteric. 4 is extrasphincteric. I remember it by the mnemonic ITSI. Right. So, how do you, I mean, easy mnemonic is site, but when you remember site, the sequence gets disrupted. So, one comes first, so it is ITSI. So, what is a pantaloon hernia? Pantaloon hernia is also called a dual hernia or a saddlebag hernia. So, both options are correct, and it means it is in an inguinal hernia, that the hernia contains both a direct as well as an indirect component. So, let us look at some other types of hernia. Gibbon's hernia contains a hydrocele. Berger's hernia is in the pouch of Douglas. Becklard's hernia is femoral hernia through opening of the saphenous vein. Usually, femoral hernia does not happen in the saphenous vein, right? It is going to happen in the medial most, that is in the lymphatic compartment. But if it happens through the opening of saphenous vein, it is going to be called a Becklard's hernia. Amy and A for Amy and A for appendix. Litters contains Meckel's. Rectus is only a circumference, that is a part of the bowel wall. Medal is a W loop. Ogilvy hernia is hernia through a defect in the conjoint tendon just lateral to its insertion with the rectus sheath. Stammer hernia is what I discussed in the morning, that is in the retrocolic GJ, in the transverse mesocolon, that is Stammer's hernia. Peterson hernia, on the other hand, is hernia under the Roux-en-Y of a Roux-en-Y gastric bypass. Again, all these surgeries, all these hernia, these are all given in a very good detail in the test and discussion, that is on the app. Now, let us look at the topic of ureteral duplication. Now, a 9-year-old boy presents with abdominal pain and recurrent UTI. Fine. IVP, that is an intravenous pyelography, reveals duplication of left ureter. So, what is the most likely site of ectopic opening? Now, um, just note two. I'll just give you the very salient points of this topic. This duplication of ureter, it is being asked commonly, it is asked frequently in the last few years. So, now let me draw, supposing say this is the urinary bladder. This is the urinary bladder, right? I'm talking about males. So, here you have the internal sphincter, right? You have the prostate gland over here. This is the prostate gland, and here you have the external urinary sphincter, right? So, these are the ureters. Now, this is the urethra. So, this is in males. In females, there is no prostate, right? In female, there is no prostate, so there is only one sphincter. Now, whenever there is duplication of ureter, what happens is, in males, the duplicated part, it is always going to, let me use a different color actually. The duplicated ureter, it is always going to open distal to the, sorry, it is always going to open proximal to this external. So, this is the external sphincter, right? In males, the duplicated ureter will always be proximal to this external sphincter. So, if it is going to be present proximal to the external sphincter, will the patient be continent or incontinent? The patient will be continent, right? So, there will be no incontinence. On the other hand, in a girl, it is going to be distal to this sphincter. So, in a girl, males, females. So, in a male, patient is continent. In female, the patient is incontinent. All right. This is one thing that you need to know. So, if a 9-year-old boy presents with duplication of left ureter, that means the most likely site of ectopic opening would be where it is proximal to the external sphincter. So, if you look at all these options, the answer is prostatic urethra. Prostatic urethra is that part of the urethra which is present in the prostate gland substance, right? And that is proximal to the sphincter. So, the answer is prostatic urethra. Now, the other options, that is this BCD, these are all present distal to that. So, these are all ruled out. So, a male will always be continent, a female will be incontinent. Now, let me tell you a few more points. So, basically, see, if this is the kidney, right, this is the bladder. Now, you have two ureters. So, you have upper one and you have the lower one. Now, the rule, there is a rule called the Weigert-Mayer rule. It is called the Weigert-Mayer rule. This rule says that the upper moiety, that is this red one, which is the upper one, this is going to open distally or more caudal, right, than the lower moiety. That is the Weigert-Mayer rule. That is one aspect. One more thing that you need to know is, so if there are two moieties, that is you have an upper moiety and a lower moiety. In this, you have to remember there is a rule, or the upper one obstructs and lower refluxes. So, easy way to remember this is like, imagine if you are, say, in your department, or if there is any hierarchy, if the people on top are obstructing the people below, the low people will rebel, right? So, upper obstructs, lower refluxes. So, what is the composition of a staghorn calculus? A staghorn calculus, you can remember it by the mnemonic CAMP. So, it contains calcium, ammonium, magnesium, phosphate. The most common types of stones in gallbladder, the most common is cholesterol. Supposing if in the options there is an option given was, if it is a mixed stone given in the option, that is the answer. Pancreas is calcium carbonate, kidney is oxalate, primary bladder stone is ammonium urate, secondary bladder stone is uric acid more than struvite, that is uric acid is more common, struvite is the second most common. Prostate is calcium phosphate, salivary gland is calcium carbonate. Again, all these stones, the pathology, everything about these stones that you should know for a NEET point of view has been discussed in the app. Okay. What is the management of 4 centimeter size renal staghorn calculus? So, now let us look at some sizes. So, now if the stone is less than 5 millimeter, it will pass on its own. That is, no treatment is required. If it is 5 to 8 centimeters, if it is 5 to 8, it will not pass on its own. And for these patients, you can give a try. It may pass on its own. I'm sorry. You might give a trial, right? But usually these patients require removal. Now, supposing if it is more than 8, it definitely requires removal. So, what treatment will you give? If the stone is less than 1.5 centimeter, right, then you will be doing extracorporeal shock wave lithotripsy. That is this. If this is done for less than 1.5 centimeter, right, then supposing, say, if it is more than 2 or 2 to 5, 2.5 centimeters, you will be doing a PCNL if it is more than 2 centimeters. Now, PCNL basically what does it mean? It means again, this is a very extensive topic. I have discussed all these options, all these modalities in good detail in the app, but here I am just discussing briefly. PCNL is basically percutaneous nephrolithotomy. So here you're going to make, you don't have to do a laparotomy. You localize which part of the kidney has a stone. You go by the percutaneous route. You open the pelvis and the renal pelvis, and you extract the stone. This is for more than 2 centimeters. If PCNL fails, then you will be doing open pyelolithotomy, right? But you will always, obviously, you will go for the minimal invasive option first. So for a 4 centimeter size stone, the answer is a PCNL. So percutaneous nephrolithotomy involves removal of renal stones by creating a tract between the skin and the pelvic ileal system. So you use fluoroscopy, you locate the stone and you establish a tract. Once you establish a tract, you dilate the tract, you use a series of dilators, you place a working sheath in the tract, and then if you cannot extract the stone on its own, you first fragment the stone. How do you fragment the stone? You have to give some energy to it. You will give usually ultrasound plus pneumatic plus laser energy. Then you remove the fragments by irrigation. Then you will keep a nephrostomy tube also for some time. So indication for this is if it is more than 2 centimeter, if it is in the lower porenal stone with an anatomy that is unfavorable for ESWL. That means even if you break the fragments, or either you cannot access that part for ESWL, or even if you break the fragments, it can't get drained out. Okay. Yes, this is important. You have to know what is miniaturized PCNL. This is again given in the new edition of Bailey and Love. Miniaturized PCNL, as the name suggests, you're going to use smaller access tract. So in standard PCNL, the access tract is more than 28 French, right? But in miniaturized PCNL, you're going to use less than 22 French. Okay. Next, what are the causative factors of transitional cell carcinoma? Now, if you look at the histological subtypes of bladder cancer, you're going to get three most common types. One is the transitional cell carcinoma, which is also called urothelial carcinoma. Why is it called transitional cell carcinoma? Because the epithelium of the urinary bladder and the distal urinary tract, it is of a transitional epithelium, right? And this is the most common subtype. It is more than 90%. You can also get squamous cell carcinoma. Squamous cell carcinoma is usually because of a some irritation. That is, there is a chronic inflammation, and secondary to that chronic inflammation, you're going to get squamous cell carcinoma. So, for example, you can get indwelling catheter, stone, schistosomiasis, or there is also a primary adenocarcinoma. Now, these three are the most common primary subtypes. Fourth one is metastatic. So, among the primary adenocarcinoma, what does that mean? So, primary adenocarcinoma, it usually originates in the urachus. Urachus, just like you have the patent, you have the Meckel's diverticulum due to a patent vitreointestinal duct. Similarly, there's a duct which connects the umbilicus to the dome of the urinary bladder. That is called the urachus. So, if it originates in the urachus, it gives a adenocarcinoma. Or supposing if you've excised the bladder, or if you've reconstructed the bladder, if you've created a new urinary bladder via reconstruction stage, so you used an ideal conduit. So that ileum, it is going to be exposed to urine constantly. There you will see adenocarcinoma. Or augmentation, enterocystoplasty, bladder extrophy, repair. So what are the causative factors for transitional cell carcinoma? Um, transitional cell carcinoma is all the traditional risk factors. So that is smoking, naphthylamine, schistosomiasis, all three. Actually, if you have to choose one, I will not. If I have to choose only one option, then I would choose smoking. Okay, but otherwise, both smoking and naphthylamine is true. Schistosomiasis, it can cause both. It can cause both transitional cell cancer and squamous cell cancer. But in the exam, if I have to choose one, then I would choose squamous cell carcinoma. So, what are the risk factors for for urinary bladder cancer? So, smoking, occupational exposure to aromatic hydrocarbons such as dyes, paints, etc. Environmental carcinogens, for example, there is arsenic in the drinking water. Then chronic inflammation of the bladder. So if there is an indwelling catheter or stone or schistosomiasis. Schistosomiasis, please remember, it predisposes to squamous cell carcinoma. You have to choose, since it is a NEET PG revision session. So you remember schistosomiasis is common cell carcinoma. Certain drugs like what is phenacetin? Phenacetin was the first analgesic produced by our form of medicine. That was discontinued because of the risk of bladder cancer. Then cyclophosphamide and also pelvic radiotherapy. Now, when you want to divert the bladder, how do you do it? It is best done at the ileum. So, why do you need this urine diversion? What is it? So, supposing if you have removed the urinary bladder, you are going to need some route by which the urine can come out, right? So, in those patients, you will require a urinary diversion, right? Because since you've removed the urinary bladder, an alternate drainage is obviously necessary. So, what are your options? Most commonly, what is done is an ileal conduit. In an ileal conduit, what you do is you take a loop of ileum, you detach a portion of it. So that part of the ileum is detached from its both proximal and distal part. Then bowel, you anastomose it, you forget about the bowel. This ileum, which is then which has been detached, you do not remove it from its mesentery. The mesenteric attachment is still there because it requires some blood supply, right? And you fashion that to create a urinary bladder, and you implant the ureters into that part of ileum. Okay. What is an orthotopic bladder? A pouch is created using small or large bowel that is then anastomosed to the patient's urethra. So, just like an orthotopic liver transplant, orthotopic means you're going to place it in the same part as where the original organ was, right? So, in in an ideal conduit, the ileum, it need not be present in the pelvis, right? You can you can place it in the abdomen, and one part of the ileum, it comes out as in from where the urine drains out, right? But in an orthotopic bladder, you need to, whatever new bladder you are fashioning or creating, that needs to be present in the same place as the original organ. Original organ was present in the pelvis, right? So an orthotopic bladder will be placed in the pelvis only, and that will be then anastomosed to the patient's urethra. So what is the main difference between an orthotopic bladder and a ileal conduit? So in an ileal conduit, there is a stoma via which the urine is coming out, whereas in an orthotopic bladder, the patient is going to urinate via his penis, just like he was urinating before. So among this orthotopic bladder, Studer pouches, memorize the name. Studer pouch is most widely performed. So then you also have something called a continent cutaneous diversion. So when you use a segment of ileum, right, either the urine can drain continuously, or since patients do not prefer that, you can create a continent diversion. That means when basically in patients who require urethrectomy, or when the urethra is non-functional, right, then there is no point in doing an orthotopic bladder transplant. So, orthotopic bladder surgery, you will be then placing the loop of ileum, that is the neo bladder, is going to be placed in this somewhere in the abdomen, right? And you're going to create a continent pouch. So you create a Studer pouch, and then there are two ways in which the patient can empty it. One is whenever the patient feels that, or in periodic intervals, the patient can insert a small tube into it and it can drain out, or the patient can use the appendix. So via the appendix, the urine can come out. Lastly, you have the ureterosigmoidostomy, that is the main stoop pouch, in which the sigmoid colon is detubularized and refashioned into a pouch into which the ureters are inserted. Again, among all these surgeries, the most commonly which is done is the ileal conduit. So again, I have given a few diagrams. You can go through this. See, this is the ileal conduit. This is the ileum, right? And here the ureters are being implanted into the ileum, right? So is this an orthotopic or not an orthotopic? This is not orthotopic, because the urine is going to come out via this, right? Now in this, what is happening is, this is the sigmoid colon. So ureters are being implanted into the sigmoid. So in these patients, they are going to both defecate as well as they are going to urinate from the anus only, right? Okay. Now this is a very important topic, Gleason score. Gleason score has changed completely in the new edition of Bailey and Love. So, what is this Gleason score? So, basically, let me just tell you what is given in the new edition of Bailey and Love. You can answer questions based on that. So, Gleason score is used to grade prostate cancer, right? So, in this, you are going to sample two areas from the prostate, right? So, when you sample two areas from the prostate, each area is given a score between 3 and 5. So, the score can be 3, 4 or 5. Since you are going to take two areas, minimum score will be 3 into 6, 3 into 2 equals 6, maximum score will be 5 into 2 equals 10, right? Just know this, you know the scoring, that is enough. Actually, I'm expecting a question from Gleason score in this. Neat. Okay. A 49-year-old man suffering from CA prostate was x-rayed. He showed areas of sclerosis and collapse of T10 and T11 vertebra in x-ray. What is the spread of this cancer to the above vertebrae? So, whenever cancer is spreading, even in CA breast, when the cancer is spreading from breast to the thoracolumbar vertebrae, it is going to be via the Battson's intervertebral plexus. Same in the prostate also. So, the internal vertebral plexus of veins, also known as the Battson's perivertebral plexus, this is responsible for spread of cancer to the vertebra. So, what are the most commonly involved nodes in the urological organs? Now, penis is inguinal, testis is pre-aortic and para-aortic. Again, there is a difference between left and right. Left is going to go into the para-aortic, right is going to go into the aortocaval, right? And your urinary bladder is going to go into the obturator, prostate is going to go into the obturator. Now, you might have noticed that testis is not going into the inguinal lymph nodes. So, in this, I have to mention one more. CA scrotum. Scrotum is going to go into the inguinal lymph nodes, but testis is going to go into the uh, pre and para-aortic lymph nodes, right? Because the testis descends from the scrotum, that is why it gets its blood supply and lymphatic drainage also over there. So, in hypospadias, all are seen except. So, what is hypospadias? So, in hypospadias, normally the see, this is the glans penis, this is the urethral opening, this is the corona glandis, this is the shaft of the penis. So, normally you have the urethra at the tip of the penis, right? In hypospadias, what happens is the urethral opening is present in the under surface, that is in the ventral surface of the penis. So, here do I have an image? Yes. So, it is on the ventral or in the under surface. So, it can either be glandular, that is on the glans penis, coronal, that is on the corona glandis, penoscrotal, that is at the junction of the penis and the scrotum. It can also be perineal. So, in this hypospadias, you are also going to get chordae. Now, chordae means bending of the penis. Now, the penis, it usually bends in the direction of pathology. So, since the urethral opening is on the undersurface, that on the ventral aspect, therefore, in hypospadias, you will get ventral chordae. You will never get dorsal chordae. If you just, I mean, the other options you need not remember, because the examiner wants to know whether it is dorsal or ventral chordae. So, the answer is dorsal chordae. So, hypospadias, there are three characteristic features which you should know. One is an ectopic ventrally located urethral meatus. Two is ventral penile curvature chordae. Three is an incomplete dorsal hooded prepuce. Basically, the prepuce, that is the foreskin, it is not present where the urethral opening is there, right? So, it's going to be present only in the dorsal part that looks like a hood. So, what is the treatment of hypospadias? So, distal hypospadias, the treatment is, I remember this by the mnemonic Tipu Sultan. So, it is tubularized incised plate urethroplasty. Proximal hypospadias with chordae has a two-stage repair. In the first stage, you're going to correct the penile curvature, and in the second stage, you're going to repair the urethra. So, when you repair the urethra, that is called a Dennis Brown urethroplasty. Now, whenever so in many cultures, for example in Muslims or Jews, they circumcise the penis, right? They circumcise their boys. But supposing if, say, if the baby has hypospadias, then circumcision is contraindicated. This is because that foreskin will then be the repair surgery. Now, when is the repair surgery done? It is done before the age of 18 months. So, moving ahead, the recommended treatment for preputial adhesions producing ballooning of prepuce during micturition in a 2-year-old boys. That means, so when do you get preputial adhesions? Preputial adhesions basically means the adhesions between the foreskin and the glans penis. So, because there is adhesion, you are not able to pull the foreskin down. That is called phimosis. Now, for phimosis, in children, usually there is physiological phimosis. So, as the child grows old, 5 years, 6 years, till puberty, in fact, you can wait and you can slowly, gradually bring the foreskin down, right? So, in that scenario, when you bring the foreskin down, what happens is, sorry, if it is physiological adhesion, you can gradually bring the foreskin down. That is physiological phimosis. Now, sometimes you have to do a surgery immediately. That is, even in a 2-year-old boy, you might have to do a surgery immediately. When is that? When there is something called a pinhole meatus. So the meatus is very, very small, like a pinhole, and because of this pinhole meatus, you are going to get ballooning of prepuce during micturition. So in these children, there is no need for waiting for the child to grow older and for the physiological adhesion to come down on its own. You can do a circumcision. So in infants and young boys, circumcision is usually performed at the request of parents for social or religious reasons. For example, in Muslims and Jews. So other indications are true phimosis, if there is lichen sclerosis, recurrent attacks of balanoposthitis, recurrent UTI with abnormalities such as high-grade vesicouretic reflux. If the foreskin does not retract during intercourse, so the sexual pleasure is less, that is why. Or there is an abnormally tight frenulum. Now, what are the contraindications of circumcision? So, one is a hypospadias, second is a penile curvature, that is chordae. Third is the buried penis. Next, what is this Prenz sign? Now, uh, so young males, there is an emergency, urological emergency in young males, which is called torsion of testis, right? Torsion of testis, what happens is there is a twisting of the test. The testis is hanging from the cord and cord contents, right? So the testis, it usually twists about that cord. So when the testis twists about that cord, it is going to cause a decrease in the vascular supply, right, of the to the testis. So because of that, the testis might become gangrenous. So that is called torsion. Now, so in torsion there will be pain. You will also get pain in a condition called epididymo-orchitis, right? So when these patients come to you, you need to be able to differentiate clinically between an epididymo-orchitis and a torsion, right? It is important. See, the best gold standard investigation is to do a Doppler. But if a Doppler is not available, or supposing say you're working in a setup where there is no Doppler at night and the child comes at night, I mean the patient comes at night, then what do you do? So you need to be able to do it to differentiate clinically. Now, why it is important is because, see, whenever the patient comes with torsion, right, the testis is in danger of gangrene. And since it is common in young males, so if imagine the stigma of removing testis in a young male, right? So your idea is to save the testis. Now the thing is, if Doppler is not available, how do you do it clinically, right? And so clinically how you do it is, so there is something called a Pren sign. Basically what happens is you lift the testis. When you cup the scrotum and you lift it up. When you lift it, if the pain increases, it is torsion of testis. So on lifting, if pain increases, it is torsion. If pain decreases, it is epididymo-orchitis. Now, obviously, you have to memorize it, but let us try and understand it. So now, Nowadays we're living in an era of AirPods, but prior to this we were using earphones. I don't know how many of you have used earphones, but when you use earphones, if you recall, whenever you place earphones in your pocket, right, the earphones, it gets there are loops forming, and you always wonder how did this part of how did one end of the earphone go into the other end, right? Same thing in torsion also. So basically, when you're supposing if you hang your earphones from the wall like this, right, will there be any chance of one part of the earphone going into another, creating loops? No. But in your pocket, it is getting coiled up, right? So basically, what I'm trying to say is, when there is no space, that is in your pocket, it is going to get coiled up, and when it is hanging down, it is not going to get coiled up. So similarly, in torsion, what you do is you cup the test and you lift it up. When you lift it up, the space decreases, and the test, it undergoes further coiling. So that is positive Prince sign. Whereas in epididyma orchitis, um, when you lift it up, since it is not because of torsion, the pathology causing pain is something else, you will not get pain. So now what is this image? Okay, the importance of detecting torsion clinically is, see, the treatment for torsion is orchidectomy, right? And now the books teach that supposing if the patient is coming to torsion, you're not sure whether there is torsion or not, whether there is torsion not present, you still have to explore the scrotum, right? You examine the, because seeing is believing, because it is testis. Testis is a very vital organ, right? So the thing is, you explore the scrotum and then you examine the testis. Supposing if the testis is normal, then if you want to just be sure, you can just anchor the testis using non-absorbable sutures between the tunica albuginea and the scrotal wall, right? If it is gangrenous, you remove it. Now, why should you explore the scrotum and see it? Because sometimes what happens is the testis, it torts and it detorts. That is, torsion occurs and detorsion occurs. This is occurring spontaneously. So when torsion is occurring, the patient gets pain, and the testis, it undergoes detorsion simultaneously. So the pain will come down. So that might be happening, right? So you have to always explore. Now, there are some anatomical abnormalities which predispose of testis to undergo torsion. What are these? So this is normal attachment. If you look at this A image, this is normal attachment. It is like this, right? Now, supposing you have a high investment of tunica vagina. So this is the high investment. This will that is this image B. This is predisposing to torsion. Second, if there is any pedicle between the testis and the head of the epididymis, that also will cause predisposed to torsion. So this pedicle which is present, the same thing might be present for sigmoid volvulus. The same thing, if you recall, might be present between the tip of the Meckel's diverticulum and the umbilicus. So whenever that is present, it gives scope for whatever is present below it. That is, wherever there is a pedicle present, it gives scope to whatever organ is present below it to twist. So torsion is a surgical emergency. The earlier the surgery is performed, the better the prognosis. Golden period for saving the testis is 6 hours. That means if the testis can survive on torted blood supply for 6 hours. Beyond 6 hours, the testis will not survive. So if there is any doubt, you still do a exploration. Now, if the testis looks viable, do an orchidopexy by 3 non-absorbable sutures. Supposing it is unilateral case, do you examine the other side also? Yes. The contralateral testis should be examined. It should be fixed even if it is normal, because whatever is abnormalities predisposing that one side to get torsion, it will usually be a bilateral anomaly. So again, a very interesting topic and a very important topic. Swelling in testis, what is the investigation of choice? So for swelling in testis, the investigation of choice is a USG. Why can you do a FNAC or can you not do an FNAC? So let us discuss why you should not do an FNAC. Now, the testis, it descends from the posterior abdominal wall to enter into the scrotum, right? As the testis descends, it takes along with it its blood supply, its lymphatic drainage, right? So imagine the testis like this young, sorry, it is like this rich spoiled girl who, when is getting married and leaving her parents' home to go to her husband's house, she's taking all her servants, all her belongings along with her. So because the testis is present in the posterior abdominal wall, it is going to get its blood supply from the testicular artery, which is from the aorta, it is going to get it is going to drain into the inferior vena cava or the left renal vein, right? But on the other hand, the scrotum is getting its blood supply from either the internal iliac or the pudendal arteries, right? But scrotum, that's not the case. This is because of its embryology. Now, uh, so the scrotum is going to drain into the inguinal region. Testis is going to drain into the pre-aortic and para-aortic lymph nodes. Now, when you do an FNAC of a testicular tumor, you are going to leave tumor seedlings in the skin of the scrotum, right? Scrotum is going to drain into the inguinal lymph nodes. So, that is going to cause upstaging of the tumor, right? That is why for testis swelling, FNAC is contraindicated and you will be doing a USG. One more advantage is that testis is present very, very close to the skin surface, right? So when you do a USG, you will get very good detail. Fine, because there is, see, for example, whenever there is a retroperitoneal structure, like for example, the pancreas or the kidney, in those patients, there is an intervening bowel loop, or in obese patients, there is so much of fat which obscures the view. But in testis, you're going to get a very good view when you place the probe right on it. So that is the reason why in testis, the investigation of choice is USG. Now, supposing, say you do want a biopsy, so now you are operating on the patient, and when you examine it, you think that fine, there might be a, so basically you've done a USG, you think there is a suspicious lesion, so you open it. When you open it, you are wondering whether there is a lesion present or not, right? So how do you confirm that time? Can you just remove that part? No, there is no role for that. In testicular tumors, the minimum surgery done is always an orchidectomy, right? So you will clamp the cord and cord structures, fine. You will excise the testis, send it for frozen section, or if not the entire testis, I'm sorry, I made a mistake. If you do not want to remove the basic surgery done is an orchidectomy, but if you don't want to remove the entire testis, if you just want to remove a part of it, in that case you will clamp the cord and cord structures. When you clamp the cord and cord structures, it is called a Shaver-Seuss maneuver. So you place a soft clamp across the cord and cord structures. Whichever part of the testis looks doubtful, you will then excise that part. You will send it to the pathologist via frozen section. They will examine it, and supposing if they say it is negative, you leave it. You release the clamp. But supposing, say, if the pathologist says it is malignant, then you do a orchidectomy. Okay. Before that, so when you do an orchidectomy, you will do a high inguinal orchidectomy. Actually, I like this topic of testicular tumors. When I was doing my MS, so we had to do these presentations, right? So one of my topic was testicular tumors, and I mean I prepared very well for that topic. So I like this topic a lot, and it's very, very interesting because there are a lot of concepts which are there in this. So then there is something called a high inguinal orchidectomy. So what I'm trying to tell you is, whenever you do an orchidectomy, where do you excise the cord and cord structures, right? So see, on the left hand side you have the paminiform plexus of veins, right? So you have multiple, you have it on both sides, you have multiple venules. On the left you have paminiform, which is more prominent, so you have these multiple venules, right? And these gradually, so you have multiple, these gradually they form two, and gradually it forms only one. So you have to do a high inguinal orchidectomy, as you do it as proximal as you can, because here if you do a high inguinal orchidectomy, what happens is, since there is only one vein which is involved, there is a lesser chance of you leaving the tumor behind. Supposing if you were to do an orchidectomy over here, right? Some tumor cells, because you're manipulating the tumor because of whatever reason, it might be present over here, here, here. That will cause recurrence. So you do it as proximal or as high up as possible. So with this, I have come to a conclusion of the urology part of our today's discussion. I have tried to, I mean, I've taken or maybe in some chapter, I've taken two topics from that particular chapter. So I've touched very briefly on this. Again, for a full discussion, please look at the app. We'll take a break. We'll resume after the break. So let us continue. An 80 kg male with bilateral upper limb, right lower limb with perineum burns 3rd degree. What is the amount of fluid that is required in the first 8 hours? So first let us look at how do you calculate the percentage of burns in this patient. So for percentage of burns, you have the Wallace rule of nines, right? In the Wallace rule of nines, you have each upper limb to be 9%, right? So upper limb, since there are two upper limbs, you will get 18%. 1 minute. Okay, each upper limb, some problem with the pencil. Each upper limb is it is 9%. Then each lower limb is 18%. The anterior thorax torso is 18%. Posterior also is 18%. Head and neck is 9%, and the genitalia is 1%. So together these will give you 100%, right? So in this patient, the patient's bilateral upper limb. That means it is 9 plus 9, that is 18%. Then right lower limb, that is again 18%. Right, and perineum burns, that is 1%. Perineum is nothing but genitalia. So these are so the patient has 37% burns, right? So what is the amount of fluid that is required? Now let us look at this fluid resuscitation in detail, because it's a very important topic. Now what are the indications of IV fluid resuscitation? It is 15% of the total body surface area in adults. It is 10% in children. It is slightly lower in children for obvious reasons. Now, what is the most commonly used fluid? It is Hartmann solution or Ringer's lactate, right? And this solution is administered by what is known as the modified Parkland formula. So, in this modified Parkland formula, how do you, what is it, how do you calculate it basically? So, it is the percentage burns of total body surface area into weight in kgs into 4. So, in our patient, he is an 80 kg male with 37% burns. So, it is 37% burns into 80 kg into 4. So, okay, before that, since the pencil is working again, let me discuss the Wallace rule of 9. So, upper limb is, okay, again the pencil is not working. Okay, anyway, so if you calculate this 37 into 80 into 4, you will get 1 that is 11840 ml, right? So this 11840, you have to, so this is the total volume that should be given over 24 hours, right? Out of this 11840, half of it, so divided by 2, that is approximately 5920 ml. So half will be given over 8 hours and the second half will be given over 16 hours, right? So the amount of fluid that is required in first 8 hours is 5920 ml. So when is this 8 hours? What do you mean by these first 8 hours? So supposing if a patient suffers burns at say 11 a.m. in the house, and by the time he comes to the hospital, it is say 2 p.m. So will your 8 hours start from 11 a.m. or 2 p.m.? So it starts from 11 a.m. So when the patient comes, so from 11 a.m. if you have 8 hours, it is up till 7 p.m. right? Patient has come to you at 2 p.m. So between 2 p.m. to 7 p.m., that is within 5 hours, you have to give half of that fluid. All right. And the second half over the next 16 hours. Now, along with giving this Parkland formula, supposing it is a child, children also need maintenance fluid. Okay. So children also need maintenance fluid. Now, so what is the maintenance fluid that is given? So in children, you're going to give uh, DNS as maintenance fluid. So please note the difference. Parkland formula, you're going to give Ringer's lactate, and in children, if you're going to use maintenance fluid, you'll be giving dextrose normal saline, right? And what is this? How much will you be giving it? So for the first 10 kgs, you will give 100 ml per kg. For the next 10 kg, you will be giving 50 ml per kg. And for each kg over 20 kg, you will be giving 20 ml per kg. So supposing if our child is 25 kgs. That means for the first 10 kgs, if you give 100 ml per kg, so it would be 100 into 10, that is 1000 ml, right? Plus 550 ml per kg for the next 10 kgs. So it will be 15 to 10, that is 500 ml, plus 20 ml for each kg over 20. Since he is 25, so that is 5 kgs more than 20 kgs. So 5 into 20 will be 100. So you have to give this child 1600 ml of DNS extra, that is apart from what you're going to give him Ringer's lactate via the Parkland formula, that is RL, you're going to give 1600 ml DNS extra. Okay. Next, so this was the discussion of crystalloids. Now let us look at colloids. So if you're giving colloids, um, what do you give and how do you give it? So the most commonly used colloid is human albumin solution. Okay, before that, why do you need to give colloids? So if you recall a bit of physiology, and you would have read this in pathology as well. So whenever there is a blood vessel, there are certain factors which cause the fluid in the blood vessel to move out, and there are certain factors which cause the fluid in the blood vessel to stay inside the blood vessel, right? So what is causing it to move out is hydrostatic pressure, right? What is causing it to stay in is the colloid oncotic pressure. This oncotic pressure is via plasma proteins, right? So because of this oncotic pressure, it is allowing the fluid to stay within the blood vessel. Now supposing, say, if a patient has lost a lot of fluid, right, has lost a lot of blood, along with the blood plasma proteins are being lost. So if plasma proteins are being lost, whatever is remaining in the whatever plasma protein is remaining in the blood vessel, in the vasculature rather, that is not enough to keep the blood vessel, to keep the blood within the blood vessel. Are you getting my point? So supposing, say, if a patient has lost a lot of blood, the patient is also losing plasma proteins, right? When the patient is losing plasma proteins, whatever plasma protein is remaining in the vasculature, that may not be enough to keep the remaining blood within the vasculature. That also might start um, traveling out of the blood vessel. So if you want to make sure that fluid, that is blood, is present within the blood vessel, you also have to maintain the oncotic pressure, that is you have to maintain the level of plasma proteins. So that is done by transfusing colloids. Most commonly used colloid is human albumin solution. And if you want to give colloids, see, for crystalloids you have to give crystalloids, that is IV transfusion of crystalloid. It should start from the moment of burn, right? But as far as colloids are concerned, these should be administered after the first 12 hours, administered after the first 12 hours post burns, because um, it is after the first 12 hours that there is massive shift in fluid which drives proteins out of the cells. Now, just like in crystalloids you had Parkland formula, in colloids you have something called the Muir and Barclay formula. This Muir and Barclay formula, it will estimate the amount of fluid that needs to be infused during the first 36 hours post burn. So if I just make the differences between the two, so you have the Parkland formula and you have the Muir and Barclay formula, right? In Parkland formula, you are going to give RL. Here, the most commonly used is human albumin. This Parkland is from the time of burns. Muir and Barclay, it will be after 12 hours. Parkland is how much food you are going to give in the first 24 hours. Muir and Barclay is the first 36 hours, right? Parkland is crystalloids. This is colloids. Along with this, you have in children, you have the maintenance fluid, that is the DNS, right? Okay. So what is the formula for this? The basic formula of this is you're going to be giving percentage burns of total body surface area into weight in kgs into 0.5. So in Parkland, you are multiplying it by 4, that is percentage burns into weight in kgs into 4, whereas in Muir and Barclay, you are multiplying it by 0.5. Basically, you are dividing it by 2. Okay. So, percentage burns of into weight in kgs into 0.5. So, in our patient, supposing if the question was asked for this patient in an 80 kg male with 37% burns, how much will you give? So, there is 37% burns with 80 kg. Again, problem with pencil. Sorry about this. 37 into 80 into 0.5. This would be approximately 1480 ml. One minute, I'll just take a technical break. I'll just come back. Sorry about the interruption. So, as far as colloids are concerned, you will in our question, in our patient, the person burns was 37, right, with a weight in kg of 80 kg into 0.5. This would be, let me just calculate, approximately 1480 ml, right. So, 1480 ml is one portion. So now 6 portions are given in total over 36 hours. So, like I told you, Parkland formula is for 24 hours, Muir and Barclay is over 36 hours, right. So, one portion is 1480 ml. So, 6 portions are given in total over 36 hours. That means over 36 hours, you are going to give the patient 1480 into 6. That is, you will be giving the patient 8880 ml of colloids. So, 8880 ml of colloids along with this 11840 ml of crystalloids. So, how do you give this? You are going to give this totally over 36 hours. So, like in Parkland, I told you it was 8 hours and 16 hours. In Muir and Barclay, how do you do it? So, since it is 36 hours, you divide it into 3 segments. So, first 12 hours, then second 12, and third 12. So, in first 12 hours, you will give one portion every fourth hourly. So, you will give every fourth hourly. All right. In the next 12 hours, you will give one portion every sixth hourly. Here, you are going to give only one, that is Q12H. So, fourth hourly means here you are going to give 3 portions. Here you are going to give 2 portions. Here you are going to give 1 portion. So, together it would become 6 portions. Okay. What is the method of breast examination depicted in the image? Now, for some reason, examiners are very fond of asking this question. I myself, I think this is a very ridiculous thing. Supposing if any human being were to be told, you examine this breast, they would examine the breast, they would examine all areas and give it. So, I mean, since doctors, especially surgeons, we have such boring lives, we like to make simple things complicated. So, anyways, a group of surgeons, they decided to publish a paper where they were examining 4 methods of palpation. All right, and they wanted to see which among these methods of palpation is the best method. That is, uh, so so they had 4 groups of patients. They were, each group were being palpated in a particular manner, and then they were seeing at to what extent these breast lumps could be picked up in which method. They were comparing it to an imaging investigation. So anyway, it doesn't matter what I think, what matters is what they want to ask in the exam. So what are these 4 methods, right? So you have to know these 4 methods. So first one is the dial of a clock method. This is the most accurate method. So it turned out that this dial a clock was um, the best method. So I don't know if any of you, I don't think any of you would have seen those old age wala phones, the old era phones where, if you had to dial a clock, it would be 1 2 3 4 5 and you have to keep on coming down. So basically that is why this dial of a clock, it gets its name from, or it could also be because it is like a face of a clock. So it is 1 o'clock, 2 3 4 5 6. So you go from the center of, that is from the nipple, you go outside to 12 o'clock, again you come back, you go from center to 1, then center to 2, center to 3. So in this manner, if you palpate the breast, this would take at least 5 or 10 minutes. The patient would think that you want to feel her breast. If you're taking 12 minutes or 10, 20 minutes to palpate somebody's breast, anybody would be suspicious. Anyways, so first method was the dial of a clock method. Second method was so what they're showing here, this is the vertical strip method. So in vertical strip method, you go from one part, you cover this strip, then you cover one more strip, then you cover one more strip. This is the vertical strip method. Third method is the quadrant method. So in quadrant wise method, you divide the breast into 4 quadrants. You nicely palpate one quadrant, then nicely palpate the second quadrant, you move on. Okay, this is the concentric method where you can see they're coming around in concentric circles. So you start outside and you gradually you circle, you zero in onto the nipple areolar complex. So anyway, these are the 4 methods of palpation. So for some reason, examiners are very fond of asking this question. I myself feel it is a ridiculous question. Anyways, so there are just these 4 methods that you need to know, and please look at this diagram carefully because, like I said, they're very fond of asking this. Okay, I have decided to choose only one more topic from this breast in today's presentation because again it is impossible to cover the entire topic chapter of breast in a 1 day session. So since that was a trending topic, the methods of palpation, they ask it very frequently, and one is CA breast, especially the staging part. So for the remaining part of breast, please look at the app. I have discussed the entire chapter of breast in extensive detail in the test and discussion series. So in breast CA of 6 centimeter, that is the size of the tumor is 6 centimeter, there is fixed ipsilateral axillary lymph node. What is the TNM staging? So like I told you earlier in the day, as far as breast is concerned, size matters, right? So how does size matter? Let us look at TNM staging of breast. So TX means the tumor cannot be assessed. T0 means there is no evidence of primary tumor. TIS is ductal carcinoma in situ. T1 is up to 2 centimeters. T2 is 2 to 5. T3 is more than 5. T4, again it has 4 parts, T4A, T4B, T4C, T4D. When as far as T4 is concerned, the size does not matter. So T4A is T4 basically is on what neighborhood structures are being invaded. So let us start from inside and come outside. So T4A is invasion of chest wall. T4B is skin involvement. So that could be in the form of ulceration, satellite nodules, QD orange. So please note that dimpling of skin or nipple retraction is not considered as a part of TNM staging, right? So it is ulceration, satellite nodules and pewdy orange. Why is dimpling of skin not a part of TNM staging? Because see, dimpling of skin or retraction of nipple is because of involvements of ligaments of Cooper, right? It is not because of skin involvement. That is why that is not considered in the TNM staging. T4C is both A and B are present. T4D is inflammatory carcinoma, right? So our patient who has a tumor of 6 centimeters, this would be T3. T3 is more than 5 centimeters. So our tumor, our patient is T3. This is the only option. So that is the answer. Anyways, let us look at the nodal classification as well. NX means the regional lymph nodes cannot be assessed. N0 is there are no regional lymph node mets. So how do you say that there are no lymph node mets? Either via imaging or via clinical exam. That is by triple assessment. You've determined that there are no regional lymph node mets. What is triple assessment, by the way? Triple assessment, you're going to use three things. First, you're going to use history and clinical examination. Second, you're going to use an imaging. So you can use a USG or a mammography. Third thing, you will use a biopsy. That is, you will be using a core needle biopsy or maybe an FNAC. Core needle biopsy is preferred. FNAC is no longer done in C average. It is not mentioned because the investigation choice is a core needle biopsy. So anyways, so when there are no regional lymph node mets, either via imaging or via clinical examination, then it is called N0. N1 means it is ipsilateral level 1 or level 2 axial lymph nodes. All right. N2 means it is ipsilateral level 1, level 2 that are clinically fixed or matted. What is the meaning of matting? So, lymph nodes, they can either occur as discrete swellings. Supposing if there is pericapsular invasion and these lymph nodes tend to stick to one another, then it will cause what is called matting. So, if it is ipsilateral level 1 or 2 axial lymph nodes that are clinically fixed or matted, that is N2, or the ipsilateral internal mammary nodes in the absence of axillary lymph node mets. That is, so N1 was only axillary lymph nodes, it is discrete. N2 means matted nodes of level 1 and 2 in the axilla, or if even if there is no axillary lymph node mets, but there is mets in the internal mammary nodes, that is N2. N3 is ipsilateral level 3. So the moment level 3 comes into picture, it becomes N3. So if you remember, notice over here, level 1 and 2 only. So the moment 3 comes, it becomes N3. Along with this level 3 lymph nodes, you might have level 1, 2 or ipsilateral internal mammary nodes with level 1, 2 mets or mets in ipsilateral supraclavian lymph nodes. Basically, along with level 3 being involved, that is only level 3, that is level 3 along with 1 or 2. 1 or 2 is optional, may be present, may not be present. Along with this level 3, so the first criteria, let me just be clear, ipsilateral level 3. Second is, see, this is plus minus 1, 2. So this plus minus 1, 2 doesn't really matter. Next is ipsilateral internal mammary with 1, 2. So if it is only internal mammary, it becomes N2. But the moment internal mammary with 1 and 2. So there are 3 groups which are involved. So again, it is, and this is a way of remembering it. Or supposing if it is in the supraclavicular lymph node, ipsilateral again, it becomes, see, it is all ipsilateral. Supposing if you have a tumor on the right side and you have mets on the left side, then that lymph nodes on the left, then it would become a metastatic cancer. It will become M1. So everything is always ipsilateral. So if it is a supraclavicular lymph node, plus or minus axillary or internal mammary. So basically, the moment level 3 is involved, it is N3, or if 3 groups, that is internal mammary plus with 1 and 2, or if it is supraclavicular lymph node, if these are involved, it becomes N3. M0 is no mets, M1 is distant mets present. So let us go back to the question. 6, and we already know it is T3. Fixed ipsilateral axillary lymph nodes. Okay, so this could be N1 also, but since, okay, since it is fixed, sorry, since it is fixed means it is matted, so it has to be N2. That is why this is the answer. Okay, next, the occurrence of hyperthyroidism following administration of supplemental iodine to subject with endemic iodine deficiency goiter is known as what? So basically just note two very important lines, short and sweet. So supposing if you give iodine and the patient gets hyperthyroidism, then it is called Jod Basedow, right? Supposing if you give iodine and the patient gets hypothyroidism, then it is called Wolff-Chaikoff. All right. I mean, if I till now I have not been able to come up with a mnemonic for this, I have always memorized it. If you know a mnemonic for this, please write it in the comments. It will help me also. And whenever I take a subsequent class, I will always credit the student who gives me a mnemonic. So, if it causes hyperthyroidism, it is called Jod Basedow. If it causes hypo, it is called Wolff-Chaikoff. Okay, radioiodine is preferred in treatment in which patients? So let us look at the options. In young patients, no. Why no? Because in young patients, since they are fit for surgery, it is better to do surgery, right? It is better to remove the thyroid gland rather than do a radioiodine therapy. So radioiodine is radioiodine is not preferred in young patients. Second, pregnancy, obviously no, because it can cause damage to the fetus. In recent onset toxicity, this is a silly option. So the answer is post surgery for papillary thyroid cancer. So this is one example of a question where I do not know, I may not be knowing what the exact answer is, but I can still uh, take an educated guess. Okay. Now, which isotope of iodine is the radioactive form? So normally you have iodine 123. This is not radioactive iodine. The higher the number, the more chance of radioactive. That is how I remember it. So iodine 131, this is radioactive. So what are the uses of this radioactive iodine? First, iodine 131, it can be given to deliver tumoricidal doses of radioactivity directly to the thyroid tissue, both benign and malignant. That is, you ask the patient to swallow the iodine gets concentrated in the thyroid gland, and that is how the tumoricidal dose is being given. Next, indicated for patients with gross extrathyroidal extension of tumor regardless of size. That is, if there is extrathyroidal extension of tumor, doesn't matter whether the primary tumor is small or big, but once there is extrathyroidal extension, you will give it, or tumors which are more than 4 centimeter. So either small tumors with extrathyroidal invasion or big tumors. By big I mean more than 4 centimeters in the absence of other high risk features such as extrathyroidal invasion. Next, to treat residual disease in the thyroid bed. This is what they are telling in our question. So, for supposing say you've discovered that the patient has papillary thyroid cancer. Papillary thyroid cancer it spreads by lymphatics, right? So there is extensive intra-gland spread as well. So because of that, you want to do a total thyroidectomy. Now, once you've done a total thyroidectomy, just like in mastectomy, where it is not possible to remove all the cells of the breast. Similarly, even for thyroid gland, it is not possible to remove all the cells of the thyroid gland. So, no matter how good a surgeon you are not God, and some amount of cells might be present, right? So, how do you destroy that? Again, what you do is after the surgery, you will give radioactivity to that area. How do you radioactive to that area? You tell the patient to drink iodine. When the patient drinks iodine, it gets concentrated in those cells, and those cells get destroyed. Next, to treat metastatic disease. So, radioactive iodine, that is RI, is used after total thyroidectomy only for patients with known distant mets. Because again, if there's a distant mets over there, there are thyroid cells which are present, which will again concentrate the iodine, and it will be susceptible to radiotherapy. Okay. Next, it is the mainstay of Graves' disease treatment in North America. So for Graves' disease in North America, that is in USA and Canada, they usually use radioactive iodine. But in India, we don't use radioactive iodine. We optimize the patient, and totally we um, we directly do a total thyroidectomy. It is most often used in older patients. So, like I told you, younger patients, they have fitness for surgery, right? So, if a surgeon can remove a gland, why will that surgeon give that patient to the radiotherapist? Why should the radiotherapist make the money? The surgeon should make the money because the surgeon is qualified to do that, right? Anyways, jokes apart, so it is most often used in older patients with small or moderate size goiters, or those who have relapsed after medical or surgical therapy, and those in whom antithyroid drugs or surgery are contraindicated. So, in older patients, there is a high likelihood of the patient not getting fitness for surgery, right? So, surgery might be contraindicated. In that scenario, you will give radioiodine. Now, what are contraindications? So, very simple, common sense basically. In women who are pregnant or who are planning pregnancy within 6 months, because then that would damage the fetus, and breastfeeding women, because then that can it can get excreted in the breast milk swallowed by the infant. So, what are the relative contraindications? Relative contraindications are young patients. So, in North America, that is in USA and Canada, it is given in young patients, right? In Graves' disease, whether young or old, it is given in patients with Graves' disease. But in India, uh, young patients relative contraindication, right? Because we believe that it's better to remove the thyroid gland. Patients with thyroid nodules and patients with ophthalmopathy. So moving ahead, keloid scar is made up of. So from the chapter of wound healing, I have just chosen this one topic where you need to differentiate between a keloid and a hypertrophic scar. So what are the characteristics of keloid and hypertrophic scars? So let us look at the differences rather. A keloid is rare, whereas a hypertrophic scar is common. So tomorrow when you guys take up surgery and you operate on your patients, you will notice that maybe 1 month or 2 months after surgery, the patient comes back to you and tells that at the site of that, he tells that the wound is healed properly, but at the site of incision, that is where the scar should have been present, he can see that the scar is slightly elevated and he's worried whether it is normal or not. So you will tell that patient that it is a hypertrophic scar. There is no need to worry, and if you give some time, it might not it might it most likely will decrease on its own. So hypertrophic scar has no ethnic uh, predisposition. It is seen across all races, whereas ethnic groups, it has a role to play in keloids. So for example, in African Americans, Asians, Hispanics, it has a role to play. Prior injury, yes, it is common to both hypertrophic as well as keloid scar. So, like I told you, post-operatively, you will see a hypertrophic scar, but keloids, usually, for example, these people who are getting the ears pierced, right? So, women who get the ears pierced, you might have seen that they are more prone to develop keloids. Then, what is the any sites up there's any predisposition. So in keloids, usually there's a triangle from both your tips of shoulders up to the xiphis sternum. If you take this as a triangle, this is very prone to keloids. Apart from that, so you have the neck, the chest, ear lobes, shoulders, upper back, right? So these are predisposed to keloids. But for a hypertrophic scar, there is no site predilection. It can occur anywhere. Now, what about genetics? So in a keloid scar, it is autosomal dominant with incomplete penetration. So what does this penetration mean? Penetration basically it means the extent to which a gene is expressed. So if it is not, so maybe a person has the gene, but it is not getting expressed. So that means it is incomplete, or it means no penetration. But if the patient has the gene and it is expressing, then it is called penetration. Anyway, so keloid autosomal dominant with incomplete penetration, whereas hypertrophic scar does not have any genetic link. So when does this keloid scar occur, and when does a hypertrophic scar occur? Hypertrophic scar usually occurs 4 to 6 weeks post injury. Okay, but a keloid scar, it need not occur immediately after surgery. So maybe the patient has had an injury, the patient has undergone a surgery, but the patient is completely symptom free, right? He has an interval where he is completely symptom free, but after many years, when the patient has forgotten about the trauma, when the patient has forgotten about the surgery, he might develop a keloid at that particular point. So what are the symptoms of keloid scars? In keloid scars, you will get pain, pruritus, hyperesthesia, and growth beyond wound margin. So I should actually started with this. The fundamental difference between a hypertrophic scar and a keloid is a hypertrophic scar, the growth is not beyond the wound margin. So supposing, say, this is a laparotomy. If the hypertrophic scar occurs, it occurs only in this area, in the scar. If it were to be a keloid, on the other hand, it can become quite big, right? So a keloid is a growth which is beyond the wound margins. That is in fact the definition of keloid and hypertrophic scar, whereas a hypertrophic scar is, it respects the wound confines. So it is raised, it respects wound confines, and there might be some amount of pruritus. So can it regress? A keloid scar does not regress, whereas a hypertrophic scar, like I told you, initially you can reassure the patient. So regression is frequent and it is even spontaneous. So what about contractures? Contractures causing keloids are rare, but contractures in a contracture, if you see hypertrophic scar, that is quite frequent. So when you look at the histology, actually in both hypertrophic scar and keloid, you will see dense collagen. See, it says keloid scar is made up of dense collagen, right? This might be true even for hypertrophic scar. But so let us look at the histology. So in in a keloid, you will see hypocellular, thick, wavy collagen fibers which in random orientation. This is a collagen fiber, this is a collagen fiber, this is a collagen, this is a, these are random oriented. Whereas in a hypertrophic scar, again you will see dense collagen, but these are in parallel orientation. Okay. Now, what is the treatment of hypertrophic and keloid scars? So, first is pressure. You can use a local mold or an elasticated garment. You can use a silicone gel sheeting. You can use intralesional steroids, that is triamcinolone. You can excise the scar and inject steroid. You can excise the scar, and after you've excised the scar, you might give post-op radiation in the form of external beam or brachytherapy, or you might do an intralesional excision, whereas only within the lesion you excise it. Next is laser, which can reduce redness, and you can also use vitamin E or palm oil massage. Now again, this wound healing is, so there are other topics also in wound healing. For example, phases of wound healing and factors affecting wound healing, both of which are important topics. But again, you have to look at the app if you want to know those topics. So is this, so let us look at some images and tell whether these are keloid or hypertrophic scars. So here you can see that keloid is happening at the site of ear piercing, right? This is a, and it is, the scar is quite big. It is not respecting the wound confine. So this is a keloid. This you can see it is, it looks like a laparotomy wound, and it is respecting the wound confine, right? So this is a hypertrophic scar. Okay. The body water content in percentage of body weights is lowest in. What they're trying to tell you is, they've given you 4 options and they want to tell you which of them will have the lowest body water content. So now let us look at this. So which are the, so there are many tissues in a body, right? Which are the tissues which contain water, which are the tissues which do not contain water? So lean tissues such as muscle and solid organs, they have a higher water content than fat and bone, right? So muscle and solid organs, for example, say liver, kidney, spleen, these have higher water content than fat and bone, right? Therefore, a young lean male has a higher proportion of, have a high proportion of body water, that is the proportion of body weight as water is higher than in an elderly or obese persons, because a young person will have more muscle mass than an elderly, right? And obese person has fat, fat does not have much water. So therefore, females are curvy, females have more fat. Therefore, females, they have a lower percentage of total body water because they are curvy and because they have less muscle mass and more fat, that is they are curvy. So coming back to our question, body water content in percentage of body weight is lowest in. So in a well built man, they have good amount of water. So this is false. Fat woman, let us consider the option. Well nourished child, no. Fat man. So fat woman and fat man, both of them have, both of them will have, both of them have lesser water content. But among these, if you have to choose one, you will choose fat woman. Why? Because a woman has lesser muscle mass than a man. So let us look at this image where we are discussing the chemical body composition of a normal 70 kg male. Okay. So in a 70 kg male, actually this topic is, it may or may not be asked in the exams, but it is kind of complicated. That is why I chose this question, because I wanted to simplify this topic for you. So if you take a 70 kg male, this patient is considered to have fat and a lean body mass. So lean body mass in 70 kg should be around 57 kg. Fat is 13 kg. Now again this lean 57 kg, it has a lot of components. So it has protein, which is 12 kg. It has water, which is 42 kg. It has fat, which is 3 kg. Right. So this is what they have given over here. They have given this fat, protein, water, minerals in this diagram. Anyways, so when you look at this, so now again I have to look at two more things in this. One is, if you look at the water content, this water mass, it is divided into intracellular and extracellular. Okay. Out of 42 kgs, around 28, that is 2/3 is intracellular and 14 kgs or 1/3 is extracellular, right? And just like water, it has two compartments. Similarly, protein will also have two compartments. So proteins can be present in the muscle and non-muscle. What do you mean by non-muscle? So for example, the organs, liver, etc. So muscle. So which one? Which do you think has more proteins? So muscle has 4 kg. Non-skeletal muscle is 8 kg. Right. And among this mineral mass, most of the minerals are present in the bony skeleton. Okay, moving ahead. What is the best guide for the management of resuscitation? The best guide, so basically when a patient has come to casualty with shock, or when if you admitted a patient with shock, maybe in wards or maybe in the ICU, how do you, and you're giving resuscitation, how do you know whether the resuscitation that you're giving is of adequate amount or whether it is low, whether it is high? So you will calculate the urine output. So the best guide for the manual resuscitation is, so it is a very simple method. You just insert a Foley's catheter and you will get to know what is the urine output. So when you are monitoring a patient with shock, what all do you monitor? So you have two headings. One is the minimum, the bare minimum that you should monitor, and one is the additional modalities. So the minimum monitoring are, you have to connect pulse oximeter, ECG, blood pressure. Blood pressure is non-invasive. That is, you will apply that BP cuff, so the sphygmomanometer, and the urine output. Additional modalities are, you will use the central venous pressure, invasive blood pressure via an intra-arterial line, cardiac output. So normal IV cannula which you're putting is in the veins, right? But if you want to know the invasive blood pressure, you have to put an intra-arterial line. Next is the base deficit and serum lactate. How do you calculate this? You will do an ABG, that is, you will do an arterial blood gas, and you will calculate both. Next, how do you monitor certain organs? So, for systemic perfusion, base deficit lactate and mixed venous oxygen saturation is required. Again, I've discussed all this in extensive detail in the app. For lack of time, I can't go into specific detail of each of these investigations as much as I want to. So, let us move on. For muscles, you will use near infrared spectroscopy, tissue oxygen electrode. For the gut, you will use three things. You will use a sublingual capnometry. You will use a gut mucosal pH, and you will use a laser Doppler. For kidney, you will use urine output. That is a clinical method. There is no need in the kidney to go into to investigate, because urine output is the best parameter. For the brain, if you want to judge clinically, you will look at the consciousness level, and if you want to investigate, you can either do a tissue oxygen electrode, or you can use you can also use a near infrared spectroscopy. Okay, so we'll take a break here, and after the break, we shall resume. So let us resume. So moving on, after 30% loss of blood volume in road traffic accident, what is the next management that is to be given? So before that, let me tell you a very easy way of remembering the grades of shock. So you have grade 1, 2, 3, 4. This is just like a tennis match. Grade 1. So in tennis, the score is 15 love, 30 love, 40 love, and game. So same way, this is less than 15%. This is 15 to 30%, 30 to 40%, and more than 40%. So after 30% loss of blood volume in RTA, what is the next management that is to be given? So you'll be giving only IV fluids. So I'll discuss the answer, but see, IV fluid is a cardiac stimulant, dopamine, vasopressor. These will be given only in specific indications, right? Since nothing is given in the question, we will not be giving anything else. So let us look at the fluid therapy. Fluid should be given before other therapies such as inotropic or chronotropic agents are given. That means before you give a vasopressor or any catecholamine, before that you have to give fluids. First line therapy is IV access and administration of IV fluids. IV fluids are usually given via green IV cannula, and usually you will give you will put two IV cannula. Why? Because in shock, if you look at the pathophysiology of shock, there is peripheral venous collapse, right? So if peripheral venous collapse occurs, then you may not be able to find an IV line later. So that is why you will be so that is why you'll be putting a green IV cannula, because if you put a green, I mean, if you put two cannula, I'm sorry, if you put two cannula, even if there is venous collapse later on, you still have, I mean, you can give fluids basically. So the ideal replacement fluid is one that approximates the fluid by the underlying cause of shock. That means if the patient is vomiting, you will give replace fluid which resembles the vomitus, that it contains gastric acid or bile. So you will want to give potassium or sodium. Um, Similarly, if the patient is losing blood, you have to give fluid which is just like blood. That is, so like replaces like. So basically, the patient losing blood, you will give blood. Now, obviously, blood can't be given to all patients, and blood is not available immediately also. So till you get blood, what do you give? Till you get blood, you will give the patient crystalloids. So if blood is being lost, ideal replacement fluid is whole blood. However, due to obvious reasons, you cannot always use blood, right? And it is transfused only when it is specifically indicated. So what fluids will you use? So you will use crystalloids. In this, you can use NS and Ringer's lactate. Hartmann solution, Ringer's lactate is the same thing. So crystalloids are routinely used for resuscitation along with appropriate electrolyte supplementation. Advantage is that it is cheaper, it is easily available. You can also use colloids, for example, human albumin. This, if you recall, it is also used in the Muir and Barclay formula of Burns. You can also use other commercially available products. The problem with colloids is, however, it is more expensive and it has a worse side effect profile. You can also use hypotonic solutions. For example, you can use dextrose. So these hypotonic solutions, these are poor volume expanders, right? So since it is a poor volume expander, you will use these hypotonic solutions in the treatment of shock only when the deficit is free water loss. So for example, if the patient has diabetes insipidus, or if the patient is sodium overloaded, that is the patient has hypernatremia, for example in cirrhosis, in such patients you will give hypotonic solutions. Now when you give these vasopressor, inotropic support, right, you will give these for specific indication only. Let us look at that. So first you have phenylephrine NORAD. These phenylephrine and NORAD, they are both vasopressors and they are used in distributive shock states. So what are the distributive shock states? You have septic shock, you have neurogenic shock, right? You also have anaphylactic shock. So if you look at the types of shock, you have hypovolemic shock, you have cardiogenic, obstructive, distributive, endocrine. In distributive shock state, that is, there is usually vasodilatation. So for examples are sepsis, neurogenic shock, and anaphylactic shock. Next, vasopressin. So vasopressin, it is used as an alternate vasopressor. So it is used when vasodilatation is resistant to catecholamines. Example, absolute or relative steroid deficiency. So, you will first give phenylephrine and NORAD only, right? Uh, Supposing if it is resistant to that, then you will add vasopressin. Also, you will use it specifically when the vasodilation is resistant to catecholamine. For example, if there is steroid deficiency. Next is dobutamine. Dobutamine is an inotrope, right? And dobutamine is used in cardiogenic shock. It is used in cardiogenic shock or where myocardial depression has complicated a shock state. So, for example, the patient in cardiogenic shock, for whatever reason, maybe there is an injury to the heart, or maybe there is an arrhythmia which is occurring. So, in that shock state, you will obviously have to treat the underlying arrhythmia. But in those patients where there is a problem, where there is myocardial depression, you will use dobutamine, right? So, for example, if there is severe shock, severe septic shock, but with low cardiac output. Okay. So, for anaphylactic shock, you will give adrenaline. For cardiogenic shock, you will give NORAD or dopamine. For distributive shock, you will give NORAD or phenylephrine. Hypovolemic shock, you will use crystalloids. For shock with oliguria, you will use dopamine. For hypoadrenal shock, you will give corticosteroids. For septic shock, you will give broad spectrum antibiotics. So, if you want to memorize, you can memorize this. So, if you memorize these few lines, these few points, you should be able to answer all the questions from this particular topic. Okay. A man is rushed to casualty, nearly dying after massive blood loss in an accident. There is not much time to match blood groups, so the physician decides to order one of the following blood groups. Which one of the following blood groups should the physician decide? So, basically, which is the universal donor? So, universal donor is O negative. Now, if you want to understand the logic behind it, so there are 4 blood groups, all of you know, A, B, AB and O. So, in A blood group, the patient has A antigen and he has anti-B antibody. In B, the patient has B antigen and anti-A antibody. So, they have antibodies to what antigen is not present. So, if it is AB, both antigens are present, there are no antibodies. In O, there are no antigens, but both antibodies are present, right? Okay, so supposing if say if so why is O negative considered to be a universal donor, since O negative does not have any anti, since so yeah, okay, I told you ABO blood group system, I forgot to tell you RH. RH, that is rhesus factor. If it is positive, that means they have rhesus factor. Negative means they do not have rhesus factor. But unlike ABO blood group, so in ABO blood group, even if you do not have the antigen, you have the antibody. But in rhesus, you may not have the rhesus factor. That is, in a patient who is rhesus negative, they do not have the antigen, but they do not have the antibody either. So that is one fundamental difference between ABO and RH blood grouping system. So, universal donor will obviously be a donor which does not have antigens. If the donor does not have antigens, when you give it to the recipient, it cannot generate a antibody response, right? And which is the best recipient? The universal recipient will be an AB blood group. Why? Because AB blood group has both antigens, it has no antibodies, right? So, universal donor will be O negative and universal recipient will be AB. In this, universal recipient, plus and minus, sorry, universal donor is O negative and universal receptor is recipient is AB blood group. So, what are the indications for transfusion of packed red blood cells or transfusion of whole blood? So, if the hemoglobin is less than 6, that means the patient will probably benefit from transfusion. So, in these patients, you have to give blood. If the hemoglobin is between 6 to 8, there is no benefit that you are going to get from transfusion if the patient is not bleeding or if you do not anticipate bleeding. What do you mean by anticipate bleeding? So, supposing the patient is going to undergo a surgery, right? I'm sorry. If the patient is going to undergo a surgery, there will be some bleeding during the surgery. So, that is some bleeding anticipated. So, these patients, they are unlikely to be of benefit I mean, if the hemoglobin is from 6 to 8, transfusion is going to be of no benefit unless the patient is undergoing surgery. This means that if routinely a patient comes to you and tells that they have a hemoglobin of 7, should you transfuse blood? No. But the same patient with a hemoglobin of 7, supposing if they are going to undergo a surgery, should you give hemoglobin? Yes. That is, should you give blood? Yes. More than 8, there is no indication for transfusion in the absence of any other risk factors. So please remember this. Next, what is the preferred time for prophylactic antibiotic administration for surgery? Now, prophylactic antibiotics are used when you are scared of some wound contamination, right? Or let us say if you're going to place a mesh, if you're going to say, supposing say you're doing hernioplasty or whatever surgery you're doing, basically, see, basically when you're doing surgery, you're going to see, skin is the best dressing, right? So when you do a surgery, you're going to make an incision in the skin, you're going to expose the basically the tissues underneath the skin will become susceptible to infection from outside, right? Or maybe say, supposing if you're going to operate on the GIT, this we discussed in a question earlier, if you're going to operate on the GIT or in the urinary tract, there are some parts of the body, so the colon is not sterile, the colon has a lot of bacteria or bowel also. So when you open that, there might be some contamination and that might cause an infection, right? So you would want to give prophylactic antibiotics. So what is the best time to give prophylactic antibiotics? It should be given at the time of induction of anesthesia. So why induction of anesthesia? That is because, so if you give IV antibiotic during induction of anesthesia, when you operate and when you are doing maximum manipulation of the organs, and that is the time when you are scared that there might be a contamination. If you have given the antibiotic during induction, that means at that crucial moment the antibiotic is circulating in the blood, and then that will therefore help to counteract the release of bacteria and bacterial products at that moment. Now, uh, let us look at the other options. 1 day before surgery, this is obviously wrong. 6 hours before surgery, this is also obviously wrong. Now, supposing there are two options at the time of induction of anesthesia and just before surgery, which one will you choose? You will still choose at the time of induction of anesthesia. Now, why shouldn't you choose before surgery? So, for example, let us say tomorrow you become surgery residents, or you would have seen during your internship also. On the OT day, in the pre-op area, there are a lot of patients waiting for to get operated, right? But many times you would have seen that even though patient is scheduled to get operated, for some reason, maybe the anesthetist is crazy, the anesthetist does not want to give a case, maybe the patient is not fit, maybe there is a genuine reason. So the OT might get cancelled, right? So in that scenario, there is no point in giving the antibiotic to that patient, right? Because you want to give the antibiotic when you're sure that the patient is getting operated. That is why the answer is induction of anesthesia. Okay. IV during surgery, it should be given IV during surgery, but it is given in prolonged surgeries. That means that you will be giving a second dose. Prophylactic dose is given at the time of induction. IV during surgery is given second dose, not the first dose. Therefore, it is not the answer. So, prophylactic antibiotics are used when there is a risk of wound contamination. As the degree of contamination increases, risk of SSI increases. So, if it is a non-prosthetic clean surgery, there is the value of antibiotic prophylaxis is low. For example, if you are doing a lipoma excision, the value of antibiotic prophylaxis is low. Supposing if you are using a prosthetic, that is, example, you are using a mesh, you will definitely use an antibiotic, right? Because even a small risk is unacceptable. Supposing if there is even a small risk and due to some reason the mesh becomes infected, that is hell both for the surgeon as well as for the patient, because for you it is for the surgeon it is difficult because it is difficult to manage. You have to do regular dressings and a lot of manpower is devoted to that. Secondly, you might have to reoperate, you might have to remove the mesh. Thirdly, you're going to get a bad name among your peers, among patients, right? So you would so with as far as a prosthetic is concerned, even a small risk is unacceptable, and you have to therefore use prophylactic antibiotics. So prophylactic antibiotics are effective in reducing the risk of infection in clean, contaminated and contaminated surgeries. So what do you mean by this clean, contaminated and contaminated? So you have clean surgeries, you have clean, contaminated and you have contaminated. Now clean surgeries are where you are not anticipating any opening in the bowel or any organ which is where bacteria might be present, that is not going to get opened. That is a clean surgery. Clean contaminant is when you're going to enter the GIT. So you make an opening in the GIT that will cause contamination, but this is a controlled opening. That is, when you make the opening in that, it is in your control, right? That is a clean contaminated surgery. A contaminated surgery is what? A contaminated surgery is where it is not in your control, and you by mistake, by an iatrogenic injury, you make a opening in the GIT and all the contents leak out. That is a contamination. Now, what is a dirty surgery? Dirty surgery is when the patient has already come with leakage of content. So, for example, say if the patient has fecal peritonitis or peritonitis, there's already some contamination from before, right? That becomes a dirty surgery. So, prophylactic antibiotics are effective in reducing the risk of infection in clean contaminated as well as contaminated surgeries. Now, if antibiotics are given to prevent infection after surgery or instrumentation, they should be used before bacterial growth becomes established. That is, they should be given within the decisive period. So, ideally, maximal blood and tissue levels should be present at the time at which the first incision is made and before contamination occurs. Tissue levels of the antibiotic should remain high throughout the operation, and antibiotics with a short tissue half-life should be avoided because then that would require repeated dosing. So, IV administration and induction of anesthesia is the best time. Now, supposing say if there is a long operation or there is excessive blood loss, or when there is unexpected contamination, you might give a second dose of antibiotic, and in prolonged surgeries you will be giving it every 4th hourly. Why do you give 4th hourly? Because tissue antibiotic levels will fall faster than serum levels. So, the antibiotic might be circulating in the blood, but it may not be present in the tissues. So, next let us move on to the topic of salivary gland tumors. So, mixed parotid tumor arises from which cells? So, as the name itself suggests, mixed parotid tumors arising from epithelium as well as mesenchymal cells, correct? Okay. So, a pleomorphic adenoma or a mixed parotid tumor is mixed parotid tumor is nothing but a pleomorphic adenoma. This is most commonly seen in the parotid gland. That is 80% of pleomorphic adenoma is seen in the parotid gland. It can also be seen in the submandibular gland in the hard palate. Now, in the parotid gland, most tumors arise in the superficial lobe and in the tail of the gland. These are both MCQ points. Please remember it. So again, here I am just describing. I'm in the discussion. I am just discussing why it is called mixed parotid tumor. For if you because of lack of time for the entire discussion, you again have to go back to the app where all the details are present. So why is it called a mixed parotid tumor on gross appearance? So when you look at the parotid, that is the pleomorphic adenoma, in the gross appearance, it is well circumscribed. That is, it is a benign tumor. It is nodular. It is firm, and it sometimes shows cartilaginous areas. So, there is a firm mass, but there are some cartilaginous areas. So, you are seeing that is why it is called a mixed tumor. Now, there is also marked morphological diversity. So, along with the firm mass, you might have glandular areas, you might have myxomatous areas, you might have solid areas, right? A capsule is usually present around the tumor, but the capsule might be focally thin or it might be absent in larger tumors. So, when you do a biopsy of this, what do you see? You see mixed epithelial, myoepithelial, and stromal components, right? Now, these parotid tumors, they are called mixed tumors because of the morphological and microscopic diversity. Because they are so diverse in appearance, they are called mixed tumors. So, when you do an immunohistochemistry, what do you see? The luminal cells, you will see CK7, that is, it expresses cytokeratin 7. Myepithelial cells will express the others, that is P63, S100, SOX10, SMA. So again, I have not gone into the details of pleomorphic adenoma. I have not looked at the treatment part and all those other parts. For that, you'll again have to look at the app. So what is ranula? Now, a ranula, okay, before that, see, pleomorphic adenoma is a benign tumor, right? So let me just tell you this also. See, the major salivary glands are what? You have the parotid, you have the sublingual, and you have the submandibular, and you have the sublingual gland, right? These are the major salivary glands. Apart from this, you have the minor salivary glands. Now, in parotid glands, in salivary glands, as the size of the gland decreases, the risk of malignancy increases. That means in these bigger tumors, risk of malignancy is lower. It is lower relative to the minor glands. In minor glands, risk of malignancy is high, right? Now, what is a ranula? A ranula is an extravasation cyst of the sublingual glands. So, there's a beautiful image over here. You can see the tongue tip, and below the tongue, that is on the floor of the mouth, you can see this nice cystic structure, right? This is the ranula, and this is a extravasation cyst of the sublingual glands. Many guidebooks, many of the older editions of BD and Love mentioned as a retention cyst. It is actually an extravasation cyst. Please do not get confused. So why is it called ranula? Because it resembles the belly of a frog, and the frog, the Greek, Latin, whatever, the name is Tigris rana, right? That is where it derives its name. So what is the treatment of this ranula? The treatment is marsupialization. Then other features are, it is a brilliantly transilluminant swelling. Which are the other swellings which are brilliantly transilluminant? You have cystic hygroma, you have epididymal cyst, spermatocele, hydrocele, meningocele, meningomyelocele, right? These are the brilliantly transilluminant swellings. So moving ahead, Saroj, a 32-year-old female from a rural background, presented with a history of chronic tobacco chewing since the age of 14. So since 18 years she has been chewing tobacco. Now she has difficulty in opening her mouth. That is, there is some amount of trismus, right? There is trismus present. So now when you think of this picture, a patient who has a history of chronic tobacco chewing and who has trismus, you will automatically think of CA oral cavity, right? So what is the most common feature of the CA oral cavity? When you do an oral examination, you will see an ulceroproliferative growth. But in this patient, when they did an oral examination, no ulcers are seen. So what is the most probable diagnosis? So if no ulcers are seen, then your diagnosis becomes submucous oral fibrosis. Let us weigh the other options. CA buccal mucosa, no. If it were to be a CA buccal mucosa, you would see an ulceroproliferative growth. That is not there, means it is not a carcinoma. Then temporomandibular joint arthritis, no. Temporomandibular joint arthritis will not be seen, first of all, in a 32-year-old female. Secondly, there is no link. I mean, they would not have mentioned tobacco chewing in the answer, in the question, if it were to be uh, temporomandibular joint arthritis. Third is trigeminal nerve paralysis, is a silly option. So let us look at this submucous fibrosis in some amount of detail. It is a chronic insidious process and it is characterized by the juxtaepithelial. So in the submucosal part, that is why it is called submucous fibrosis. Below the mucosa, there is deposition of fibrous tissue, and this happens in the oral cavity and in the pharynx. It is important because it is a pre-malignant condition and malignant transformation might be seen. So what is the pathogenesis? It is considered to be a cell-mediated immunity reaction to areca nuts. To be more specific, it is to the arecoline in the areca nuts. Secondly, it may also reflect a localized collagen disorder or it can be an autoimmune process in the oral cavity. So, lastly, the cytokines act on the mesenchymal cells to produce fibrosis, right. So, in this oral submucous fibrosis, there is upregulation of synthesis of collagen, obviously. This is obvious. There is an upregulation of synthesis of collagen. At the same time, there is down regulation of collagenase production. So, all these things together, they are um, promoting fibrosis. So, now what are the clinical features? So, it mostly affects this age group only, that is between the age of 20 to 40 years. The first symptom that the patient will usually tell you is that they are unable to eat any spicy food anymore. So, that is, there is intolerance to chilies and spicy food. Whenever they eat spicy food, there is a burning sensation. Actually, the patient may have a burning sensation continuously, that is throughout, but when they eat something which is even slightly spicy, it burns a lot. Along with that, there is repeated eruption, that is vesicles will get erupted on the palate and on the pillars, that is the anterior and posterior fauces. There is trismus. The trismus is progressive. So, it might progress to such an extent that ultimately the patient may not even able to put their finger in the mouth. So, the patient not able to brush their teeth also. So, the patient will then have halitosis, that is foul smelling breath. Now, since there is fibrosis, the patient not able to move about their tongue. The patient cannot move about their tongue. There is difficulty in speech. There is difficulty in mastication. There is difficulty in chewing. And it is a pre-malignant condition, right? So, there might be associated leukoplakia as well as squamous cell carcinoma. Now, when you examine such patients in the initial stages, there is patchy redness of mucous membrane with formation of vesicles which rupture to form superficial ulcers. This means that in submucous fibrosis, you might see ulcers, but in CA buccal mucosa, you will see an ulcer of proliferative growth. Please note the difference. In submucous fibrosis, ulcers might be present or absent, but in CA buccal mucosa, you will see an ulcero proliferative growth. Now, in later stages, when the fibrosis develops in the submucosal layers, there is blanching of the mucosa with loss of suppleness. Obviously, right? Because there is going to be some collagen deposition, the mucosa is no longer supple, it becomes fibrosed. And you can see as well as feel the fibrotic bands. So, now how do you treat it? Now, since it is considered to be a cell-mediated immunity reaction to the arecoline and areca nuts, you want to give an immunosuppressant. So, what do? You will give topical injection of steroids into the affected area. This topical injection of steroids, it might be combined with Hylase. Then you tell the patient to avoid the irritant factor. So, tell the patient to stop chewing tobacco, to stop chewing areca nuts. Now, and you improve the overall health of the patient, because the patient is going to be malnourished, right? The patient not able to eat properly. So, you treat existing anemia or vitamin deficiencies. Then you encourage jaw opening exercise, that is, you give physiotherapy. Now, surgical treatment, um, it is indicated in advanced cases to relieve trismus. So, supposing the patient not able to open the mouth at all and you want to relieve that trismus, in those cases you will be giving, you will be doing surgical treatment. Now, various surgical techniques are used, right? So, what are those surgical techniques which are used? You might be using simple release of fibrosis and skin grafting, that is one technique. The others are tongue flaps, nasolabial flaps, island palatal mucoparietal flap, radial forearm free flap. You might excise the part which is fibrosed. You might have to put a buccal fat pad graft, or you might put a superficial temporal fascia flap and split skin graft. Okay, so let us move ahead. What is this modified radical neck dissection? So, a very simple topic and very important topic. So, let us look at three types of neck dissection, right? One is radical neck dissection, two is modified radical neck dissection, three is selective neck dissection. Now, in radical neck dissection, you are going to remove all the lymphatic levels. So, traditionally, there are 5 levels of lymph nodes in the neck. Some books they might give up to level 7, but traditionally there are considered to be 5 levels of lymph nodes. So, when you remove all the 5 levels of lymph nodes, in order to do that, you have to sacrifice 3 structures. You are going to sacrifice the sternocleidomastoid, internal jugular vein, and the accessory nerve. Right. So, when you are going to sacrifice these 3 structures and you are going to remove all the lymphatic levels, it is called a radical neck dissection. Fine. Now, what is a modified radical neck dissection? In a modified radical neck dissection, your goal is to preserve at least one of those 3 structures, that is among the sternocleidomastoid, internal jugular vein, and cranial accessory nerve, that is the spinal accessory nerve, cranial nerve 11. If you want to preserve any one of these structures, then that is would be called a modified radical neck dissection. So, any modification of RND which preserves at least one of the non-lymphatic structures. So, if you are preserving a non-lymphatic structure, it is called a MRND, right. So, in MRND, the number of lymph nodes that are dissected will also be reduced, but that is immaterial. MRND is when you are preserving a non-lymphatic structure, right. So, radical neck dissection, you are removing all the levels of lymph nodes and you are removing 3 structures. In an MRND, you are preserving at least one non-lymphatic structure. And in a selective neck dissection, that is in an SND, you are preserving lymphatic compartments, that is you are preserving at least one level of lymph node. Alright, that is called a selective neck dissection. So, for example, so in both MRND and I am sorry, in selective neck dissection, these 3 are generally preserved. So, sternocleidomastoid, interjugular vein, and accessory nerve are all preserved. In MRND, at least one is preserved. In selective, all are preserved. In selective, all are preserved, and also along with since you're along with preserving all those 3 structures, you're also preserving a lymphatic level, right. So, what are the examples of selective neck dissection? So, you have supraomohyoid neck dissection. So, in supraomohyoid neck dissection, you're going to dissect levels 1 to 3. Lateral neck dissection will be levels 2 to 4. Posterolateral will be levels 2 to 5. So, moving ahead, which of the following graft is known as a Wolff's graft? Now, what are the types of graft? There is some, let me just take a technical break. Sorry for the interruption. Actually, the screen had it had hanged, so I had to discontinue. So, continuing, Which of the following graft is known as a Wolff's graft? Now, if you look at the types of graft, you have the split thickness skin graft and you have a full thickness graft, right? So, to know this, let us first look at the layers of skin. So, the skin, if you go from deep to superficial, you have the dermis. This is the dermis, and here you have the epidermis, and below dermis you have the subcutaneous fat, right? Now, dermis, it has two layers. So, deeper you have reticular dermis, superficially you have papillary dermis, and the mnemonic for remembering the epidermis layers is base shall generate lovely cells. So, stratum basalis, stratum spinosum, granulosum, lucidum, corneum. So, in a split thickness graft, as the name itself suggests, you are going to take a part of you're going to take you're going to split the skin. Skin has two layers, right? So it has epidermis and dermis. So you're going to take the epidermis in split thickness skin graft. You're going to take the epidermis plus a variable portion of the dermis. So a fraction of the dermis, right? That is a split thickness skin graft. In a full thickness graft, you're going to take epidermis plus dermis. Partial thickness graft is the same thing. So in this option, since partial thickness and split thickness mean the same thing, so obviously both these options are ruled out. So even if you do not know what the answer is, you can safely rule out these two options. Now, what is a myocutaneous graft? So you, apart from a skin graft, you also have a composite graft. So for example, a myocutaneous graft, it contains muscle plus skin. Then you have a fasciocutaneous graft. It contains fascia plus skin. You might also have an osteocutaneous graft, bone plus skin. Okay, so these are composite grafts. When it contains so skin plus something else is equal to a composite graft. Skin plus XYZ is equal to a composite graft. Now, this split thickness skin graft, so full thickness skin graft is also called a Wolff graft. Okay. So moving ahead, what is true about Marjolin's ulcer? Now, a Marjolin's ulcer is a name which is given to a malignancy which is occurring in a non-healing wound. This malignancy, it is most commonly a squamous cell carcinoma, but it can also be a basal cell carcinoma and the even the rarer types. So when this was first described, they described this in burn wounds. So a burn wound which was there for a long time, which turned malignant, they called it a Marjolin's ulcer, right? But now we know that a Marjolin's ulcer is not just seen in burns; it can be seen in any chronic non-healing wound. So here the answer is an ulcer over a scar. So marginal ulcer characteristically arises in chronically inflamed wounds or in scars. So originally described in chronic burn scars, however, it can occur in any chronically inflamed wound. So for example, a long-standing venous ulcer, chronic sinus tract, pre-existing scar, chronic osteomyelitis, vaccination points, pressure sores, and hidradenitis suppurativa. So a wound which does not heal for a prolonged period of time. So what do you mean by a prolonged period of time? To call a wound a chronic wound, that means the wound has not healed for 6 months. So if a wound is not healed for 6 months, it is called a chronic wound. And these chronic wounds, they are prone to get transformed into malignancy. So before they get transformed into malignancy, there is also a pre-malignant stage. That is, when you take a biopsy of that, you will see something which is called as a pseudoepitheliomatous hyperplasia, right? That is a pre-malignant condition before it transforms into SCC or BCC. Other rare tumors, so I told you most common is SCC, followed by BCC, followed by the rarer tumors, right? Among the rarer tumors, you can get anything. So there is no need of memorizing it, but I'm just telling you. You can get sarcoma, neurotropic, malignant melanoma, malignant fibrous histiocytoma. Anyways, if you just remember SEC, BC, that is enough. So these typically appear decades after the original injury, right? But burn scar carcinoma is usually encountered within the first year. Now there is a so see squamous cell carcinomas, they can spread by lymph, right? But Marjolin's ulcer, even though it is forming a squamous cell carcinoma, since it is a slowly developing, since it is occurring chronic wounds, so there is destruction of the lymphatics around the scar, around the wound. So that is why lymphatic spread does not occur that easily in a Marjolin's ulcer. So how do you treat such lesions? So you will do wide local excision of the lesion, uh, along with you might have to, I mean, depending on how big the defect is, you might have to do a reconstruction. And burn scar carcinoma in head and neck can be treated with excision followed by radiotherapy. Okay. A 48-year-old sports photographer has noticed a small nodule over the upper lip from 4 months. The nodule is, this is what the nodule looks like. This is not over the upper lip, but it resembles the description given in the question. So it is pearly white in color. There is central necrosis, and if when you look at the lesion, there is umbilication as well as there is telangiectasia. So if you look at this image carefully, you might see some blood vessels which are forming over here. This is telangiectasia, right? So what is the diagnosis of this? So this is basal cell. The moment they tell you pearly white nodule or they tell you telangiectasia, automatically your answer should become basal cell carcinoma. These are clues which are hidden in a question of basal cell carcinoma. Next, they have also told you that it is over the upper lip. Basically, it is present on the face and the face is exposed to the sun, right? That is a risk factor. So the answer is basal cell carcinoma. Same way here you can see. So in this image, you can see there is central necrosis, right? This central necrosis is typically seen in basal cell carcinoma. So this is actually, this is a nodulocystic basal cystic carcinoma, nodulocystic type. This is an ulcerative type. And this is a morphic type. So what are the clinical features? So unlike squamous cell carcinoma, which has certain precursor lesions, basal cell carcinoma does not have any precursor skin lesions. The appearance varies. You might get nodules, you might get non-healing ulcers, and these tumors have a slow growth rate. Okay, some tumors, they are slow grow, that for all practical purposes they are considered to be benign. Now, nodular growth pattern is classical basal cell carcinoma. These are well defined, elevated lesions with a waxy appearance. If you recall the image that I had shown you earlier, it resembles just like that. As the lesion grows, opalescent nodules, pearly white nodules basically, these are typical of BCC. Then you might get central depression with umbilication or ulceration and rolled edges. So rolled edges is a classical sign of basal cell carcinoma. How do you remember this? So basal cell carcinoma is also called rodent ulcer, right? R for rodent and R for a rolled edge, right? Squamous cell carcinoma, on the other hand, will have an everted edge. So distinct blood vessels, that is telangiectasia, might be seen across the surface of the lesion and even along the edges. So most lesions, they might be pink or skin colored, but if there is ulceration or necrosis, they might have other colors such as brown or black. The other types are cystic type, Then you have also have a superficial type, and you have a morphic type. This morphic type is also called cicatricial basal cell carcinoma. This is of a white scarring growth pattern, right? And this morphic pattern, it is important because it is it is among the most locally invasive. So basal cell carcinoma, it invades by local invasion, it spreads by local invasion rather, but among this morphiform or the morphic type has a high local invasion uh, tendency. So rodent ulcer is also known as Jacobi ulcer. It is a neglected basal cell carcinoma that has formed an ulceration, and basically the same thing only. Yes, this is important. So what is this on-Grenz line? On-Grenz line, it connects basically, it connects the medial canthus of the eye to the angle of the mandible. So what the rule says it is that, so medial canthus of the eye to the angle of mandible. Whatever tumors are present above this line, they have a better prognosis than those which are present below the line. I'm sorry. So Ongren's line is from middle canthus to the angle of mandible. Below it is a better prognosis than above it. If it is below it, it is away from the eyes and the ears. If it is above it, it is closer to the eyes. Now let us look at some images. So in the last couple of years, there's a very high chance of them asking these image-based questions. So let us look at these questions. So what are the types of knots? So what is the difference between a granny knot and a square knot? Now, whenever this question is asked in the exam, the image will always have two shades of the same color. So here you have blue, here you have blue, right, in the first one. Here you have green. So if you will notice, in the blue one there is light blue and darker blue. In the second one there is light green and dark green. Now in a granny knot, if you look at the central portion, devote your attention to this part. So here the dark blue portion is above, but here the dark blue portion is below. So this is a granny knot. This knot is not that strong, right? That is, the crossings are opposite. If you devote your attention to the second image, that is the green image, here you will notice that in both the upper part as well as in the lower part, the dark green portion is on top. This is called a square knot. All right, a square knot is a secure knot when compared to a granny knot. So a square knot is also called a reef knot. Now you also have something called a surgeon's knot. So what is this surgeon's knot? So basically in a surgeon's knot, so in a square knot you have only one turn, right? But in a surgeon's knot you will have multiple turns. So you have, see, one turn, two turns, three turns. So when there are multiple turns in a knot, it is called a surgeon's knot, and the more the number of turns, the stronger the knot is. So let us look at some instruments which are commonly asked in your exam. So this is a Langenbeck retractor. Easy way of remembering it is L for long. So you can see this blade. This blade is quite long, right? That is why it is a Langenbeck. This is a Morris retractor. So Morris, it is short and broad. Langenbeck was long, thin. Deaver retractor is slight. It is a curved retractor basically. Then some other instrument. This is a Humbee's knife. A Humbee's knife is used to harvest a split skin graft. Let us identify some flaps. So, see, this is a Limburg flap, which is also a rhomboid flap. This is a Limburg. Okay, some okay, some problem with the pencil. Anyways, this is also called a Limburg or a rhomboid flap. In this, as you can see, so this is the defect. This, what looks like a rhomboid, there's a defect in this, and we want to cover this defect, right? Okay, before that, what is the difference between a graft and a flap? So, a skin graft is basically where you are just the difference between a graft and a flap. The basic difference is that in a graft, it does not have its own blood supply, right? So, it is dependent on wherever you place the graft, it is dependent on the recipient side for nutrition. Whereas in a flap, it carries its own blood supply. So, when a flap is carrying its own blood supply, that means it is based on certain blood vessel. So, you have to manipulate the skin in such a way that you can move the skin from one part to another, right? You have to pull it in various fashions. So, depending on how you pull it, since you can pull it in various fashions, depending on how you pull it, that will give the name to the flap. So, here in this rhomboid or Limburg flap, what you're doing is you are this part of the skin. So, this what I've put in red, and it is a rhomboid, this diamond shaped. This is the defect. Now, to cover the defect, I have to create one more. What is that? I have to create one more diamond shaped thing from the skin itself, which can then cover the defect, right? So, this is called a rhomboid flap. So, what I'll do is I'll make an incision along this, and I will change the position of this entire thing. That is why it is called a transposition flap, because I'm changing its position, right? So, the most common type of a transposition flap is a Limburg flap. So, the fundamental difference between a graft and a flap is a graft does not have its own blood supply, a flap has its blood supply. Now, then what is a free flap? In a free flap, you are removing it completely, and so maybe you're taking tissue from the leg and putting it in the thorax, but it is still a flap. So, why do you call it a flap? So, then that becomes a free flap. Free flap means when you are harvesting the flap, you are taking care to preserve its um, the blood vessels. So, when you place it on the recipient area, your job uh, is to perform anastomosis between the blood vessels of the donor flap and the recipient site. So, when you anastomosis, that means it is getting its blood supply. So, then it is a flap, but it is dependent. I mean, it is a flap, but it is free of its blood supply. That is why it is called a free flap. So, this is a transposition flap, also known as a rim. I mean, the most common example is a Limburg or a rhomboid flap, and this is most commonly used in the treatment of pilonidal sinus. Next is a rotation flap. So, in a rotation flap, you can see this is the defect. All right. So, the defect is triangular, and to cover this defect, they have to shift some part of the skin, that is it's like a semicircle. They have to rotate it and bring it. So, the manner in which you're bringing it, that gives its name, right? So, you have to rotate the skin. See, this is being rotated slightly. That is why it is called a rotation flap. So, free flap, like I already discussed, and then you have an advancement flap. So, see, this is the defect, right? And the movement that you're going to do to cover this defect is you are advancing this part of skin. That is why it is called an advancement flap. So, let us look at a few common instruments. So, this is a chemoport. So, what do you mean by a chemoport? A chemoport basically is, so port is, what do you mean by port? So, you have a sea port, air port, or you have port side during doing laparoscopic surgery. Port is basically a place from which you can either enter or exit, right? So, chemoport. So, chemoport is a portal, a site of entry via which you can give chemotherapy, right? That is why it is called a chemoport. So, for example, say if the patient if there is a tumor in the in CA breast after excision or before excision, if you want to give chemotherapy directly into the tumor, you will have to insert a chemoport. So, this is what a chemoport looks like. See, this is what the chemoport looks like, and this is what you can actually feel on the skin, right? So, the central soft portion is where you put the syringe and where you give the from which you can give the chemotherapy, right? So, as you give the chemotherapy, the drug, if it can travel in this tube like structure, and it gets delivered into the tumor site. So this that you can see over here is a chemo port. See here you can see the syringe, you can see the needle which is entering into the port. This is a chemo port. Next, this is a temperature probe. So, temperature probe actually, when I was looking for images on Google for a temperature probe, I got so many images. So, but what is the easiest way of identifying it? So, one end of this temperature probe, it resembles your old earphones, right? So, this is going to be inserted into a monitor, and the other end, if you see it, it has a slightly broad surface, and you can see these coils of wire depending on how long they want the temperature probe to be. So, this broad surface that you can see over here, basically this is placed on the skin, right? And that it monitors the, it detects the temperature and it displays it on the monitor. So, when you get an instrument like this, it is a temperature probe. Now, this complicated looking instrument is a Swan-Ganz catheter. Basically, in a Swan-Ganz catheter, um, it might resemble a Foley's in color and the texture and all that. You might get confused with the Foley's, but remember that it is a Swan-Ganz catheter. It looks way more complicated. It has many more. See, here you have 1, 2, 3, 4, 5. So it is way more complicated than a. No need to go into details of each tube and all that. That is not required for your level. It is just a very complicated looking catheter. So Swan-Ganz catheter is also a pulmonary artery catheter or a right heart catheter. Next, let us look at what is a gamma camera. So, gamma camera basically, so it is used in nuclear medicine. So supposing you inject something, you inject a fluorescent dye or maybe something of that, or maybe a in a technetium scintigraphy, you inject something and that gets concentrated in only particular areas, right? So in a gamma camera, you are injecting a substance which is it is fluorescent. I would not call it radioactive. It is fluorescent, and it gets accumulated in your area of interest. So it is accumulated in that particular area, and when you use a camera, that lights up on the screen. So when you image the entire body, so see here, you can see that this is the head. See, this is the let me zoom in. I will zoom out again. See, this is the head part. So here you can see this is bright white, right? See, 50 shades of grey in radiology. Anyways, so here you can see white. Chest also you can see this part is more white. See in the pelvis, in the vertebrae, this is more white, right? In the knees you can see it is more white over here, and even among this you can see certain dots, places where it is more white. So basically these are the places where it is getting concentrated, right? So you first inject a substance, okay, a fluorescent substance, and then you use an instrument to take an image of the body. So this is the image, this is the instrument that is used to take an image. That is why this is called a I mean, this is an image of a gamma camera. Next, you have a vena cava filter. So vena cava filters, remember I told you earlier in the day that when you want to prevent pulmonary embolism, but you're not, I'm sorry, earlier in the day I had, when we were discussing DVT, I had told you, that in some patients you are not able to anticoagulate the patient, right? So you are letting clots form, but you do not want them to embolize and go to the heart. So you temporarily place a filter in the inferior vena cava, right? So this is, so that is called an IVC filter. So this is what the IVC filter looks like. So this is the direction of blood flow, and see, this is the image of the IVC filter. So this will trap any emboli which is present in the blood. Then this is a pacemaker. So this is what a pacemaker looks like, right? It is not that big in size, relatively small in size. And if I go back to the previous image, so you can feel this metallic thing, you can feel it subcutaneously over here, right? And you can see these wires, it is going, it is giving, it is going into the right atrium, it is again going into the towards the apex. Basically, it is causing, it is performing the function of the SAN and the AVN, that is the pacemaker. Okay. What is the source of bleed in subdural hemorrhage? So now, I mean, I've also included a few questions which have been asked in the previous years. So let us discuss. So now there are, when you look at the types of intracranial hemorrhage, you will see that there is extradural hemorrhage, there is subdural hemorrhage, and there is subarachnoid hemorrhage. Now, how do you remember what is the source of bleed in all of these? Now, extradura, as the name suggests, so basically the brain, it has three meninges, right? So you have a dura outside to inside, from out to in, you have dura mater, arachnoid mater, and pia mater, right? These are the three layers of meninges of the brain. Now, in extradural hemorrhage, the bleeding is happening outside the dura. So it is present. How do I put it? So this is the skull, and here you have the brain with its meninges, right? It is not a very good diagram actually. Anyways, so you have the skull and you have the brain with its three meninges. Let me just change this image. Now, normally what happens is, Sanjay, just listen to me carefully, because then you don't need to remember this. So the dura mater, it is almost very closely opposed to the skull. Okay, so in fact, if you're doing dissection and if you want to remove the dura mater of the cranium, you have to put considerable effort to prise it apart, right? Now, so if it is so closely adherent to the inner table of the skull, that is the inner part of the skull bone, then if you want some blood to collect over there, and if you want that characteristic crescent, I mean the biconvex or the lens shaped hematoma, there has to be considerable force between the brain as well as the skull, right? So how do you get this shape? I mean, how do you get the blood to accumulate over there, which will cause so much shape? So if you are requiring so much strength to remove it, to prise it apart, obviously then the bleeding that is happening over there should also be under high pressure, right? From where does the high pressure come? It comes from arteries. Therefore, an extradural hematoma is from a middle meningeal artery. This is the most common source of bleeding for a extradural hemorrhage. Then what is this subdural hemorrhage? So subdural hemorrhage, as the name suggests, the bleeding is happening between the dura and the arachnoid matter, right? So this subdural hemorrhage, it can be of two types. It can be either acute or it can be chronic, right? Acute is because of trauma. Chronic also can be of trauma, but there's one more reason why chronic is happening. So let me explain that to you. Now, when it is happening because of trauma, there are two kinds of trauma, right? One is a high energy trauma, one is a low energy trauma. So, in high energy trauma, it is easy to imagine why a subdural hemorrhage would occur. But what about a low energy trauma? So, sometimes a patient, especially elderly patients, when they just fall in the bathroom, they hit their head on the floor or on the wall of the bathroom, and then they develop a subarachnoid hemorrhage. If the same injury were to happen in a young patient, then they would not get a subdural hematoma. So why is the old patient getting it? That is because um, in elderly patients, there is cerebral atrophy going on, right? So the brain which was used, so supposing say this is the skull, right? Earlier the brain was, the early image which I showed you, it was very close, right? If you remember the early, I don't want to draw it again, the early image where it was very close, but in elderly patients the brain becomes smaller, it shrinks in size. So there is cerebral atrophy going on. Now um, from the skull to the brain, there are certain veins which are going, right? Those are called bridging veins. So now when the brain was up till this part, that is it was close to it, then the bridging veins were very small, right? But what happens when there is cerebral atrophy, these same bridging veins, they become elongated, right? Because as the brain is shrinking, it is pulling the bridging vein along with it, so it becomes elongated, it becomes taut. So even a minor injury, it will cause rupture of this bridging vein, which will cause subdural hemorrhage. So in subdural hemorrhage, your source of bleeding would be a bridging vein. Easy to remember. Now, subarachnoid hemorrhage is nothing but your berry aneurysm, rupture of berry aneurysm or your stroke, that is your intracerebral hemorrhage. That is because of berry aneurysm or middle cerebral artery. So, bridging vein, the answer is subdural hematoma. Middle meningeal artery is extradural hematoma. Berry aneurysm and middle cerebral artery is your subarachnoid hematoma. So moving ahead, what is the grade of pressure sore shown in the image? Now, pressure sores are of 4 grades, right? Actually, in the recent years, there is when I gave my NEET PG, it had, actually, I was the first batch to give NEET PG, and NEET came for the first time. And I took quite a few attempts to clear my NEET PG, and by the time I got into my MS from after clearing my NEET PG, um, that year when I got my seat, it was the first year when there was a single exam held. And so what we noticed was the number of image-based questions that were being asked, it has kept increasing over the years. Since it is now a computer-based exam, you should obviously know all the commonly asked images. So let us look at the grades of pressure sore depending on the based on an image. Now there are 4 grades of a pressure sore. So you have grade 1, 2, 3, and 4. So in grade 1, there is non-blanchable erythema. So usually, supposing if you put pressure on your face for a long time, this part is red, right? But then that it disappears. But in bed sores, that is in grade 1 bed sores, the erythema which is present, it is constant. Secondly, wherever there is any redness, supposing if you place any pressure, so for example, say if there is a patient is going to has an abscess, so that area is very red, right? It is erythematous. When you next time you get such a patient, apply pressure on that with your digit. You will notice that wherever you are applying pressure, it blanches. But in grade 1 pressure sore, the erythema is such that it does not blanch. So there is non-blanchable erythema of intaction, that is grade 1. Then what is grade 2? So in grade 2, um, basically the skin is being lost, right? But it is a partial thickness skin loss. So this partial thickness skin loss, it can be either epidermis or it can be dermis or both. So basically, maybe only the epidermis is involved. That is also grade 2. Maybe the epidermis and only the papillary dermis is involved. That is also grade 2. This is like a split thickness skin graft, right? Then you have grade 3. Grade 3 is full thickness skin loss. Full thickness skin loss means your epidermis is gone, both the layers of dermis are gone. That is the papillary as well as the reticular area. Okay, and along with the skin, along with both the layers of the skin, that is dermis and epidermis, it is also going to affect the subcutaneous fat, but it does not go beyond the fascia. So, uh, non-blanchable erythema. All right, here um here it is partial thickness skin loss. So dermis not fully gone. This is how you remember it. Grade 3 is fascia not gone. So whatever is superficial to fascia will go. So what is superficial to fascia? You have both the layers of skin, you have the subcutaneous fat, and then you have fascia, right? Grade 4 is full thickness skin loss. That is, you have epidermis is gone, dermis is gone, subcutaneous fat is gone, and fascia is gone. So once fascia goes, so in this fascia is gone. So once fascia is gone, obviously it is going to affect the layers beneath it. So what is present beneath it? It might be muscle, it might be bone, right? So let us look at these images. So grade 1, you can see it is non-blanchable erythema. Grade 2, see this looks just like grade 2. This image, it looks just like what it would look if you were to harvest a skin graft. Now, but in grade 2, you can see non-blanchable erythema over here, and you can see skin loss over here. So if both are present, your grade will be the higher one. Now in grade 3, the fascia is intact, right? And in grade 4, you can see over here it is going even deeper. Which of the following is seen in kidney in hypovolemic shock? So in hypovolemic shock, what happens is there is lesser volume in the which is circulating in the vasculature. So if there is lesser volume, the role of the kidney is to preserve blood as much as possible. So the urine output should decrease. Now for the urine output to decrease, what will happen? There is there will be decreased, see in a shock state. Basically what happens is you are going to preserve blood flow to the essential organs, right? So to preserve blood flow to the essential organs, as a consequence the urine output decreases. So for the urine output to decrease, kidney is receiving blood via the afferent artery, receiving blood via the afferent, and it is coming out via the efferent. So what should happen? The blood flow coming to the kidney via the afferent artery should decrease, right? Now let us look at the options. So if afferent flow decreases, that means the GFR will also decrease. So which of the following is seen in kidney in hypovolemic shock? Increased GFR, obviously no. The GFR will decrease so that the urine output decreases. That is a compensatory mechanism. Increase in blood flow, no. Why will that happen? Afferent arterial constriction, yes, this will happen. So when the afferent arteries constrict, the flow decreases and the urine output also decreases. So this is a incorrect option. So moving ahead, parathyroid gland is implanted in which muscle? So a parathyroid gland, whenever you do total thyroidectomy and accidentally, supposing say if you have excised the parathyroid gland, um, and you identify that you've removed the parathyroid gland by accident, then what do you do? So you can still give the patient his gland back to him. So what you do is you know that this is the parathyroid gland. You remove all the excess fat, you chop it into fine pieces, that is you morcellate it, and then you implant it into any muscle. The muscle which is most commonly used is the brachioradialis for parathyroid autoimplantation. So moving ahead, what is the most common content of gallstones? So 80% of gallstones contain cholesterol. So types of gallstones in USA and Europe, 80% are cholesterol stones or mixed stones, that is they might contain some other component along with cholesterol. In Asia it is pigment stones which are most common. So what are the types of gallstones? First you have cholesterol stones, which consist almost entirely of cholesterol. These are usually solitary. That is why it is called cholesterol solitaire, like the diamond ring, the solitaire rings that you wear, it is called a cholesterol solitaire. Next, you have a mixed stone. In a mixed stone, cholesterol is the major component. So the other components, it can be calcium salts, bile acids, bile pigments, phospholipids, whatever. These are multiple and they are often faceted. Now, because cholesterol is a major component in gallstones, that is why whenever you do an X-ray, only 20% gallstones are radio opaque. That is, in 80% of the case, you will not be able to see gallstones, right? This is ulta from what is seen in the kidneys. In renal stones, you can actually see the stones because their calcium is the most common content. So pigment stones are black or brown stones which contain relatively lesser cholesterol, and patients who have cirrhosis of the liver, they have a higher incidence of pigment stones. So for example, black stones, they are associated with all the hemolytic anemias, so hereditary spherocytosis, sickle cell anemias. Brown stones on the other hand are related to bile stasis, bile infection present, they are associated with the presence of foreign bodies in the bile ducts such as stents or parasites such as Clonorchis sinensis and Ascaris lubricoides. So coming to the last question of today, this is a one-liner question, no explanation required, just you have to memorize it. Uvula vesicae is produced by which lobe of prostate? It is produced by the median lobe. So this uvula vesicae will be seen when you do a cystoscopy, right? It will not be seen on any image. So with this, we come to a conclusion of, we end our final dash discussion of for NEET PG. So I could not go into extensive detail of any topic. I have touched on all chapters superficially. I have tried to discuss one or two questions from each chapter, and I've only discussed it briefly. So if you want a more thorough and a more complete discussion, I would again encourage you to go please look at the app, where in the testing discussion series I have discussed all the topics extensively, and sir has also discussed the topics in good amount of detail. Thank you.